Good morning, everybody. I welcome you all next round. Before that, I invite Dr. Rahul Madam, President IMA, onto the stage. I request Dr. Shruti to bring your prayers now. Thank you, Dr. Shruti. Now, now we have a welcome dance by Ramakrishna and Do. Those who are in breakfast session, please do join, finish your breakfast and come forward. So, have a wonderful welcome dance by Ramakrishna and Do. Hello.
ఎందరో మహానుభావులు అందరికీ నమస్కారం. డాక్టర్ ప్రొఫెసర్ కన్నా మహోన్నతమైన ప్రొఫెసర్ ఏముంటుంది చెప్పండి. I welcome you all to this Orations and Mega Series. I invite our President, Dr. R. to preside over the program. has not only advanced medical science but also inspired humanity. Their journey is a guiding light for all of us. It reassures us that excellence is not just achieved through knowledge, but through empathy and purpose. Dear colleagues, in the rush of our daily duties, we sometimes forget the profound impact we have. A comforting word, a reassuring smile, or simply being present for a patient can mean more than any prescription. As it is often said, to cure sometimes, to relieve often, and to comfort always. Let this gathering rekindle that spark within us. The reason we choose this noble path, let it remind us that beyond science and skill, it is our humanity that truly heals. On behalf of the organizing committee, I extend my sincere and warm welcome to each one of you. May this oration inspire not just our minds, but also our hearts. Now today we have four orations: Dr. Karimnagar Orations by Dr. Ima Karimnagar, Dr. I. Orations by Dr. Dr. Orations by Dr. Dr. Orations by Dr. Special topic by Dr. Many more topics come from our local talented academicians. Let us listen to them. I'm sure it's scared to wonder experience. Lastly, there is Telangana folk dances and Orchestra ceremony. So sit back and relax, enjoy the session. Thank you, and once again welcome to this meaningful and prestigious occasion. Thank you.
Before starting, I would like to invite the gentleman to tell about the recognitions.
That is about the Lakshmana Oration. He is a serious official, respected teacher, dear friends, elders, and all gathered here. Today I invite you to walk with me into the life of a man who lost his mother at 4 years of age and became a mother of houses. A man who never accepted a single duty from a patient, yet treated a temple with his own hand. A man who speaks the rustic Telangana dialect with pride and love, and his granddaughter teases him about his age. I am speaking of none other than Dr. Lakshmana, physician, philosopher, devotee of Radha, and a living embodiment of Vaishnava compassion. The orphaned boy who became a leader, born on December 23, 1948, maternal hometown in Kurula, son of his mother,
Besides who of his address, deeper than the ocean, but realize the gravity that the Titanic is not further turning to surface. The great Vaishnava says, Namara says, those who have taken refuge in the Lord's feet see all beings as their own kin. Dr. Lakshminarayan lost his mother, but he found the Divine Mother in every patient who came to him. In the midnight now, in the dawn, emergency is a poor farmer who could not afford an injection. He has done 10th in Kurukula PUC SRM College, Karimnagar MBBS in 1971 at Aurangabad Government Medical College, MD in 1974. Father was Patwari in his village. Lakshminarayan sir worked as a family planning medical officer in PHC Ambaripet, Katlapur Mandal. In those days, PHC has not achieved under Medpalli SHPO curriculum KFC Warangal 1976. After teaching experience again, transferred to district headquarters Karimnagar. In 1990, registered to government job and joined private practice. In last 35 years, he has been practicing in his own nursing home, serious patients as a critical care center. He did not close his hospital in epidemic COVID. With his son, Dr. Harishankar, it was not a COVID center, yet he served the patient with compassion. He got married to Srimati Andalu, his uncle's daughter, in 1973. He is having Dr. Sumati, wife of Dr. Gattu Ravichandar, is a professor of Manas Sarovar Kailash Parikrama. In 2007, Damodar Kund also he took 1 month during Parikrama. He fell down from the back of the horse, broken 9 ribs, reached home safely by God's grace. He believes in God. He used to see patients free of cost who writes Ramakoti through Sanatani. He is a follower of Ramanuja's Vishishtasvaita and visited 108 Divyadeshas and Chardham several times and did services to villagers. During his traveling, hospital was run by Dr. Harishankar or Dr. Vidyasagar. Never closed his hospital for a single day past 35 years. He constructed a Sita Ramachandra Swami temple in 2011 by donating and with the help of government and villagers. Dulur village, Katlapur Mandal, Jagityal. Now during Vaishakha Shuddha Panchami, 22nd April, you are all invited from Brahmotsava that is being conducted by him grandly for last 15 years. Such a great doctor who started his practice with ₹20 and used to admit critical patients without ICU, given day and night service, a great inspiration. That is why the all alone in treating patients in those days, no diagnostic tools, no critical care centers. He never knew when to sleep, when to eat. Particularly skilled in cardiac and neurological cases. In those days, even if patient dies, they used to accept. He says our dharma is to do our best, rest leave it on God. As it is written in surrender to the Lord, accepts both joy and sorrow as a divine gift. One of the most touching aspects of Sir's life is his deep love for Telangana dialect, the love for his mother tongue. He says compassion is the root of all dharma. As great Indian philosopher Swami Vivekananda proclaimed, he who sees Shiva in the poor, in the weak, in the diseased, he is the Vaishnava. The philosopher Socrates said, I am the wisest man alive, for I know one thing, that I know nothing. Dr. Lakshminarayan sir saw Lord in all beings, serving their Lord is the only worship. He treated his patients as a name in themselves, not a case number, not a billing code, but a living soul. Let us stand, if only for a moment, in gratitude for such a life, and let us carry forward this quiet revolution of kindness. Jai Shri Ram. Thank you. Dr. Shyam Sundar sir, Dr. Sri Lanka Reddy madam. Please come on to the dais. Family of Lakshmi Narayan sir, present, please come on to the dais. So, in those days when critical care center was not there, sir used to treat emergency cases. Not there, fully equipped with diagnostic tools. In those days, only clinical things which Lakshmi Narayan sir used to do the practice of radiology and cardiology. Srimati Mamata madam. Now over to Mahesh for the introduction of Vijay Kumar sir.
Good morning, everybody. Here is the citation in honor of Dr. Sri. It is a moment of immense pride and privilege to introduce a physician who is not just a doctor by profession, but a healer by heart, a teacher by profession, and a human being by remarkable depth. Born on 29th August 1962 in Lakshmi Narayan district, his journey is a story of brilliance, discipline, and unwavering commitment. From his school days at Lakshmi, where he consistently stood first, excellence was not his achievement, it was a habit. His continued academic journey at Andhra Layala College, Vijayawada, attending the prestigious state merit scholarship, and he went on to complete his MBBS from KMC Varangal and MD in General Medicine from Usmania Medical College. His merit and generation were further proven when he was selected for UPSC Combined Medical Services for 4 consecutive years, a rare and remarkable feat. Since 1991, he has been the pillar of secretary serving tirelessly at Modern Nursing Home and others as a consultant and assistant critical care unit. For decades, he has been entrusted names of complex patients and doctors who heals not just with medicine but with empathy. He is an exceptional academician. He shaped generations of young doctors as a professor of medicine at Case, examined for Chermana Medical College, and dedicated postgraduate guide for over 15 years. His leadership in professional bodies is equally inspiring, a dynamic force in IMA, API, and RSSDI. He served as Vice President of API Telangana and API Local Chairman. As the Alliance Secretary, he successfully conducted major API and RSSDI state conferences in Karimnagar, bringing academic excellence to our doorstep. A respected national speaker, his voice has resonated from Karimnagar to Patna and beyond. But what truly defines him is heart for service. Through numerous free medical camps under IPA, API, and Ghana, he has reached the unreached, serving the poor and needy with dedication and humanity. Behind this successful man is a strong and supportive family, his better half, Dr. Mamata, Professor at Serabi Medical College, his pillar of strength. He blessed me 2 accomplished daughters, Dr. Madhavi, pediatric consultant, and Dr. Priyanka, pursuing MD anesthesia. A family that truly reflects excellence in medicine. A man of intellect and sensitivity, he finds joy in literature, music, and cinema. His book, A Letter from Doctors, was then met with overwhelming appreciation, with all copies sold out within just 15 days. A testament to his thoughtful expression and passion with people. He fondly remembers his father, a leading advocate whose legacy continues to guide him, and his mother encourages women who sacrifice their career to shape his future. Values the preference in every aspect of his life. he proudly says, I would choose to be a doctor again, not once, but for next 10 generations. Because of him, medicine is not just a career, it's a calling, commitment, and source of deep inner fulfillment and serving humanity. Ima Karimnagar Awards Committee and Executive Committee unanimously decided to honor you with the Lakshmi Orations Award for 2026. Thank you, sir. Please accept. Now, I would like to invite Dr. Ima Karimnagar to deliver his oration.
Good morning, everybody. Thank you very much, Academy, Teacher, Dr. Naresh, selecting me as orator. We are extremely thankful to them for choosing me as a speaker today. So, when I was trying to choose the topic, Dr. Raghunaman sir has advised me to take up this topic. But Lakshmana sir used to treat a lot of patients before MRI, before CT scan was available in Karimnagar, and he is very popularly known as a neurophysician here. So I thought of explaining everything. What is that we miss in neurology? What is that we miss in strokes? For every common practitioner, and this is meant for all the ordinary IMA members, not for super specialists. So, first slide please. Let me introduce the definition. This definition is coined in 1940 by World Health Organization. What it says is, the onset should be abrupt and acute, and there should not be any other cause other than vascular cause. And the third is, it should be more than 24 hours. So there is you need some clarity about 24 hours. Now we are able to diagnose within minutes. So lasting for 24 hours is no more valid. Before 3 hours we should start thrombolysis. Within 6 hours we should start mechanical thrombectomy. So for a small stroke, a patient may improve within 6 hours. So lasting for 24 hours is no longer valid. Next slide please. So the strokes can be ischemic or hemorrhagic. Ischemic is very, very common. It's around 84%. Next slide please. Atherosclerosis is quite common, causing thrombotic strokes, and they are very common. As I said, it is 80%. So what is that we miss when we are diagnosing a patient? I have seen a patient who was admitted with accidental hypertension. His BP was 240 by 140. And the next day, he was complaining that his right side being is not as normal as the left side, doubly. So, do we have to consider it or not? Please consider, and that is the topmost priority, because even before CT scan, even before MRI, the patient's symptom is more valuable, and for diagnosis and treatment of stroke, the it's not mandatory to see infarct in the imaging process. So even if there is no infarct, we can start treatment like thrombolysis can be given for those patients. So a patient with small diminished vision, a patient with small diplopia, a patient with small confusion, a patient with small unsteady gait, these are all things we should consider. So there are some topics in various conferences where people say that one topic was the mistakes I have committed in my clinical practice. So most of the times we miss such things in the early stage and later they come with all the disabilities and we will not be able to treat them. So be cautious, listen to the patient. Next slide please. So this is very important concept. What is ischemic penumbra? So when there is ischemia, the core, the central part of the brain which gets infarcted will lose the blood, and peripheral part is penumbra, that is salvageable part of the brain. We should assess this, and if there is any salvageable part of the brain, you should treat it early so that part gets the blood and the hyperperfused area becomes fully perfused and the function gets back away. So this is most important in treating and for all revascularization therapies like thrombolysis and thrombectomies. Next slide please. So there is a pattern in all cerebrovascular accidents. It all depends on the vascular supply. So for each vessel, when there is a vessel is affected, there is a pattern, and for migraine and Cox palsy, it will be global or generalized changes will be there in the environment. For a vascular pattern, it will be localized to the supply and to the blood vessel involved. Next please. So the strokes are classified as large strokes and small strokes. Large vessel stroke within arterial circulation, large vessel stroke within pulmonary circulation, and small vessel disease of either vascular bed. So what is the importance of saying that large vascular bed? Large vascular occlusion is the indication for thrombectomy. So even in small vessels, when there is a lacunar infarct, we need thrombolysis and the results are good. It all depends on the disability the patient has. Next please. Next. Posterior circulation strokes are very commonly missed strokes. You should concentrate on the symptoms. Most of the strokes are diagnosed in bedside before any investigation. Where all the symptoms of posterior circulation stroke must be assessed. They are known as 5 Ds: diplopia, dysarthria, dysmetria, diplopia, and diminished vision. And 2 Ns: nystagmus and nausea. When there are such symptoms, you should consider posterior circulation stroke. Basilar artery, when the complete basilar artery is occluded, patient will have quadriplegia. He is in locked-in syndrome, and he is conscious. And for such patient, even the vessel is small, you should do thrombectomy because the area it supplies is vast and the parts it supplies are very vital for the survival of the patient. So here the thrombectomy role is for the survival of the patient, not for the disability improvement. So you should consider thrombectomy for, even though it is not a large vascular occlusion, you should consider for basilar artery occlusion. First, whenever the patient comes to emergency department, you should stabilize the patient and you should see what is the time. side lost our well. Since how long he is sick? Is it during the night he had stroke or after waking up? At what time here? The time is very, very, very crucial. So here you see the slide. MRI and clinical examination. Clinical examination is far, far better than MRI. So clinical examination is very vital. I am stressing this because the Lakshmana sir is on one side and Dr. Sanjay and his team are on the other side. So Dr. Sanjay is stressing more on it. I agree that he is stressing on clinical examination also. So he is more based on investigations. So clinical examination as well as investigations are very, very vital in taking strokes. So this is for a layman who sits in the ambulance. You should teach him that the accelerating fast is very important. Any facial weakness, any arm weakness, any speech difficulty, immediately call. So this is extended for be fast for clinicians. B is balance, E is eyesight. For all the patients with stroke, CT scan is the initial investigation of choice. Because for starting endovascular therapies or thrombolysis, you should know whether there is hemorrhage or not. That is the only thing you should do. CT scan is a faster mode, and before MRI takes a lot of time. So CT scan is must for all the patients. Once you rule out hemorrhage, you should start thrombolysis. Time loss cannot be gained. So even few minutes are important, few seconds are important. The ischemia progresses very fast in brain than in heart. There is no glycogen in the brain, so the worsening is very, very fast. So you should be very careful and be ready to treat vascular accidents, cerebrovascular accidents immediately. What are the treatment objectives? You should assess how much brain is still damaged reversibly, and even irreversible damage, that is an infarct, you cannot do anything. So the brain that is still has a reversible damage can be treated with all our procedures like thrombosis and endovascular treatment. So you should assess that. You should prevent complications like septic edema, aspiration pneumonia, and DVTs, and you should rehabilitate immediately. There is 30% improvement if a person is properly rehabilitated with all the new modalities. Reduce the risk of recurrence with aspirin and statins. So BP control is important. You should allow 220 by 120 if you are not planning thrombolysis. After thrombolysis, it should be around 180 by 105. Fever should not be accepted under any circumstances. See this slide. Average stroke patient uses approximately 1.2 million neurons every 1 minute. So if you allow him to stay, you don't treat him for 10 hours, you will be losing 36 years of his brain age. 36, not a simple thing. When do you do CT population? First, if the CT scan is normal and it shows no hemorrhage, you should give thrombolysis. If there is no improvement in thrombolysis, you should consider CT angio and assess if there is any large vessel involvement. CT perfusion is to see whether still there is any salvageable brain tissue. This is about thrombolysis. So thrombolysis has got its own limitations. With thrombolysis, you will not be able to clear all the clots in large vessel occlusions. So when you suspect large vessel occlusion, you should immediately take up for CT angio and plan for thrombectomy immediately. Do you know who is doing thrombectomy in Karimnagar? Are there any centers doing thrombectomy? I am very proud to declare that Sunan Chennai Medical College is doing that, and he is doing all the, he is helping Dr. Sanjay do all the procedures, and he is encouraging. Give a big hand to Dr. Sunan. So unless someone supports who doesn't care about financial or money aspects is there, will not be able to do such aggressive procedures. With thrombolysis and even after thrombectomy also, patient can develop infarct can go into hemorrhagic transformation. If the infarct is large, if the patient reports to the hospital late, the hemorrhagic transformation is higher. So again, thrombolysis, what next? As I told, it is thrombectomy. Thrombectomy, you should detect whether there is large vessel occlusion by doing CT angio. Within 6 hours, if the patient reports, if you do thrombolysis, if you see that there is large vessel occlusion, you should go to thrombectomy immediately. But there are some studies which say that thrombectomy is also effective for 16 hours and for 24 hours also. In such patients, you should do perfusion studies. God trial. There is a clinical mismatch. So the CT perfusion study shows that there is a lot of salivary in the brain, but the symptoms are low. For such patients, even after 24 hours, we can do thrombectomy. This is the 3 study. So here the mismatch is in the CT study. The imaging mismatch is there. So the core infarct area is small and the penumbra is more. So because the salivary brain tissue is there, you have to do for 16 hours you can do thrombectomy. As I told, large vessel occlusion is very, very important before starting thrombectomy. For posterior circulation strokes and for vascular artery syndrome, even though it is a small vessel, you have to go for thrombectomy because the area it supplies are quite vital and it supplies to a larger extent. So let us talk about some stroke mimics. I have done few mistakes in my earlier practice. Then there used to be no immediate assessment, immediate investigation for doing random blood sugar. Now we have got GRPS readily available. In those years, in 1993, 94, we used to send to the lab and they used to report after 2 or 3 hours. So ruling out hypoglycemia is extremely important. It is as important as measuring the airways, treating hypertension, treating diabetes. So knowing whether the patient is hypoglycemic is very important, and because hypoglycemia can cause acute symptoms. There will be focal deficit will be there will be unconsciousness, and even MRI may show some changes. So ruling out hypoglycemia is very important. Please do that before starting any aggressive treatment. So there are some limits. There are some chameleons. Chameleons are real strokes, but we miss them. So simple symptoms like visual loss, diplopia, homonymous hemianopia, these are all things which we miss, and if we miss, they will have some strokes in the latter time. This is about hypoglycemia. Even alcoholics may have hypoglycemia without diabetes. What? So other limits are brain tumors, migraine, and horse palsy. So even when the whole thing, even the whole atmosphere is very, very silent, you will be able to listen to some sounds. Be careful, apply and listen. You will be able to listen to some sounds. There it is in the ocular signs, so cortical motor signs. Once you see them, treat them as strokes. Gaze palsy not only suggests stroke, it also suggests that there is large vessel occlusion. Neglect, aphasia, these are also suggestions of large vessel occlusions. Now I will explain these things in detail once again. So this is a multiple choice question. The patient presents with acute diplopia and ataxia. CT brain is normal. Best approach. Rule of stroke. Discharge will follow. Consider postal stroke and proceed with approach evaluation. Diagnose, proceed practice. So here there is acute diplopia and there is ataxia. Even if CT scan is normal, you should consider it as stroke. Postal circulation stroke may not appear in CT scan immediately. Once there is no hemorrhage, you can start thrombolysis for such patients. So the answer is C. This is another MCQ. The patient presents within 3 hours with isolated severe dysarthria, affecting communication. CT normal. What next? No treatment, antiplatelets, thrombolysis, wait for MRI. So the answer is C once again. Should immediately start thrombolysis. So if you want to rule out any commercial considerations, you should have a stroke board. Yesterday I was discussing with Dr. Sanjay. As there are tumor boards, why don't you have stroke boards where a neurosurgeon, neurophysician, critical care physician and rehabilitation specialist and your dietitian sits together and decides what treatment should a patient get. I think this is very important, and I hope that Sanjay will set up a team like that in future. Hemorrhagic stroke is altogether different. There is thrombolysis and thrombectomy will not work. The only one indication where intraventricular thrombolytics can be given if the clots are very big, you can give intraventricular thrombolytics for hemorrhagic stroke also, very rare indication. So primary and secondary prevention. Most of the hypertension patients are associated with diabetes, and most of the coronary artery disease patients are associated with cerebrovascular accidents. So here, friends, friendships, and the true cure are very, very important. Can you name the best friends in the world till today? Who are the best friends? K.A. Balshan. K.A. Bal will come. Best friends in the world. World. Why? The best friends in the world are Arjuna and Krishna. Those are relatives, they're the best friends. When there is nothing for Arjuna and Dharma, they are in some other place, they have got no kingdom, they are only 5 people. Arjuna goes to them and helps them. He never hesitates to help them, even at the cost of his own interest. When he was fighting with Bhishma, he runs down and tries to kill Bhishma. And on the other side, you have Karna and Bhishma. They are very principled and they stick to their words. Krishna is not like that. We should have friends like Krishna. And even in the music world, Muhammad Rafi, once he gets a call from Lakshmikant Karala and they record 4 songs and give him some money and send him away. Their assistant asked why you are asking to sing the songs, because there are no songs right now for Rafi. They say that when we are nothing, Rafi helped us, and now he is in a depressed mood, and because of the movie, Kishore is not able to have any songs. We should help him right now. Such friends are very vital for our life. I thank my all friends like Dr. Rajendra, Dr. Rakeya, Dr. Shah, Dr. Ramachari, Dr. Ram Reddy, and all my friends. Here, I also want to remember, so whenever there is a great function, whenever there is a big movement is there, we used to see Dr. Bhumreddy sir, Dr. Ravindra Rao sir, Dr. Sara Rao sir, Dr. Surya Prakash at the function in a very happy mood. We are all missing you, sir. We are all missing you. And even I miss my close friends, Dr. Prabhakar Reddy and Dr. Ramesh, who always wish my welfare, who always used to love me very much. So finally, again, I will just 2 seconds and tell them clinical whispers we should not forget. So this is fast, sudden facial asymmetry, change in the watch, unilateral limb heaviness, unexplained dizziness, acute onset confusion. Don't leave the patient. Get the best opinion. Never hesitate to send a patient to a neurophysician. Neuroradiologist and neurophysician are better than us in early diagnosis of strokes. Tiny signs in the history. Last known well is very important for giving thrombolytic therapy and for our endovascular treatment. TIAs are very important. In a setup, in a clinical setting where a patient is hypertensive, diabetic, with past history of TIAs and atrial fibrillation, you should consider stroke very much. Bedside diagnostic groups. Pronated always suggests that there is early cerebral weakness and there is some problem. Gaze deviation, as I told, large vessel occlusion is there. Visual neglect and aphasia suggests large vessel occlusion over 1 second. Medical investigations, first do CT scan, next CT angio, next CT cohesion, and always rule out hypoglycemia. These are all time-sensitive treatments. TPA within 4.5 hours, mechanical thrombectomy up to 24 hours as per Dawn study, strict BP control, avoid hypoxia. So whenever a patient with ischemic stroke gets worsened, think of hemorrhagic transformation. Early rehabilitation, difficulty in swallowing must be addressed. Speech therapy is very difficult. So, for a clinician, updating every day is very important. Most of you must have read the final diagnosis novel. There the pathologist keeps on praying God, baby take the breath, baby take the breath. You have seen only the worst part of the medicine, you have seen only the negligent part of medicine. Baby, please breathe. Come on to the life. We have shown you our negligence. There is a lot in the world. There is a lot of good things in the world. Please breathe, live. But the baby dies because of RH incompatibility. So we should update ourselves every day and we are not just diagnosing, we are treating the patient's life who is crucial in his family, in the society, and a sick patient, leaving a sick patient and handing over to the society is very, very costly mistake. Diagnosis is just not a word. It decides a life. So, stroke is rarely hidden, only overlooked. Take care to treat strokes and be careful to address each symptom and sign because it is a clinical diagnosis. Thank you very much for all your patient care.
Thank you, Vijay. First of all, let me congratulate Dr. Shailaja, the visionary and hard-working president of Ima Karimnagar, the dynamic secretary, cool and dynamic secretary Dr. Mahesh, intelligent and one more hard worker, president of Ima, and other members of the team Ima Karimnagar for conducting this beautiful and excellent academic program in the extraordinary ambience and extraordinary enrollment of delegates crossing more than 650 or 680. So, big claps for the team Ima Karimnagar for this excellent academic bonanza today with us. 40-50 ఏళ్ల సంవత్సరాలకు పూర్వం పాత కరీంనగర్ జిల్లాకే కాకుండా నార్త్ తెలంగాణలో మూల సామాన్య ప్రజానీకానికి ఆ శ్రీమన్నారాయణుని తర్వాత ఎవరైనా దేవుడు అంటే మన లక్ష్మీనారాయణ స్వామి గారు. ఎందుకు అంటే నాకు గుర్తున్నంత వరకు కరీంనగర్ పట్టణంలో మొట్టమొదటి క్రిటికల్ ఎమర్జెన్సీ సర్వీసెస్ మొదలుపెట్టిందే ఆయన. కాబట్టి వారు ఎప్పటికీ అభినందనీయులు. మాట కొంచెం కఠినం కానీ మనసు వెన్న. అటువంటి మహోన్నతమైన వ్యక్తి ఆపరేషన్కు ఈరోజు నేను ఒక భాగస్వామి అయినందుకు భాగ్యంగా భావిస్తూ, ఇక స్పీకర్ విషయానికి వస్తే మాకు అత్యంత ఆప్తమిత్రుడు డాక్టర్ విజయమోహన్ రెడ్డి ఈజ్ ద మ్యాన్ విత్ మెచ్యూర్ థాట్స్, వండర్ఫుల్ ఐడియాస్, enriched knowledge and oceanic wisdom. I hope these words are less for him and not taking much of his time. He presented the talk with a lucid clarity and clearance. So, for his future endeavors, I wish him all the best, and I am very proud to be here today to change his talk and Lakshmana position. Thank you very much. We are now to Dr. Sridhar. Few words.
నమస్కారం. లక్ష్మీనారాయణ సార్ గురించి చెప్పాల్సిన అవసరం లేదు. కరీంనగర్ పాత జిల్లా, కొత్త జిల్లా అందరికీ ఎన్నో సంవత్సరాలుగా, 30-40 సంవత్సరాలుగా పరిచయమైన వ్యక్తి. ఆ సార్ పర్సనల్గా కూడా నాకు చాలా బాగా తెలుసు. ఆ సార్ మాట్లాడితే సంవత్సరాలుగా గారు చెప్పినట్టే ఆ మాట కఠినంగా ఉంటుంది కావచ్చు, కానీ 100% అందులో నిజం ఉంటుంది. కాబట్టి ఈరోజు మన లక్ష్మీనారాయణ సార్ గారి ఒరేషన్ మన కరీంనగర్ ప్రాక్టీషనర్ డాక్టర్ విజయమోహన్ రెడ్డి గారు ద్వారా ప్రజెంట్ చేయించడం చాలా సంతోషంగా ఉన్నది. డాక్టర్ విజయమోహన్ రెడ్డి గారు ఆ టాపిక్ ఆ పూర్తి న్యాయం చేకూర్చిండ్రు. ఎవరికైనా ఏమైనా ప్రశ్నలు ఉంటే వారిని అడగవచ్చు. థ్యాంక్ యూ. నమస్కారం.
ప్రశ్నలు అడగవద్దు ఓరేషన్ కాబట్టి సందేహాలన్నీ నివృత్తమైనట్టుగా భావించి కంటిన్యూ
Thank you for the kind words. It is an honor to know about Lakshminarayan sir and Vijay Mohan sir. Sir, after your lecture, these are no longer clinical whispers, they are shoutouts for stone. Thank you, sir, by Lakshminarayan sir. I request Dr. Shyam sir, Dr. Srilata ma'am to receive small tokens of appreciation.
The next topic. Our Captain Madam will introduce Dr. Karimnagar Orations.
Now, tribute to the one and only Ima Karimnagar, late Dr. Reddy Garu. With profound respect and admiration, we pay tribute to the legendary Dr. Reddy Garu, fondly revered as the Bhishma Pitamaha of IMA Karimnagar. Born on 9th July 1936 in the Jangalpalli village, he pursued his medical education in the Usmania Medical College, Hyderabad, graduating in 1960, and went on to complete his MS in General Surgery from All India Institute of Medical Sciences in 1963. Earning a gold medal from distinguished Prime Minister Jawaharlal Nehru. He served as assistant professor at Usmania Medical College and Kakatiya Medical College, and later at District Headquarters Hospital, Karnataka. With compassion and dedication, he treated patients with a human touch. Before establishing his own hospital in 1976, marking the beginning of modern private healthcare in Karimnagar. He was also the pioneer in initiating blood transfusion services in private hospitals in the region. A visionary and institution builder, he was instrumental in establishing the IMA Karimnagar building at Payday. Key role in mobilizing funds from Susmita Cancer Center and North Telangana. He was also one of the founders of this prestigious institution. His association extended beyond medicine into social and cultural spheres through Lions Club, Rotary Club and literary organization. He was a founder member of Raja Bahadur Venkatram Reddy Vidya Parishad. Dr. Reddy Garu held several prestigious positions, including IMA Secretary Warangal, IMA President Karimnagar, IMA Andhra State President, and Vice President national level. He was instrumental in the numerous IMA branches across Andhra Pradesh and Telangana. A philanthropist at heart, he conducted several IMA state and regional academic conferences and was the founder president of APNA. His silent service to four students' contributions to Reddy Hospital and BE College and support to the underprivileged came to life profoundly after his passing. A mentor par excellence in guidance to doctors, seniors and juniors alike is unmatched. His presence was considered auspicious, and many hospitals in Karimnagar were inaugurated by his blessed hand. A gifted speaker, every address of his carried wisdom, clarity and inspiration. True to his faith, he would conclude with a smile, reminding everyone the laughter is the best medicine. Even in sports, he remained active, DX champion and participant in freedom movement and Telangana agitation. He left us last year, late Reddy Garu, wife Srimati Sarojini Devi, 3 daughters and one son, Dr. Suryanarayan Reddy and Mrs. Dr. Srimati Rama Devi, well known to all of us. One daughter stays in Karimnagar, Dr. Sudha, well known to us. One daughter stays in Hyderabad and the other daughter stays in USA, Sujata and Sunanda. Is the legacy by instituting the prestigious Dr. Reddy IMA Karimnagar Orations, enshrined in the Constitution and bylaws. Dr. Reddy's life is an inspiration of service, sacrifice, leadership and humanity. His legacy will continue to guide generations of doctors and the society is so selflessly served. Some lives are unforgettable as his journey is inspiration. Let us welcome Dr. Madhusudan, who is going to give oration on Dr. Late Boom Reddy sir. His oration is being delivered by Dr. Madhusudan, liver transplant surgeon, my classmate, pioneer friend, KMC 1988 batch. Please come on to the dais and let us see a small video of Dr. Boom Reddy sir. Please play video. Dr. Boom Reddy sir.
I would like to invite my persons for this session, Dr. G. Harikishan sir, Dr. Ima Karimnagar on the stage, please. Please play the song.
Karimnagar Vishwa Pitama.
Video.
అత్యంత గౌరవపూర్వకంగా మరియు ఆరాధనకు ఐఎంఏ కరీంనగర్ భీష్మ పితామహగా ఆదరించబడింది. ఈ భూమికి గారికి మేము ఘన నివసిస్తాం. వారి జీవిత ప్రస్థానం 9 జూలై 1936 జనకంపల్లి ఉస్మానియా మెడికల్ కాలేజీలో వైద్య విద్యలో ప్రవేశించి 1900 కరీంనగర్ జిల్లా ప్రధాన ఆసుపత్రిలో అసిస్టెంట్ ప్రొఫెసర్గా సేవలు అందించారు. మానవీయ కోణంలో రోగులకు చికిత్స చేస్తూ 1976లో సొంత ఆసుపత్రిని స్థాపించారు. ఇది కరీంనగర్లో ఆధునిక ప్రైవేట్ వైద్య రంగానికి నాంది పలికింది. ప్రాంతంలో నిధుల సేకరణలో ఆయన భూమికలు పోషించారు. సామాజిక మరియు సాంస్కృతిక సేవ వైద్యకారిని పరికల్పాలు రోటరీ మరియు వివిధ సాహిత్య ఐఎంఏ సెక్రటరీ వరంగల్, ఐఎంఏ ప్రెసిడెంట్ కరీంనగర్, ఐఎంఏ ఆంధ్రప్రదేశ్ రాష్ట్ర మరియు అధ్యక్షుడిగా అనేక ప్రతిష్టాత్మక పదవుల్ని నిర్వహించారు. ఉమ్మడి ఆంధ్రప్రదేశ్ మరియు తెలంగాణ వ్యాప్తంగా అనేక ఐఎంఏ ప్రారంభోత్సవాలు వీరు పోషించారు. ప్రభుత్వం మరియు నిరుపేద విద్యార్థులకు సాయం చేయడం, రెడ్డి హాస్టల్ మరియు బీఈడీ కాలేజీలకు అందించిన విరాళాలు వీరి మరణానంతరం వెలుగులోకి వచ్చాయి. సీనియర్ జూనియర్ డాక్టర్లందరికీ వీరు కరీంనగర్లోని అనేక ఆసుపత్రులు వీరి శుభహస్తాలను వీరి ప్రసంగ చాతుర్యం వీరు అద్భుతమైన వక్త. ప్రతి ప్రసంగం ఎంతో జ్ఞానంతో స్పష్టతతో మరియు స్ఫూర్తిదాయకంగా ఉంటుంది. లాఫ్టర్ అని చిరునవ్వుతో గుర్తు చేసేవారు. క్రీడలు మరియు పోరాట స్ఫూర్తి. క్రీడల్లో చురుగ్గాను విలియమ్స్ ఛాంపియన్గా నిలిచారు. స్వాతంత్ర ఉద్యమంలో మరియు తెలంగాణ ఉద్యమంలో కూడా మీరు పంచుకున్నారు. గౌరవ వందన. మీ వారసత్వాన్ని గౌరవిస్తూ ఐఎంఏ సేవ, త్యాగం, నాయకత్వం మరియు మానవత్వానికి నిలువెత్తు నిదర్శనం. డాక్టర్ భూమిరెడ్డి గారి జీవితం, సేవ, త్యాగం, నాయకత్వం, మానవత్వానికి నిలువెత్తు నిదర్శనం. వీరి స్ఫూర్తి భావితరాల వైద్యులకు మరియు సమాజానికి ఎప్పుడు మార్గదర్శకంగా ఉంటుంది. ఘన నివాళులతో ఐఎంఈ కరీంనగర్.
Thank you, Ananda. Now I will. From It's a moment of immense pride and privilege to introduce an outstanding surgeon, an inspiring teacher, and a pioneer in the field of surgical gastroenterology, Dr. C.H. Masudar. He is a distinguished member of several prestigious national and international professional bodies, including Indian Association of Surgical Gastroenterology, the Associations of Surgeons of India, and the Asia Pacific Hepatopancreatitis Association. He is also former member of MRC and fellow Royal College of Surgeons of Edinburgh. It's an honor that reflects his global standing and surgical excellence. With over 25 years of rich teaching experience, he currently serves as professor and head of department surgical gastroenterology and liver transplantation at Osmania General Hospital in Hyderabad. A visionary academician, Dr. Madhusudan initiated MCH program in surgical gastroenterology in Osmania, shaping the future of countless young surgeons. His commitment to the service is truly remarkable. He was truly instrumental in starting liver, pancreas, and intestinal transplantation services at Osmania General Hospital, ensuring access to advanced care for underprivileged patients. His academic journey is equally impressive, having served as assistant professor, senior assistant professor, associate professor, and now professor, to maintain generations with dedication and excellence. His training at the prestigious All India Institute of Medical Sciences, New Delhi, further strengthened his expertise in GI surgery and transplantation. Beyond clinical and academic excellence, he has also contributed as an MCI assessor, helping maintain high standards in medical education across institutions. Sir, your relentless dedication, surgical brilliance, and commitment to the teaching have made a profound impact on the medical community. Ima Karimnagar is feeling proud to have a member like you here, sir. Our committee and executive committee of Ima Karimnagar unanimously decided to honor you with prestigious oration of Dr. Bhumreddy sir for year 2026. Thank you, sir. Now I would like to request Dr. C.H. Masudar to deliver his lecture.
Good morning. Respected senior faculty, persons, thankful to the IIM President and Secretary and IIM teachers for giving me this opportunity. More honor giving a lecture at a prestigious senior president. So I had an interaction with Kumari almost 10 years back when I finished my MCS of National Probably from Army and Medical Center. Sir was very active in AS activities. So I used to give a hepatic dissection topic almost many places. So once he approached me, he said that I am also from Army and Medical Center. I did MS long back. So you started liver resections because during their time, liver resection was a really challenging surgery. So sir was asking, why can't you give one lecture at Karimnagar where rural surgeons will get a confidence on especially liver trauma cases. So with that time, Dr. Ravindra sir was also there. So with these two legends, I given a one lecture on hepatic trauma and liver resection. So this was my association with the late Gomaredi sir. So I am today more honored to talk on his birth name. So coming to my topic. So basically, why organ donation is important? What is the need? People think that there are so many other diseases. Why organ transplantation is needed? We should understand that in India, previously before 80s, non-communicable disease like cholera, malaria, these were the dominant diseases causes for mortality. Now non-communicable disease. As you know that, look at that. There are 80% of the IT employees are fatty liver disease. You know that Hyderabad is the capital, especially Telangana is the capital of diabetes. So diabetes, hypertension, obesity, lifestyle disorders, lack of exercises, these are all contributing to the non-communicable diseases, especially fatty liver disease. So world over, the commonest cause for liver transplantation etiology is fatty liver disease, that is non-alcoholic fatty liver disease. So that's why there is an interesting survey. See, it's not only about adult population. School-going children, the ICMR did a study, it is showing an alarming 20% of the school children also have fatty liver disease. So what these all leads, so as you know that diabetes and hypertension is the leading cause for chronic kidney disease, leading cause for chronic liver disease, and also coronary artery diseases and its sequelae. So these are all finally landing into the end stage organ failure. So this is one important survey. People are thinking that India is it needed liver transplant. No, it is needed. The reason is average in India, average 2 lakhs population is dying because of various chronic liver disease or liver cancer. So in that super rich families also there, very poor families also there. Sometimes even doctors also there. The reason is why these people are dying because not available of suitable donor. Because sometimes you have a money, you have a access, but you don't have a fit family member in your family. Like blood group is not matching. What you will do? You will depend on brain dead donation only. So that is why. So out of 2 lakhs, in India, only hardly 3,000 liver transplants are happening compared to Delhi, Chennai, North, South, both government institution and private institution. So 3,000 only people are benefiting out of 2 lakhs population research. So that means there is a strong gap which need organ donation very essential. So where you will get organ, that is very important because people will ask, sir, can I get an organ? No, it's not just like that. So primarily organ comes from the 3 sources. One is live donor. If your family member is feeling like kidney or liver or sometimes intestine also you can donate. So in live donation, because I am seeing so many times in a WhatsApp coming, 4 kidneys are available, you can use it. It's not like that. Basically, the Indian organ transplant law says that only first degree relatives, like children, parents, or brothers and sisters, or grandparents only will be allowed as a legally organ donation. So what will happen? Next question will ask us, sir, my entire family member's blood group is not matching, not medically fit. Is there any way second degree can donate organs? Yes, there is a cousin, brother-in-laws can also donate, provided you have to show that these are the degree fellows are unfit. So in that scenario, what you have to do is you have to apply state organ transplant center. So I am one of the legal Telangana authorizing committee members, so we will get a regularly such cases. So second one is donation after brain death. So this is a very comprehensive reason for organ donation. Next one is donation after cardiac. How we do it? So usually a patient sustained road accident or a patient had a massive intracerebral bleed because of rupture of aneurysm or intracerebral bleed. If his brain is irreversibly damaged, he is on ventilator dependent. So his blood pressure circulation is intact. Such patients, if you fulfill the criteria of brain death, then we will ask their family member for the organ donation. If they agree only, then we will take organs from such family. So here is brain death identification is a big challenge because many of the transplant coordinators or grief counselors or children are not even having aware where is the brain death. So that is why I choose an IMA as a platform, because you are the doctor first to see whenever in your clinic, in your hospital, in your practice area, whenever you see a potential brain death donor, don't get stressful. You won't have any legal issues because now brain death donation, organ retrieval is legally sanctioned, legally valid. So whenever you see that potential brain death donor, don't inform family at all. You just inform children and family, they will come. Officially, coordinators will come. They will counsel the family members. If the family members agree only, we will take organs. So it is now police station also knows this rule, forensic fellows also know this rule. So it is a legally. So you should not have a worry because many of the time our doctors concern why I want to take extra headache. It is not at all. Because organ donation saves one day your family member also. So what is donation after cardiac death? This is the recent concept. What is that mean? Sometimes family members, patient is non-recoverable disease. They want to give a euthanasia permission or they want to disconnect the ventilator. Is there any way to use that organ? Yes, we can use that organ. It is a recent concept, but in India it is not started. Whereas in Europe and Sweden it is very common. So donation after cardiac death also we can take. If the family member says that they want to gain off the life-saving support system, they give a consent for organ donation. What we do is we cannulate the femoral artery, femoral vein, we use a perfusion solution, and once cardiac death occurs, death declares, then we start procuring of organs by using an extracorporeal membrane oxygen. So this is the way also you can take organ from donation of the cardiac. So coming to the point topic about liver transplant. Why liver transplant is needed? Because liver transplantation is a life-saving procedure, especially for the patients with the permanent liver failure patients. Sometimes, healthy fellow suddenly suffer viral fever like dengue fever or hepatitis A or hepatitis E. If the severe liver failure patient sometimes may not recover with conservative measures, such patients need liver transplantation. So this can happen to any of our family members. I can tell you one classical example is one of the doctors, one is anesthetist, one is a pediatrician, who had only one child. So he was intermediate to the student, suddenly he had a viral fever, then he had a liver failure, then patient went on ventilator and coagulopathy. None of the blood group was matching, they both parents. So patient was dying. That time we realized that organ donation is very important. we don't do any HLA type. So we do only blood group match. If the blood group match, we can proceed. Another important thing is, in liver transplantation, surgery is very difficult surgery. But if they survive from surgical insult or surgical trauma, they live better than kidney transplant, better than heart transplant. Why? Because they give a least immunosuppression. So I will show you some of my patients are rugby football players. So they don't get burden on you. They can earn their job back also. So liver transplant survival, we are not calculating 5 years, 10 years. Now people are living 20 years also. So it gives a really second life. So look at these patients. This is the child having a congenital biliary atresia, totally decompensated. Whatever the methods used conservatively, you cannot take life back because they have to live a long life. So after this is the child, single parent child. She is studying a second year. Recently, one the chief minister was appreciated. This child is 18 years girl. Suddenly had a viral fever, coagulopathy. Then they came to Usmania in an intubated condition with the INR more than 4.5. In such cases, there is only one parent, so no fit donor is there. So we rise in a Jivana super urgent category. We transplanted within 12 hours. So within 12 hours, so you can see that child. So liver transplant definitely is a life-saving procedure. So this is the way children, especially genetic diseases, if you do a right time transplantation, you can give a normal life. So this is the, when I was doing a liver transplant fellowship in the US, Starger Transplant Center. That Starger did liver transplant for this boy at the age of 6 years for congenital biliary atresia. So during my outpatient clinic, this fellow came. I thought he is attended. No, I am a liver transplant recipient. So what he is doing is a rugby football player, Buffalo team key player. So I even not, we can't have that much stamina. So what message I want to tell you is, liver transplant not only gives long-term survival, it also gives equally good quality of life. That is the message I want to convey. So you can see also. So this is the boy when I was in India Institute of Medical Sciences. This guy underwent liver transplant. We all went to saw his surgery. So that's why now I send a message, sir, now I have joined general surgery first year. So you can see that these are the examples. And that child underwent at the age of 6 weeks for Ima Karimnagar. Now the lady came to India during the Velas conference. So she is a model for British. So these are some of the examples. Like that, so many examples are there. Liver transplant, even though surgically is very difficult, but if it is done by a proper team, it can give a good quality of life and long survival. So there are so many ways, because I want to say that is there only cadaver transplant, is there only living donor, is there any other method? What is new advances in liver transplant? There are so many ways. So these are the common indications. So cirrhosis, acute liver failure, metabolic diseases, tumors also sometimes do a transplant. The reason for a tumor is, in any cancer, generally, depending upon the cancer stage, we do first 2 stages, we do resection, 3, 4, we give a palliative or chemotherapy or systemic therapy. Whereas in a liver surgery, even though if it is stage 1 also, if the HCC occurs, hepatocellular carcinoma occurs, very tiny lesion, if it is occurring in the background of chronic liver disease like hepatitis B or cirrhosis, you cannot resect because liver function is not good. In such cases, we do a liver transplant also, which gives equally long-term survival. So, for a liver transplant in a malignant tumor, we have some criteria like Neon's criteria. Such criteria, if it is fulfilled, we can do a transplant. So, what the difference between the kidney transplant and liver transplantation is, kidney transplant, native kidney will not be removed. They transplant additional kidney, third kidney in the right iliac fossa, left iliac fossa. So whereas in a liver transplant, the biggest challenge is you should remove the cirrhotic liver. So cirrhotic liver removing is very challenging in the background of portal hypertension, coagulopathy, massive bleeding, metabolic changes, severe acidosis will occur. So that is why a liver transplant anesthesia is also equally very important. So this is a very important thing. Once after removing the diseased liver, there is an anaphylaxis phase, no liver stage. Then we implant a no liver. If it is cadaver, we will use the whole liver. If it is living donor, we use it partially. So this is the method of classically done method. This is some of the cases. You can see that this is the brainiac donor. We remove the cirrhotic liver with transplant diet in a cadaver transplant. Not playing. It's not playing. Video. Just play. So what we do is just 1 minute. So usually, whenever there is a brain dead organ is there, we cut an entire abdomen and chest, we will see that. So fatty liver, severe fatty liver is not used. So a good quality liver should be soft, beefy, color, sharp. This is the idea we are taking such livers here. Liver donation. So what we do in the living donor liver transplantation is the main fundamentals is a good radiology. Preoperative only, we will assess how much liver is there in donor, how much safely we can take. So you can see that the center picture. Volumetry, the blue color we shade that we are going to take a liver. So the main principle of liver surgery, it's not like a tumor surgery. Tumor surgery side you ligate the blood vessels and remove it. But here, in this case we are planning the right lobe liver transplant. If you see the downward picture, the right lobe also should not compromise blood flow. Future liver element, that is left lobe also should maintain blood flow. That is the important. So we plan such a meticulous way of this we can play with. So this is the one of the pediatric liver, living donor liver. You can see that we just left lateral segment, we start general transaction done. You see the left branch of the portal vein, left branch of the nodular. Classically, we maintain and maintain. So this is some of the patients I did with liver transplant. So till now we caused more than 528 cadaver and adult liver transplant more than 138 pediatric liver. So our president of the Liver Transplant Society of India, Muhammad India, so he has saw some of our patients. Right, not made. It's not made. So these are the some of the pediatric patients. So really I this is the split liver transplant. I told you sometimes so many recipients are waiting. Donations are occurring in less number, so many people are dying during the waiting period only. Is there any way to reduce waiting list mortality? So sometimes a fit donor is available. We split the liver into the right lobe and left lobe. You can split the recipients during the breathing part or exposure also. So this example, if you see that. The two fellows, adult sitting in the chair is a right lobe liver transplant, and the child is pediatric liver recipient. So, with the help of one cadaver donor, we are split and given to the two recipients blood. So, this is the way of liver regeneration principle. So, this is the one case we did it in Usman. So, So that was organ allocated to the Usmania. So we had more than 350 waiting list in Usmania. So we have that splitting of the liver and we used this child and one adult. So sometimes permanent liver failure also we need to do it. So what is new advancement? As you know that acute liver failure will occur those doesn't have any liver disease previously. Suddenly they are normal, suddenly develop some liver disease in the form of viral fever or toxins. Then they go into the liver failure and the life-saving liver transplant. So what will happen in liver transplant is, or any organ transplantation is, post-transplant they need to take a lifelong immunosuppression because it is belong to other fellows organs. So your body tries to reject. So in a ALF patients, once you do a transplant, they leave it, but they will go on suffer with the immunosuppressions, medicine-related complications. So is there any way to avoid immunosuppression for lifetime? So one of that is auxiliary liver transplant. Auxiliary means additional liver. So what we do is, normally we remove entire liver. In a permanent liver failure, we remove a portion of the liver, thinking that liver will regenerate. Only portion of the liver will transplant. If you look at that, this patient had a permanent liver failure. We have not removed entire liver. Right now we get lipotomy, we have to do transplant. Once patient recovers from liver failure or insult, after 1 to 2 years, we will see that liver is right for patient's one liver is regrown, working well, but it's not the immunosuppression. Because patient will take care of his own liver. So if you see the class C, the left lateral graft automatically atrophy occurs, so patient will not to take it right now immunosuppression. That is the way of auxiliary liver. This is one case, primary hyperoxaluria. Patient had a defect in a calcium metabolism defect, citrate metabolism in the liver. So patient doesn't have any liver disease. Patient developed extensive renal calcinosis. So patient had a renal failure and dialysis. So if you do kidney transplant, then again that kidney also will be done. So what we have done in this case in this manual, simultaneously liver and kidney. So sometimes liver intestine also. Second very challenging is in adult after transplant we give immunosuppression like steroids and immunosuppression tacrolimus. Whereas if you do transplant in children, if you use the steroids and tacrolimus, baby's growth will be hampered because they cannot grow. Skeleton muscle will not grow. So that is why the liver transplant doing in a children is always challenging because not only organs should survive, patient also should grow. So that is why we go on changes the immunosuppression, we go on decrease the immunosuppression. So doing a liver transplant in a children is really challenging. So these are some of the recent diseases, tyrosine. So this tyrosine, if you look at that child, she was having a tyrosine defect which causes renal tubular acidosis. She was losing calcium in the bones, she is losing calcium in the urine. So patient developed both lower limb fractures. So she did not come with the liver abnormality. She came with the increased urination, bedwetting and unable to walk, more fractures. So one of the pediatrician diagnosed that the renal tubular acidosis is due to tyrosinemia. So tyrosinemia only treatment is the liver transplant. So we needed to transplant for that. Now the baby is walking and actively going to the hospital. So sometimes metabolic disorders, they don't have any liver function abnormality. Some defects in our gene. As you know, liver does more than 2000 functions. So some of the defects in the gene which causes is propionic acidemia, urea cycle diseases, they present like myopathy, seizures, or brain damage. But per se they don't have a liver disease. Even anatomically also liver will be normal. So in such cases, why to remove whole liver? Why can't we make a genetic therapy in the form of a partial liver transplant? control the neck. Can you play this video? So after partial auxiliary transplant, we just taken a left lateral from the father to transplant. Now you can see that when the baby came, totally neck flaccid collapse, not even standing up. This is the way of surgical gene therapy, also called auxiliary partial orthotopic genome. That means we add additional gene defective in the form of healthy liver partial transplant. So these are the areas as this we got one of the world congress, one of the first reported in India. This syndrome, genetical defect, no hair, skin is dry skin, and also have skin lesions, also have a liver disease. So to do transplant is very challenging because skin whether heals or not. Laparotomy knows whether skin will heal or not. So difficult challenge and we deal. And we published, this is the fourth case only documented in the world literature, first case in India. So we presented in a World Congress at Japan. So our one of the postgraduate got a best paper for this. So this is Allegedly syndrome. It's a summary feature. Because of time that I cannot do. What I mean to say that people think that liver transplantation is a complex surgery, it carries high mortality. No. Now with the advent of modern methods of investigation, teamwork, anesthetics, critical care, pediatricians, as a team, if you properly select cases, you can give them good quality of life, long-term survival of the graft, and also patients will live like normally, like non-transplantation. So sometimes, because diabetes is increasing, Telangana is the capital of diabetes in India. So type 1, type 2, type 3 diabetes also increasing. So we started pancreas transplantation also. I will tell you where you will do exactly. Only one word. See, the type 1 diabetes coming with 20 years with bilateral kidney failure, diabetic nephropathy, conventionally doing is a kidney transplant. What will happen? If you do kidney transplant, you give us steroids, active sugars will shoot up, and transplanted kidney also, because he is going to transplant 20 years only. Another 10 years or 50 years, that kidney also will go into diabetic nephropathy, another transplant. So by the time the patient will develop other complications like retinopathy, microangiopathy, cardiopathy. So we advocate whenever you got the cadaver kidney from the same organ, why can't you take the pancreas also from the organ? So you can use simultaneously pancreas and kidney transplant. By doing that, you can decrease the insulin requirement. You can prevent the transplanted kidney from reoccurring of sugar-related, diabetes-related kidney damage, and you can stop retinopathy, you can stop cataract, you can stop progress of bone ischemia disorders. So this is the key. So there are enough examples of survival is there. So this is our first pancreas transplant done in India. So this guy came with an already bilateral cataract surgery of full retinopathy. Vision almost you can't see just 1 feet beyond also. He was having a lower limb problem. He was bilateral kidney disease, CKD, he is on dialysis. So when they have listed the kidney transplant, I only request a nephrologist, why can't we do simultaneous pancreas kidney transplant? The reason is this patient was already taking 60 units of insulin per day. So after pancreas transplant, so generally we do pancreas right side and kidney on the left side. So after transplant, his insulin requirement is decreased. Now he is doing that. So sometimes intestine massive bowel gangrene also we do. Following COVID, usually vascular occlusion, sudden cardiac arrest, sudden mesenteric artery occlusion. Young fellows are coming with a massive bowel gangrene. So this is the girl, if you see the following COVID vaccination, she had a mesenteric artery occlusion, massive bowel damage, remote question was on parenteral nutrition. So we did a living donor intestinal transplant. This is first intestinal transplant done from this patient belongs to Karimnagar. This is our first. This is the first liver transplant done in Usmania in 2015. This patient is once we approached him because he was print media or your cinema media has got a more penetration in the public than a doctor takes. So they agreed on this. So this video I am showing everybody that this got a more impact than what I am telling you. So this you can see that even if our ancient people, Shankaracharya also says that his body is for others, so we have to donate. Even if you see that Lord Ganesha also got a head transplantation with him. We think that we have done a great thing after my death, my memory, my legacy will that. No, now you think is, why only memory? Still you can give during your death time also you can donate organs. Not only your memory, you can organs also receive. So, this I am telling my younger colleagues, Gen Z generation, don't use cell phone
stomach liver transplant and also the awareness video. I think looking at the video, many of us will pledge for organ donation. Now the citizens of Karimnagar want to felicitate yourself. I ask the chairpersons to join the felicitation.
All subjects of Karimnagar please go join the felicitate Dr. Madhusudan sir. My manager sir, please come onto the stage now. I am a state president. Please come onto the stage. I invite all state body officers, please come onto the stage to felicitate Dr. Madhusudan sir. With the inspiring lectures for organ donation and so many indications for liver transplantation. The lecture is truly inspiring and inspiring many to for organ donation. Dr. Vikas sir,
Yes, sir, please, sir.
please come on to the stage. Dr. Vikas sir, Dr. Vijayendra Reddy sir, Advocate Vijayendra Reddy sir, please come on to the stage. Dr. Shyam Sundar sir, Dr. V.N. Rao sir, Dr. Rajeshwar sir,
Madhusudan is a great surgeon. He works in Usmania Medical College and helping poor patients. So he gives lots of money to poor patients for the medicines. So he fought with government to start a liver transplant unit in Usmania Medical College. Fortunately, he is my classmate in Kakatiya Medical College 1988 batch. And pioneers batch, most of them they came from Hyderabad, Warangal, nearby places. I invite pioneers to come onto the dais. I invite all the pioneers to come onto the dais because we are very proud of Dr. Madhusudan, who is doing liver transplantation for the poor patients. Our life is for patients and he is doing to the fullest. He is doing to the fullest. Dr. Madhusudan, we are very proud of you, Madhusudan. During our class, he used to sit in the first row and in the dissection hall with the curly hair with 19-year-old boy, youngest in our class, 18-year-old boy. He used to do dissection. No other people can see the dissection because of his curly hair. So, such a legend he is Dr. Madhusudan. And due to the continuous liver transplants, maybe his curly hair has come down. So, serving poor patients, we are very proud of you, Dr. Madhusudan. And Dr. Poop Reddy sir, he did his studies in the All India Institute of Medical Sciences, and our Madhusudan also did his post-graduation from All India Institute of Medical Sciences. We are very proud of Dr. Madhusudan. Give a round of applause to Dr. Madhusudan. Thank you. Thank you, our state IMA president, please stay here, and all the IMA leaders, past presidents, please stay here for the inauguration function. I request Dr. Dukaleni sir and Shashikala ma'am to come on to the dais for the inaugural function. Dr. Surya Narayan Reddy sir, the group ladies were son, he is so kind enough to felicitate the President, Secretary and Treasurer. I don't know, we are serving IMA and we don't think that we have done a great thing. We are just serving IMA and every IMA member should feel happy. And I am here to announce you that IMA stall is there in our stalls. Those who have not become IMA members, please become IMA members because most of the people they have come. And some of the schemes like family benefit scheme and all, if they have not joined, please join. Any queries, there are IMA state president Dr. Kishan sir appointed 5 female attendants clerks who can help you in taking the membership. Thank you.
Good morning, everybody. Sorry, we are disturbing you. We take a 1 minute of thank Dr. Shailaja for becoming a president of IMA and lady. But we know her since 1988. She is so jovial and also she is very sincere doctor. As you know that one of the time she fought against cesarean section.
Thank you for accepting the presentation. I request Mahesh sir to participate the chairpersons. I request all the dignitaries on the stage to please kindly get down so that we can start the inaugural.
Now we will proceed for the inaugural function. So before that, Chandra Madam and students are all from the group photo.
Okay, ma'am, please.
Now I request Dr. Radhi Sridhar madam. Please come forward.
Ladies and gentlemen, settle down. Now we are going to have another function. The Guru Editor has come here. Guru Editor, as you all know, is a well-known famous orthopedic surgeon. Dr. Shashikara Madam, gynecologist. Our dear Dr. Kishan sir, please our present IFA, stage present. I invite Dr. B.A. sir to come on to the dais for inaugural function. To all the senior IFA leaders to come on to the dais for the lighting. Dr. Ali sir,
Namulo
ex-serviceman. He never missed a single flag hosting in Ima Karimnagar from 1982 to 85. Orthopedic surgeon, personally specialty hospital network, 1985 to today. Orthopedic surgeon in private practice in Karimnagar. One of the founder members of the first president of Karimnagar Orthopedic Association. He has membership in IMA Karimnagar, IOA, Bombay Orthopedic Association, Pediatric Orthopedic Society, Indian Biological Orthopedic, Indo-German Orthopedic, Academy of Orthopedic. He received many certifications from various prestigious associations. IMA Karimnagar, Indian Orthopedic Association, Orthopedic Association of South India, OSC. His father is late Sri Ayyani Lakshman Rao, agriculturist, died aged 107 years. Mother late Srimati Satyamma, homemaker. Father-in-law late Sri Jivadi Ramapati Rao, ex-MP Lok Sabha Karimnagar 1962 to 67. Mother-in-law is Srimati late Kausalya, wife Ayidevi Lalini, homemaker. Two sons, first son is Sri Praveen Rao, orthopedic surgeon, joints promo in Yashoda Hospital, Secretariat, and second son Dr. Ramakant Rao, orthopedic spine surgeon, SPS Institute of Neurosciences. He is down to earth, simple, humble, always positive. He is very lavish in appreciating others, and he is a miser in criticizing others. He sees everything positive in others, treat patients with great respect. His patients feel comfortable with him. They utter his name with pride. They feel as Srivarosa is God for them. Let us salute his services to mankind and his services to country as ex-serviceman. He says that his life served for in the border when he was doing as an army doctor. It was a great experience for me, and it was a fortune for him to serve for the country. Today, Srivarosa oration is by well-known orthosurgeon, world famous Dr. Guru Reddy Garu. Please come out of the dais. Chairperson Dr. Vijayendra Reddy Garu, Dr. Bangan Swami Garu. Srivarosa family, please come out to the dais stage.
The orange medal is presented to Dr. Ima Karimnagar Orations Cme. All please be seated. It's a great honor to present Dr. Ima Karimnagar in the name of Dr. Srivarosa. Here is the citation of honor of the Guru Reddy sir. He is an eminent orthopedic surgeon of international repute. He is the founder and managing director of Sunshine Hospital, Hyderabad. He is chairman of Sunshine Bone and Joint Institute. A pioneer in joint replacement in India. He has been at the forefront of advancing orthopedic care, precision, innovation, and compassion. He serves as the president of Indian Society of Spine Surgeons and is a distinguished founder member of the society. Under his visionary leadership, Sunshine Hospital has evolved into one of the largest orthopedic group of hospitals in South Asia and globally recognized centers of excellence in joint replacement surgery. Dr. Guru Reddy established Sunshine Ortho-Robotics, a designated global center of excellence for robotic assisted joint replacement, and was the first in India to acquire 4-generation striker Mako robotic system. His contributions extend internationally as an active faculty member and examiner for Royal College of Surgeons Training World. its literature, media, and public forums. Behind this contributing significantly to women's healthcare, Dr. August Gupta is a deputy doctorate surgeon, continuing the legacy of Cme.
Is it okay now?
Kavya, his daughter,
Okay, madam, please, madam.
Savitri, Dr. Gupta, Shamila, doctorate surgeon, further medical contributions to
Yeah, ready? Fire on the place.
Jamila, the CEO of Kondarapa, Nestle Incorporate and Industrial Domain. I is proud to have never like you here. The award to be an executive member and university research model. Prestigious recognition of capital. I see the law for the year 2026. And thank you.
Request everyone to maintain silence. Please don't take pictures right now near the doctor's side.
Yeah, good morning everyone. It's a great honor to be here in Karimnagar. So they were very kind and they were very open and gave me a lot of support. From Sridhar, sons of our friends, Ima Karimnagar. So it's a great honor to be here. Allah Swami, and he was actually, I was very reluctant to come. I did halfway, I wanted to cover the outside engagements so that I can spend more time with my wife. But the Sridhar was very insistent. We can not regularly use to hold it. Okay, so year medical student that is finally a doctor after 15 years. The honest truth about doctors, 70% doctors report burnout symptoms, 50% skip meals at least 3 times a week. I'm feeling subscribed to that. I became a doctor to save lives, I forgot to save my own. But for me, every day is a celebration. There is no second thought about it. As I talk to you now, I enjoy this moment, living the present. So I just briefly share my day schedule. Morning I wake up, I have to wake up because my wife wakes up at 4 o'clock. So I love dogs, I love sunrises. How many people see sunrise every day? Can you catch up? I did 10 members. Yeah, I was 80 years old. I try to live and I eat breakfast in the car to save 15-20 minutes of time. And then that is my daily schedule. This is the operating list. I'm the one only very few doctors who see both sunrise and sunset. And after dinner, I take my grandson, my wife, and that is me reading a book on the terrace, under the moonlight, and the bus current. Thanks to Amazon, 200 rupees bus current, you can sleep on the terrace. We all the children slept on the terraces to next to our family. The government would pay all over the base system. Because our terrace will carry all the Amazon and copies are complimentary. Because our terrace will come moonlight zone or books out for the arm of Manila. That is what happened in all the world. So the next 30 minutes was 3E, 4G, 5F in the divine chapter. Avoid Jalan 3E, ego, envy, excess greed. And having a family, 4G, gratitude, see good in everything, gestures, giving, and 5F, family, friends, food, fun, and focus. So let us start with the family. And of course, this is a relationship, your real life support system. Spouse, your anchor, invest, or you will drift alone. Children, they need a parent, not a provider. Parents, they are aging, you know this clinically. Friends, your humanity leaders. Mentors, like Sridhar sir, your professional compass. You, the most dedicated relationship of all. A happy marriage is about 3 things: memories of togetherness, forgiveness of mistakes, and the promise to never give up on each other. That's an important point to state it. And the husband of an option reason, difficulties are there. Even his husband also can't do that. ఒక చిన్న జోక్ చెప్తాను, జోక్ నిజం. ఒక రోజు రాత్రి నాకు ఎక్స్పైర్ వచ్చింది, ఖండిస్తున్నా. పక్కన భవనం ఉంది, తప్పి లేపితే ట్రై చేశాను, లేవలేదు. మర్నాడు రోజున నేను చెప్తే ఫోన్ తీసుకుని కదా అంటే గైనకాలజిస్ట్కి ఈ ఫోన్ ఎంత అలవాటైపోయిందంటే ఆ ఫోన్ చేసి 8 సెంటీమీటర్స్ అనేది. సో దట్ ఈస్ ద ప్రాబ్లమ్ ఆఫ్ బీయింగ్ an obstetrician husband. So every week, Mangalore, Tuesday, I spend time with my wife. Come what day. So I call Mangalore once more. I take her out for a meeting out, or we go to cinema, we go to deserts. I even take to Bombay to show her some programs in cultural center. So all the youngsters don't do it at the age of 65, they will be too late. Start at 30, the moment you are married. How many people are not married in this group? Very few. Right, okay. So rest of the people who are married, spend one day, extra hours, non-negotiable. Body goes to parents, you will be the happiest person in the world. So, you can do need to do the army is to come here. Important point. Aduna, what is the okay, tell me, okay. So, boy, carrom board is already, I play carrom board. I also do like it, but I will just like in carrom board 20, power 20, points 20, cutting is done. So again, important point of being happy. Go on, narrative is good. Narrative is good. What vessels to take is again? Say, husband. I am a DM traveler, the doctor mode. Degree. There are of end or word of the public order, I think the end of the best way to never comfort by the narrative of book publication. How to be your husband. If we come here today, we want this for ladies. But I would never doctor guide. Now the doctor's guide not to lose your spouse and be happy. Number one, no for dinner. Listen more guide. So take the vacation. Remember anniversaries. Important point. Random acts of appreciation and laugh together daily. So family now come to the family, Sunday morning, again holidays together. When you enter good family again, now the whole so that we sit together, we speak together and get food. So that is important. Being a family, running a family. So that is working together and eating together. So my son is Ima Karimnagar. So what about the next one? So you are spending time with the family and studying Malu, just a balance. Bombay is one of the for operation they are the best of the table is better. They are but this is a beauty of the big family. That is one of the important point of being happy. Now, the fourth generation point donor, still the also combined family. If you have opportunity, spend time with your parents, and that's a wonderful way to live like that. My mother, now again, okay, the don't remind what we say, the one reminder I want to do is to remind and spend with my mother. My mother would go down and spend even day, I could not go because I was running in the Hyderabad practice. By the time she came to me, she was on the wheelchair, suffering from a stroke, 4 years not away, but she could not recognize who I am. So do not do that mistake, please youngsters. Spend time with your parents. Very important point. Of course, all we are going to spend your time and sister in Germany. Again, don't do that opportunity. Now my both parents are gone. But every year, I do something on their name. Ladies, my father is so noble. Without me telling, he donated his whole body to the government department. So which was very, very good. If now I have grown up, I have gone and attend their school days. Again, I make the point. In the again, grandparents are so they're not busy. But we have to take a leave and go to school to show yourself there. That's what it is. So again, spending time with grandchildren, and again with my 4 grandchildren, and create an excuse for family get together. Extended family, Baba, cousins, just something like that. I think you know the family man, and these people do happy man. Now coming to the next year, friends. Friends are very important. You know that they put down the blanket of age. These friends never ever to age. Up to friends, dancing, instrumental dancing, simple dancing. That's what we have here. Okay. Now, please focus. ನಿಮ್ಮ ಹಾಸ್ಪಿಟಲ್ share every Monday morning. I get all the people, fourth class, to train them in the patient relationship. This goes a long way. But to train the nurses, it is very, very appalling here. Okay? I'll move it. Okay? So nurse training is very important. And again, when you are hiring the last one, don't even bother the first two. Current profession. So these people better today, you will be put in this thing. All relationships are taken care of people who are if you want just like that, never manage private work, it is incidental. Of course, this all everybody knows. There are two ways that being about that do good, be seen as being good. The second one is where we fall. That's what we have to take care of it. A very important quotation from Kafka in this movie, you treat a disease, you lose. But you treat a person, I guarantee you will no matter what the outcome. So, having practiced this today, choose one or two subspecialties, expertise, develop your own patient base, never do surgery without expertise, act like GP first 5 years, never criticize colleagues, second to us, update your knowledge, one more professional partnership, how PhD bank, indicates security based on finance. Money to hospital like this, something is wrong. So never do that. You should be happy unless your patient will not be happy. Medicine, law, business, engineering, these are all pursuits necessary to sustain life. But poetry, these are what you stay alive for. Sometimes you have to decide to retire. Okay, we are all coming to the age. Okay. So, not come to that stage. Okay. Positive attitude are చాలా important. Very interested. Positive attitude are చాలా important. Very interested. The biggest lesson in the world is your mindset. Our mindset positive is I can proudly tell name use case is the correct one which I want. Sejal is one of the finest, happiest doctors I have encountered in my life. Again, balance, which is going to talk. And again, so much of happiness depends on how we choose to live the world. Same God, we need to do one of which is good to what our father is on. Same person. It's like the individual of the power on dance. So one attitude, the life. Okay, and I love to see you can play the video. The positive so I see positive but I keep reminding myself of happiness. These are my breakfast bowls, those are my bed sheets. Everywhere in my house, there will be thinking that you should be happy. That even in my bathroom, the power for happiness is in there. Every minute, I mention this. And again, in the hospital operations, so it should be surrounded by good people and again, good things there. Health, always remember. These are the two important things in life. And again, in that cases, it's all about patience. Okay. And again, I took Pune, I attended my fellows training and came back and got operated there. Again, patience. Now I stop patient to stop accidents, to give it back to the society. Again, another important part is giving back. These are all giving back. Now, final slides, work-life balance. We all know the work-life balance. Nothing to do about this. But very important part is work-life balance. To keep yourself happy. Important thing is you should have some amount of pressure. Otherwise, you cannot achieve or you cannot go forward. But the beauty is the center. You should keep aiming and aspiring for better things. And again, work-life balance. Whoever friends come to me or my relatives come to me, I make a working life. When working, it's a busy schedule. But I make a point. This is all my working life. You can see very well. God will. Individual operate, this is operating theater. And individual surgeries, I come out and look into the nature and relax. And you don't need to go to holiday to financial for everyone. I wanted to marry Kanchana, I wanted to marry Mahasina. Right. Spend your time with people who only want to invest money. So finally, the people who surround you are very important. So don't be surrounded by negative people who have your knowledge. So 33% is important. One third you work with the people below you. One third people on your level. One third who are superior to you to inspire you. And again, these are the people whom I don't even believe in them, but I listen to them because they are best things to put it there. Again, important point is surround with good people. If you look at the people in the circle and don't get inspired, then you don't have a circle. You don't have anything. So that you have a case. So these are all my colleagues who can inspire, create, inspire me, and you with them. Again, meet the person and respect the person, not his style. This is the last week when the chief minister called us for boosting our reservation. I had a selfie with him. But that is my lift boy. The big boy does lift so well. I want to have a selfie with him. What I'm trying to say is, don't judge the people because of their titles. Judge the people because of their things there. Last 3 weeks here, there is so much of going around, there is not any time to share. Where is the time to hate somebody? So, love somebody, we keep running for the money, and at the end of the day, we come to the final part, by the time it's too late. This is a real story of life. When people are created to be loved, things are created to be used. The reason why the world is gaps is because things are being loved and people are being used. Take care of your health, very important, sleep on time, well balanced food, take your sport or hobby, and do the things. And again, if Dalai Lama asked about operation, he knows about humanity, answered, man, because he sacrifices his health in order to make money, then he sacrifices money to recuperate his health, and then he is so anxious about the future that he does not enjoy the present. The result being that he does not live the present or the future, he lives as he is never going to die, and then dies having never really. Very, very profound quotation, so enjoy my friend, and be passionate what you have. As soon as that, you are not inside. So, good level until I sign my room. So, I'm like that. And again, don't keep comparing others first. Your life is yours. He shouldn't say, Chana important. He also, if I had only her favorite, a young girl, before I had her diamonds, a young man, if I only had his money, he old man, if I had only his life. One of the most important things is after and there are things start like there are things every marriage. Then I was dying for my child to go, enough for the right to retire. And now I'm dying 3 years, I forgot. So think like that now. So don't wait for some decision to make yourself. Okay? The secret to living together, long eat calm, walk the road, last remote, and love meditation. Okay? If you think for an hour, okay? Last 3 slides. And again, time is made elastic by experience. The more fully rich energetic one is, the longer one is the experience comes. That's what we all do, we have to do. As soon as that. And again, let me say one more Thank you so much.
Thank you, sir. Thank you for the wonderful lecture on how to be a happy doctor. It is especially useful in present scenario in territories where we are facing many problems, and we try to inculcate we remove the three, like to inculcate 4G and 5G. Thank you, sir. You are always an inspiration. We would like to honor the chairpersons.
Thank you, Dr. Guru for the lecture. Extremely and highly honored to chair this session. Firstly, the oration in the name of Dr. I. If honesty, sincerity, and discipline have to be poured into one single person, it will be Dr. Sindhara. The very scientific surgery and ideal doctor in the town of Karimnagar. Secondly, Dr. Guru is a person with a multi-faceted personality, and he is a good speaker, orator, a witness person, most transparent, most relations, even with the patients. And if I am not wrong, he has left the United Kingdom during the initial stages of his career after the death of Lady Diana. Am I right, sir? May I know the reason, sir? I heard when you were speaking to the Ms. Saki on the duty, I felt that the interview was very nice. And really covered a good topic. It is near the hour and it is helpful to our profession. Most of us are tense most of the time, and we are always in the constant stress. All the human beings, whatever living creatures, they tend to miss all the time. It's because the souls are basically Sat-Chit Anand. They are conscious and they are peaceful. And if you want to be happiness, if you want to be happy for some time, you may go and have 2 pigs. The happy lingers only for 1 or 2 hours. You will watch a movie maybe for a more time. And if you spend some time at your dream destination, maybe for more time you may be happy. But if you want to be happy all the time, then love your job too. And you just like and develop passion for the work and whatever you are doing, do for you. And I like express my thanks, sincere thanks to all other organizers. Of course, I like that also. That's all I'm saying. Don't say. Guru sir was telling
Earlier I used to enjoy with a small group rainbow. Now I have got a full sky because of my pioneer friends also tell whenever you are in Karimnagar, you enjoy with your friends. So, I in me and Ima and Mahesh, three of us, we really enjoy like children. That members to chairperson, sir. Sridhar sir, please come. ఒకసారి మెడికల్ కాలేజ్కి వెళ్ళి ఓవేషన్స్కి రమ్మంటే చాలామంది ఏంటో ఓవేషన్స్ అంటే ఏంటి ఏ డాక్టర్స్ వాళ్ళ ఎక్స్పీరియన్స్ అని చెప్పాలి మనం నేర్చుకుంటే మనం ఎప్పుడు హ్యాపీగా ఉండవచ్చు. సో మనిషికి డబ్బే ఇంపార్టెంట్ కాదు, మనం హ్యాపీగా పాజిటివిటీ అనేది వదిలిపెట్టి ముందుకెళ్తే బాగుంటుంది. Thank you, sir. Thank you.
Karimnagar Orations want to felicitate Sridhar sir today. We should now learn humility from both of you, sir. I think it is seen to witness, and we have to invite these qualities.
Okay, sir, please, sir.
In the great personalities to my photo ఇస్తున్నామంటే మా అదృష్టం.
Sir, okay, please, sir. Welcome. Yes.
Sridhar sir ఎక్సలెన్షన్. Sridhar sir వాళ్ళ డ్రైవర్ ఒకసారి కలిశారు. ఆయన చెప్పారు సార్ గురించి. డ్రైవర్ కూడా మీరు అని పలకరిస్తారట. అంతకుముందు ఆ డ్రైవర్ చాలా మేనర్లెస్గా మాట్లాడేది. డ్రైవర్ ఒకసారి మా దగ్గర వచ్చాడు. వచ్చి అమ్మగారు మీరు వస్తారన్నారు. అంటే అమ్మ ఇంత మంచిగా మాట్లాడుతున్నారు అంటే శ్రీనివాస దగ్గర పనిచేస్తున్నాను నేను అని అన్నారు. సో అంత మర్యాద దాని కింద పనిచేసే వాళ్ళని కూడా మీరు అని పలకరిస్తారు శ్రీధరరావు గారు.
studies obstetrics. She contributed many chapters for postgraduate textbooks in obstetrics and gynecology. It is
as Duhari sir told you, Shishikala madam is always happy. Once we traveled to Spain for a conference, there we had very good time. There, every moment was like enjoying. Every moment was enjoying, and she enjoyed company. Shashi madam, I became fan for her, and she also became fan for me. That is mutual fans, both of us. So I'm very happy to Shashi madam here.
Thankful for the Ima Karimnagar for inviting me for this walk today. And I have a lot of juniors and students here who are practicing Vijay. Dr. Govareddy's talk and break. She heard him speaking in Uttur Medical College once. I think for the
share responsibilities, then you can choose one person to make it one right duties, then divide. There is a option in this. Even if you are a medical medicine specialist or an IVF specialist, like that you have 6 of you, you can share your duties. So you will not make that much money, but you make time. We are happy 80 doctor. Okay? So responsibility towards leaders. This is again an important thing. Don't speak ill of a colleague. Many times patients come and try to extract some negative point about a colleague. Don't do that. Support that would be a distress. See, reduce error. Job is, we all know. This is one thing we need to remember. Physical and mental exhaustion. Physical exhaustion when you are working whole day, then you feel exhausted, want to take rest. But the same thing early morning when you goes for his walk, is invigorating. So exercise and incorporate day makes you existential fatigue. So whole day, lot of disturbance, somebody is coming, going, no work is getting done. By evening you get lot of stress. The same thing you handle a complex case, do it very well, and develop leaves us with knowledge. So we have to make sure that we have the physical exercise that makes us invigorating and do our professions in an evident. Patients are of different types. They will be grateful, ungrateful, and our response to them is the key. They are ungrateful, don't bother. You have a baby. You do your karma properly. So you can face okay and pretty facts. Some patients will come and say, "Madam, because of you I have this baby." Some of you say, "Because you didn't bother, this happened to me." So accept both the equality. Only continue to do your work. You can. So that's why you have to take responsibility. All these during asides are not going to repeat. So periodic breaks. So do it. The balance is the most difficult thing to do in our profession, in a lady doctor's profession. How it's a times are having social media, probably are there all the time seeing videos or things they are seeing on their cell phone, on their computer, and for yourself you need a personal time, develop hobbies. All this spiritual outlook is also very, very important. So bringing up children is, I feel like, dedicated how did my parents bring up. They had a down-to-earth upbringing, they were taught to respect others, imbibe the value of hard work. My mother was all the time a professional lady throughout her life. She was working 8 to 10 hours and focus on the finer aspects of life. So only profession is not important. Music, dance, how good is spending it, all the minor things he appreciates. All of us have it in us, but we have to inculcate that in our kids. So unless we expose them, they will not know. If we keep on telling, go to the school, study, go, come back, do tuition, and so whole day they are only studying. So only one part of their brain is being engaged. There is other part. So the other part is not getting stimulated. So then they will not learn to appreciate. After they grow up, they feel they have not learned the things which they should have. And they should not feel entitled. I'm so and so's daughter or son, so I get to be there. Those things you should, these are important things to cultivate. And financial independence. As a lady doctor, you have to be independent. So don't think you can hand over all your finances to your spouse. So fiscal decision making you should take part, and we all right. Black money nowadays doesn't work because that's not the right thing to do. And 30-40% of your income towards savings in the post tax or investments. So this is the importance of compounding. So first 7 years you save, next 3 years you see some growth. After that only after 10 years only you start seeing the accordingly you must plan long-term financial goals. Children, so much of inflation going on, what health issues you will have, all these are important. So be afraid not of growing slowly, be afraid of standing still. So don't stay where you are. So these are all the problems I faced as a freelancer. No nursing home, there was outpatient road, labor cases, life-threatening emergencies, gynae cases requiring surgery, and I was operating in different hospitals. All this was happening. So this I wanted to put up because in 1994 I lost one patient, maternal death due to cerebral hemorrhage. Patient had antiphospholipid syndrome. She had accidental hemorrhage, IUFP, and section. During section, suddenly her PP dropped, anesthesia
became a professor at the age of 31. She became director of Institute of Preventive Medicine at 1773 and became vice chancellor of Mahila University. Then she was AP Mahila Congress president during Rajiv Gandhi time. She became head. Then she was secretary Red Cross. Finally, she was member of the Legislative Council. So what she taught us was do your way. She brought us up independently. She never asked which class are you at some or playing. So she never stopped us from anything. So this was my marriage in 1977. When my elder son was 79, the lady doctor here thinks that she can do her profession well without family support or without support of others, and she is totally wrong. She has to take help, otherwise there is no way you can move on in life. Unfortunately, we lost early, and my older daughter-in-law, they were my support at home. So the 3 generations of joint family, my older son's graduation, older son's wedding. Then my husband in the meantime, he was also busy, and he won the best printer in the world award thrice in 1980, 2006, 2008 and 2010. And all the 3 elements in entire proud moment. So I lost this. This is my younger son's wedding, my niece's wedding. These are the women in my family, my niece, my granddaughter. This is my parents' family, my brother, sister-in-law, cousins. This was the 10th wedding anniversary of my younger son. Generations we have. Narendra is my greatest admirer and critic. So whatever I do, he admires the point. I don't like, I think, tell him on his face. I think these are the things which help us grow in our life. So, as the Guru said, we are not perfect all the time. So, we support each other, we don't make bad. Always behind me, my friend. So, Oscar Award, this is the Oscar Award won by Chandra Bose for RRR. So, there was a party, I said, can I take a picture with it? I took a picture. So, these are the awards I received from 3 generations. My mother, daughter with every year. And this was like my younger son, when he was in class 1. He wrote, my mother is the best doctor in the world. That was an award which I got. And my granddaughter, she wrote, I don't know where she found this paper. Friendship, whatever souls are made of, yours and mine are the same. Emily brought it, she has signed this. So these are the awards. So the last slide. So recently, January 1st, I was asked to talk about deadlines and checklists. So I said life has always been about taking things as they come and doing the best of any situation. I never believed in goals, checklists, or taxing most of the time, but it makes life meaningful and memorable. Satisfaction, success, and money, only gratitude as they all bring a sense of calm. So, no regrets and thankful to God for all that I have in life. Thank you so much for giving me this opportunity and giving me a chance to go through my life all over again.
Lesson for us. I request all the chairpersons. Village, high school studies at government JTHS Gollapalli Mandal, intermediate at government SKNR College Area, MBS from KMC Varangal 1986 with distinctions in biochemistry and microbiology, MD Pediatrics at All India Institute of Medical Sciences New Delhi in 1989, senior resident for 2 years at All India Institute of Medical Sciences, established Deakin Hospital in 1991 at Karimnagar with the first NICU facility, 35 years of clinical practice in child care and service, teaching faculty at KIMS Karimnagar for UGs and PGs for 20 years, examiner for UGs and PGs, presently Professor of KIMS Karimnagar, speaker at state and national telecom conferences, given oration in IIT Telangana, past presidents of TAPS 2019 Telangana, Chief Organizing Secretary TS Telecom 2019 held at Karimnagar, CIAT ED 2025, CIAT Finance Committee 2025, past President IMA Karimnagar 2021-22, past Treasurer IIM BMT, Secretary IMA BMT 2022-26, 10 publications, state and national faculty, active member almost all medical organizations and Lions Club International, founder trust member of Durga Bhavani Temple, married to Manjula Madam, homemaker, and having 3 children, Dr. Nikhil MD General Medicine, daughter-in-law Dr. VP MD Dermatology, second son Mr. Akhil BTech, and daughter Dr. Nikhila Sri PG, senior pediatrician Dr. Lakshman Kumar's oration is by Indrashekar sir. I invite Indrashekar sir to come on to the dais.
Master Indira, Dr. Indrashekar sir, please come on to the stage.
तुझे सूरज कहूँ या चंदा, तुझे दीप कहूँ या तारा, मेरा नाम करे रोशन, जग में मेरा लाला तारा, मेरा नाम करे रोशन, जग में मेरा
All PhDs of Karimnagar, please come on to the stage.
सूरज कहूँ या चंदा, तुझे दीप कहूँ या तारा, मेरा नाम करे रोशन,
Please come on to the stage. After being ourselves.
Dr. Indira, please come on to the stage. Dr. Indira. Madam.
Malika himself, the man behind the event, please come on to the stage. Indira, Dr. Indira, please come on to the stage. We are going to get both of you.
Senior pediatricians, most of the pediatricians, they came from Karimnagar, Warangal, and nearby places to hear Dr. Indrashekar sir, and he is going to talk on the oration of Dr. Lakshman Kumar sir, the senior pediatrician.
Thank you. Here is the citation in the honor of Dr. N. Indrashekar Rao sir. Dr. N. Indrashekar Rao. Please be seated. We are going to start the oration now. Lunch will be provided after this oration. Please be seated.
Okay, sir.
Dr. N. Indrashekar Rao with 5 decades of legacy in pediatrics, neonatology, and vaccinology. Dr. N. Indrashekar Rao is in exemplary service, has made outstanding contribution to the fields of pediatrics, neonatology, and vaccinology. With over 5 decades of dedication to pediatrics education, research, clinical care, and has played pivotal role in shaping generations of medical professionals. He is the former professor and head of pediatrics at Usmani Medical College and is medical superintendent of Nilapur Hospital. He has played pivotal role in strengthening pediatric and neonatal services across Andhra Pradesh and Telangana. His advanced training in neonatology from University of Illinois, USA, and his pioneering efforts in establishing neonatal care systems and large-scale training programs significantly improved Most Trusted Pediatrician Award in India and National Award for Excellence in 2026. Through his dedicated rural pediatric services, alongside his wife, Dr. Indra Sarapati, senior pediatrician, has helped educate parents and healthcare workers to meet challenges of emerging infections and future healthcare needs. Sir, Ima Karimnagar is proud to have a member here. The awards committee and executive committee of Ima Karimnagar have unanimously decided to honor you with prestigious oration of Dr. Cme for year 2026. Thank you.
I request all the audience to be please seated. All the delegates please maintain the decorum. Let the orators speak now. All the delegates please be seated. All the delegates downstage please be seated.
From Karimnagar Pediatrics Association, Lakshman sir want to present Lakshman sir.
Sir, okay, sir? Please, sir.
Pediatric Association.
Madam, sir. Madam, please, get up. Sir, please, sir.
IUP sir. Secretary Raghunath. Treasurer Ramya Madam.
Okay, sir. Sir, please, sir. Smile, sir. Okay.
I request the audience to be please seated. Delegates please be seated. Sir, his orator is about to give his speech.
Now over to Shekhar sir.
నమస్కారం. ఆకలి పిలుస్తుంది, భోజనం రమ్మంటుంది, కానీ మీరు దయచేసి కూర్చోవాలి ఒక 20 నిమిషాలు. ఆకలి పిలుస్తుంది, భోజనం రమ్మంటుంది, కానీ కూర్చోవాలి. ఎందరో ఎందరో శిష్యగణులు అందరికీ ఆశీర్వచనం. ఈ రోజు పవిత్రమైన అక్షయ పూజలను మీరందరూ అక్షయంగా ఆయురారోగ్యంగా ఐశ్వర్యంతో ఉండాలని ప్రార్థిస్తున్నాను. నేను మా డాక్టర్ ఇందిర ఇద్దరం జోడు గుర్రాల్లాగా 55 సంవత్సరాలు రూరల్ హెల్త్లో ప్రతిరోజు బస్సులో బైక్లో వెళ్ళి ఎందుకయ్యా అంటే మా గురువు గారు సిటీలో ప్రాక్టీస్ చేయవద్దు, అవుట్స్కర్ట్స్లోనే చేయండి, అక్కడే పీడియాట్రిక్ ప్రాసెస్ అలా 1975 తీసుకోండి. ఈ గ్రంథంలో Ima Karimnagar and Dr. Lakshman Kumar, whom I know since 30 years and admiring the first pediatrician here from All India Institute of Research, New Delhi. From that time, I have been observing him doing medical service to the organization. He has also organized in 2019 ID chapter CME, a very young surgeon when my son was here, and he was a great thing, and he is my son and my all but I cherish those memories today. Now coming back to the topic, it is a physicians, not a pediatricians. Actually, in private practice, all the physicians are also pediatricians, except for the sophisticated work. May I have the first slide, please? Today what I have is because of my teacher and mentor, Padma Bhushan Sirma Rao, who told me, adolescent is an adult without the senses of a real adult. Let us ponder what we can do. Now, the concepts of adolescence have really changed, and now the magnitude of the problem is to adolescents because they are really the true citizens and the back of our country. It is a phase of transition of their life from a child to an adult, that is from a budding flower to a full-grown flower. So, once again, adolescence is a fascinating yet curious phase of life, marked with a transition from childhood to independently functioning healthy adult. All of us have gone through these stages to recall most thoroughly. Let us see the stages. The Shishu, Balya, Kaumara, Yavana, Virasa, and Vyavasa. Most of us belong to the last two stages of life. The Virasa stage, and its responsibility as a Koskirashur and Vanyagrasasha for beyond 70 to retire into the jungles. So, these are all the stages. Of children is not optimum like other countries, not optimum like other countries. Eating Malandak means fruits, vegetables. To fighting obesity, we have to tell them about eating no junk food, no sweet food, and only healthy life. Every time adolescent girl and every fourth adolescent boy in 10 to 19 years is short for teaching as the community is below the normal standards. And 5% of adolescents 10 to 14 years and 4% of adolescents 15 to 90 years are overweight. Why they are overweight now? When they are young, you walk, you cycle, do our work. Now the 6, 7, 3, eat and sit and eat and sit. Family physicians, all of you have a great role to play in creating the right on the proper disease and communication. Self-esteem. Self-esteem is how adolescents see and value themselves. We should respect their dignity, respect their sensitivity is very important. We share the confidence, mission, vision, and relationships. Health is self-esteem, encourages positive behavior and resilience. And low self-esteem will cause anxiety, depression. This is so many other different factors. Self-esteem is not there. Among the factors, they go into depression, and some of them go into suicidal disorders. What is that they need? They need support from the family, support from the teachers, and peers is very, very important. Encourage the strength and celebrate self-good. Congratulations for every small achievement they do, and see that they develop healthy body image. Open communication and listening to the adolescents and helping understand them, which is very important. Healthy self-esteem means a strong foundation for adulthood, where crying and worried. This is what we see mostly in the cities. Misuse of substances like alcohol, tobacco, drugs, great cause of the family. Thus, and lack of awareness about bad effects of that. These drugs affect the brain development, memory, and emotional. Scholastic performance will go down badly, which will rank first class as double at work. This leads to poor academic performance, risky behavior, and health problems. Prevention is early detection, open communication, strong family support is so necessary, and effective counseling is very, very important. We must catch the young, identify, and even more time receive communicate. Only one-to-one, take parents in departments and the teachers in departments, and prevent this abnormal activity of substances. School should run awareness program and promote healthy activities. So say goodbye to the ambition. Shattered dreams, etc. Substance abuse should be stopped at any stage in the adolescence other than this early prevention guidelines is a professional responsibility. When you have any specialty, it is a duty to do proper guidance toward the healthy adult. Wasn't it? Who is the mentor? Who is the monitor? Who is monitoring the children? Hopefully, digital connection, modern payment, very, very menace. A child is neglected, mother is busy, father goes for the software industry, mother is busy on there, and baby on getting birth is in the cell phone. Digital application is so rapid, we see everything that all the this child will not see. Mommy and dad will see. She or he will see. After your daughter, and reduce physical activity, high strain causes so many issues. Morning, not fresh to go to school again. Negative impact on performance and mental health, and increased risk of anxiety, depression, social isolation. Early information by parents, teachers, and schools is very crucial about the use of cell phone. Very easy. It can be active or spend happy time teacher to the family with television, not by alone. Do not encourage child alone to expose to the TV or to also media. So make it limited screen time, limited talks is very important. Encourage outdoor activities like hobbies, playing, that will deserve addiction. And recognition by doctors, parents, teachers, and peers. Very, very, very appreciated. Encourage them to spend time together, Adolescent, we all think we have to, as a physician, responsibility to help them to take some vaccines which are really government of India is giving, we must encourage them to take HPV vaccination, TDAC, hepatitis B, influenza, and MMR vaccines. These are can cause catastrophe in the children because they are not immunized, they can get all these things. The boost the very immune response talk and work on good. Explain values, beliefs, and moral is very, very important. Risk-taking behavior is part of the growth and learning. We have seen so many children dying out of backs or doubting themselves because of this reason. Please let us protect as a family physician. Identify and protect them by this. Emotional upset, most things are very important responsibility of doctors, parents, teachers, mentors is crucial for good behavior, good development in childhood. So necessary. Every time, particularly adolescents between 2 years to 20 years, they become adolescents. One girl looks at the other girl, whether she is tall enough, fair enough, is she obese, is thin, and she will be. All boys want to grow a beard and also long hair. They want to grow updated with appearance like being professors. This is a time of primary and secondary sexual characters develop between these years and rapid increase in height and weight. Those who are in the age muscle mass, strength and endurance. Onset of menstruation in girls and boys deepening in the bodies is sign of their maturity. Acne, body odor, other symptoms are common. They need balanced nutrition, exercise, good hygiene. Let us see emotional support, handle body massage, talk to them personally. Why are you feeling bad? My contact person close, my brother is close, I don't have to cream, I talk. Give them emotional support and talk to parents to give them good support. To do good. This is an important community responsibility for all of us. Though many adolescents are living as they are, there are a fraction of them who are not normal. They are handicapped, differently able adolescents. The area of adolescence is between approximately 10 to 12%. Behavior problems is not poliomyelitis, now polio vaccines given so much, and they are not given proper vaccines. Some of them are also having HIV, post-HIV, and also spasticity, etc. This is also for the parents of survival of children and have these cases contribute to poor or disabled children. We are increasing the mechanism on our level treatment, saving so many lower programs, but not in modern their development is so much different. We will contribute to the pool of handicapped children. It is our duty, community duty, to take care of them. Give them priority when they come here today. Talk to them. This is really, really important. This is very, very important. Adolescent sexual and reproductive health. So education, puberty, menstruation, reproductive, they have to be in the schools. All schools they have this assess nowadays, reproductive health, etc. Prevention of sexual transmitted guidance on the boundaries and respect to now there is what is called a crash. This is why class is called other is called crash. This is where team was and this is our mission. See communication is there and that doctor country health services behind below the hospital activity. So adolescent friendly health services are very, very important. We must do it in our hospitals. Probably IMA Karimnagar have once in a month a clinic for adolescents who have 4-5 dozen clinicians, outpatient and also pediatric assistants and engage them on several aspects of adolescence, including the body, self-esteem, etc. This is an important silent career that is going on. Adolescent sexual abuse, we are seeing emergency medical care is provided by the doctors and no thorough medical examination.
The child and you have a lot of mental stress, discuss so many things. So he has to learn, he has to be taught, he has to be guided. And this is a very important topic about the happiness of Lakshman. He has to know how to be unhappy because he knows only how to be happy. The next comes to me. Thank you, sir. You spoke very well. Sir.
Thank you, Anita and Sai, for the opportunity. So, for both, Sir is our teacher, Mother Ekala Shishis, so Sir is not a direct professor to me. So, we learned a lot from Trishekar Rao, from various forums, IAP, IMA, and all other forums. And Lakshman Kumar, for the past 13 years, has been here, in spite of doing his aims from New Delhi. He has chosen Karimnagar, his hometown, to practice. That should be appreciated. Thank you. Thank you.
Thank you, sir.
And one more thing, sorry. And Lakshman Kumar, I think he is the only pediatrician who is going to see 0 to 18 years. So, understand is a big topic. This is between pediatricians and physicians. So, Sir has taken a name as physician. Probably physician, not a general physician, not a MD physician, in general physician. Thank you.
I asked for famous presentation when I was in Saudi. He was so brilliant, but then I asked him why you were being so brilliant without being anything, but why you opted for preventing? He told me that, Dr. Rao, I don't want to miss any part of the medicine. That's the reason I became brilliant.
Thank you, sir. Please receive chairpersons. Please come on to there to receive your mementos. As Imashika sir told, we are doing adolescent health camps for girls from IMA and Foxy, and we are also educating the adolescent girls regarding sexual abuse, good touch and bad touch. Because innocent adolescent girls, they do not know what is happening, even boys also. So we are regularly organizing camps for adolescent girls from IMA and Foxy. For your kind information, sir. Thank you.
There will be an organization given the campaign backstage. So, Dr. Madhusudan sir will inaugurate this organization campaign and organization pledge by various officers during the those who are free can go to IMA stall for membership drive, and we will start the CM sessions right now because of shortage of time. Over the scientific committees.
I thank Henry Garu, I thank Phil Garu, and Ima Garu for busy last 2 weeks and doing it so well. I thank. I will feel duty if I not tell my thanks and respect towards Lakshman Kumar and his wife, Gayatri.
It is indeed our honor, sir, to have you here.
Shortly we will start the series on explanation.
Imashika sir is participating our operations officer, Dr. Lakshman Kumar sir, with family.
Sir, okay, sir? Sir, ready, sir?
delivered so many orations to the national level and at the state level. Thank you very much, sir, for accepting our invitation to deliver one of the most important. We understand is a very critical stage. All the physicians are there in the background, all the gynecologists, all these super specialists are sitting there. So whatever we give an healthy adult, it is very important to have an healthy adult, to have a best future of this country and best brains must be there for this country. So adolescent care is very emerging now. Thank you very much, sir, once again for accepting my invitation to deliver my most important oration. Thank you very much.
Thank you, Lakshman. All this I could do in my life journey only because of activeness of my wife who could make me do, and I live in her house. She acknowledge me.
I request Indra madam, please on the stage, please. It's my request, madam, please. I know Indra madam also, she has been checked also from so many 20 years. We are almost citizens. Madam, please sit on the stage. Madam, President Garu, President, Madam Osmaru, just we have a photo with them. Mahesh, there is a Mahesh, please come. I request the President and Secretary and Treasurer of IUA to join the registration of Veteran Second Officer and Madam Indra.
Yeah, okay. Satya, sir, please. Okay, madam, please, madam. Is okay, na? Yeah, ready, smile, along smile, please. Sir, double say. Nice.
Thank you all, the doctors who have given prestigious orations today. Now we are round of T20. Now we go for T15. So we are having short and crispy sessions, 19 sessions. Each session will be for 10 minutes. We will be having various one or two questions also. And all the speakers are eminent speakers, and they try to give whatever the message. And the speakers are available always so that you can exchange your knowledge also with them. Now, without this session, I call the first speaker on interventional radiology. What it is? When to call before you cut. So this is the topic. I request the chairpersons Dr. P.D. Kishore sir, Senior Neurosurgeon from Karimnagar, Dr. Jhansi Madam, Gynecologist from Karimnagar, Dr. M. Mallikarjun sir, Senior Pediatrician from Karimnagar, Dr. S. Naveen Kumar sir, Radiologist, President Deshwari Tirumala, Dr. K. Shivakumar sir, Pediatrician from Karimnagar. I invite today's speaker Dr. Khada Veeradin, who is major and he is MD radio diagnosis and is having fellow LSK MRI and is fellow in pancreatic imaging. He is having multiple publications in lot of interventions to his credit and he is having academic qualification of fellow in neuro and vascular intervention radiology from Asian Hospitals in Hyderabad and he has worked in lot of private hospitals like Yeshoma, Medicover, Omega and Adarsha. He is doing lot of newer techniques also in Karimnagar and this is the blessing for us. I request the chairperson to take over and introduce. Thank you, sir. I request the chairperson to call the speaker.
Good afternoon, all. It is a pleasure to introduce speaker
respected seniors, colleagues, and my juniors, welcome everyone. Since it's a pre-lunch session, I will try to be more practical and I will crisp and short. So, to start with, a 31-year-old male, carcinoma presented with profuse oral bleeding, HB dropped to 8. Can this be treated without surgery? Is there a faster, safer option before you cut? Can this stop the bleed? What if I tell you this patient was managed with selective lingual artery embolization? Bleeding stopped immediately. This is not surgery. This is interventional radiology. Stabilize first, treat definitively later. And today I am here to show you when to call IR. So, interventional radiology is a subspecialty of radiology which utilizes a minimally invasive image-guided procedures to diagnose and treat disease in every organ system. It bridges the surgery and medicine. Time is less than 5 mm, 9 out of 10. So these are the various catheters used in the interventional radiology. And these are the worst parts of the interventional radiology: gel foam, which acts as a temporary embolic agent, atmosphere, PVA particles, and coils. Why select IR? Minimally invasive, lower morbidity and mortality, faster recovery, often avoids the major surgery. So, when to call IR? Patient with active bleed on CT angio, IR embolization can be planned. Liver and trauma injury, IR embolization can be done and organ can be preserved. GI bleed, IR embolization. Post-surgical tumor bleed, first IR is the treatment of line. Biliary obstruction, PTBs can be planned. Hydronephrosis, PCL, GI obstruction, self-expandable metallic stents, and treat the obstruction first, treat the cause later. Avoid the surgery. In vascular DVT, thrombolysis and thrombectomy can be planned. Pulmonary thromboembolism, directed therapy, peripheral arterial disease, angioplasty as well as stenting can be planned. AVM vascular malformation embolization can be planned. Restore flow, save limbs, save lives. So why IR matters? Here organ can be preserved, lower morbidity, short hospital stay and repeatability. We can repeat the procedure many times. So golden rule, if it can be treated to a milli or catheter, call IR before you cut. We don't always replace the surgery. We make surgery safer or sometimes unnecessary. So I would like to present some of the real world cases from interventional radiology practice. A 34-year-old female with gestation underwent emergency ASCS for preterm labor. Post-operatively, she developed atonic PPH leading to hemorrhagic shock. Bleeding persisted despite uterotomies and aggressive resuscitation. What next? This patient was done with urinary embolization, and these are the before and after image. As you can see here in before image, there is extravasation of contrast, and after embolization there is no extravasation. So similar 27-year-old female presented with PG bleeding, highly vascular bleed in RPOC, uterine embolization was done. And these are the pre and post images. A 35-year-old female with pressure sicker and bleeding PG, uterine embolization performed safely. As we can see, fibroid over there is highly vascular fibroid. So only the vascularity to the fibroid was knocked off, preserving the uterine artery. It was found that pool rates of pregnancy of 39.4%, live birth 69.2%, and miscarriage of 22% following the uterine artery embolization. The available evidence supports the use of uterine artery as viable management option in seeking to preserve the fertility, those with symptomatic adenomyosis and those with large fibroids. A 8-year-old male elderly presented with displaced femoral neck fracture, prolonged immobilization presenting with proximal neck lowering DVT. Since it was a high risk of pulmonary volume, limited mobility and anticipated challenges with anticoagulant, IVC filter placement was performed and catheter dilated thrombectomy was done. So this is the run showing deployment of the IVC filter and the free flow of the contrast through the IVC filter. This was done recently. And these are the pre and images of the thrombectomy images. So after the thrombectomy, the flow has been restored. Down you can see over here. Coming to the next case, this is our first opening case. A 31-year-old man carcinoma left lateral with profuse bleed, respiratory hematoma, and fungating oral mass. Taken up for emergency superselective lethal artery embolization due to active hemorrhage and clinical instability. Immediate complete bleeding was achieved. So this is the liver artery was cannulated, as you can see over here. And these are the pre and post images. So these are the clinical pictures. This is the pre-clinical picture presented with severe bleeding and large hematoma in the mouth. And immediately after the embolization, unfollow patient image has been taken. So next, 45-year-old male with recurrent hemolysis, bronchial artery embolization was performed. So as you can see, this is the ACBC, intercostal brachial tract, where the intercostal artery arising superiorly. Intercostal artery arising superiorly, and these are laid on the brachial tract. So as you can see, we have embolized the super selective only the bronchial artery was embolized the intercostal artery. So this was a case of pancreatic cancer. This was a case of pancreatic cancer with ISBRT. So internal and external drain was good. Next, coming percutaneous biopsy. If we can see it, we can biopsy it. So percutaneous transgastric biopsy from skin through stomach to the lesion under local anesthesia for deep-seated posterior retroperitoneal lesion. Traditionally, such cases are referred to the higher centers like Hyderabad. But now with the available expertise and imaging support, we are able to perform these advanced procedures here in Karimnagar itself. It's not about where the procedure is done. It's about ensuring the patient gets the right treatment at the right time as well as to home office. So this was a case of percutaneous biopsy done in a 50-year-old female. As you can see here, from the skin, it is passing from the skin through the stomach into the lesion, into the target area. And this came as solid pseudocapillary neoplasm of the pancreas. Another case, a 57-year-old known case of CSI with suspicious neck lesion recently. So percutaneous biopsy was performed, and the biopsy was suggestive of squamous cell carcinoma metastatic. And a 75-year-old female, identical biopsy was taken up. There was a small lesion in the adrenal, so it was super selectively targeted, and the biopsy was taken, which was suggestive of adenocarcinoma. And 73-year-old male known case of urothelial carcinoma. So biotic region was a large, so it's targeted percutaneously, and it was suggestive of positive for malignancy. A 51-year-old female presented with multiple lytic bone lesions for evaluation. So she was taken up for percutaneous bone biopsy, where bone biopsy was performed, and it turned out to be the plasma cell myeloma. So transcranial biopsy, when there is no safe lateral axis or non-free approach a case where the lesion is a prevascular lesion. So we have approached it avoiding the lungs, so directly into the lesion, and the result of this patient was turned to the TB. The treatment was given, the patient responded well. A 50-year-old man with multiple lung nodules. As you can see here, multiple nodules were there, and while performing the percutaneous grafting, there was a pneumothorax. As you can see here, blackish coloration, pneumothorax was present. So on table, pneumothorax was managed, it was aspirated and therefore was infused, and this is the last post image showing no pneumothorax. So complication was handled. So I would like to share some challenging cases. This was a terrified lung nodule adjacent to the pericardium, awaiting the left ventricle. As you can see, there is a small nodule along the heart border. So it was super selectively targeted. As you can see the lead over there. And this was a small para-aortic lymph node. It was small, very small node adjacent to the aorta. It was targeted percutaneously. And various bone lesions like vertebral bone lesions, pelvic bone lesions have targeted. And this was a case of necrotizing pancreatitis. This was a case of necrotizing pancreatitis.
Everything will be alright.
Do years more, Kaja.
I would like to understand few cases. Only few cases are enough. So this was a case of necrotizing pancreatitis. So drain was put and the same access was used for necrotic experiments. And liver tumor ablation. Earlier ablation was considered as an alternative. Now guidelines clearly position it as a first-line curative treatment in early disease. Small lesion research centers will have the best result, and less than 2 centers have best comparable to the surgery. It can be repeated multiple times, alternative to surgery. And a 22-year female with painful cervical pressure, she was diagnosed with ADM, steam phenomenon, digital ischemia. This was the pre-image. And after embolization, these are the post-image. As you can see here, she responded very well after embolization. So, take as an intervention radiologist, we strongly believe in minimally invasive care. Best outcome happens when IR and surgery work together. Not every patient needs a hand. Sometimes the best surgery is no surgery. And is IR. Right patient, right treatment and right time is the goal of the IR. Thank you.
Nice presentation, the great job you are doing is appreciated. Thank you, Dr.
Thank you, Kaja. Taking about radiology is now new to Karimnagar. I think all the Karimnagar doctors will utilize your services because they will create lots of invasive surgeries also. And it is happy that we are working together in Chennai. Thank you. Always.
As an OBG doctor, I feel that you are both selling with the area. Thank you so much.
Thank you.
So, wonderful presentation. It was status and speaker to collect the moment of client's speech. Thanks so much. And now we're going to speak as well.
The next section. Please
And Dr. T.K. Naidu, sir, Professor Naturally of Forensic Medicine from Pratima Institute of Medical Sciences.
Good afternoon, everyone. I welcome the delegates to the dais. Good afternoon, sir and madam. It's honorable to speak here. It's honorable to speak here in front of you. You're spending your valuable time here. And thankful to Balasan sir bringing me from all the way from Madurai to Hyderabad to Delhi Hospital in Karimnagar. Today's topic for discussion is fluid management in critical care. It's a very essential and one of the most challenging and vitals are important to be managed on based on fluid infusion. So first we have to assess the fluid. How much is the loss? How much in each patient, right from the pediatrics, illiterate to the geriatrics, we need to assess the fluid on each condition of the patient. So what are the types of fluids available for us? Right from the normal saline to linear nitrate to half normal saline, colloids and crystalloids, plasma, hydroxy, starch, plastic, albumin, everything. So choice of fluids depends on the nature of the condition of the patient. And also the amount of fluids we given is based on the loss of the fluid. Next slide please. So here the basic physiology is intracellular fluid, extracellular fluid. What is it composed? Two major compartments. Two-thirds of the fluid is present in the intracellular compartment, one-third is found in the extracellular compartment. Extracellular compartment is again divided into interstitial and three-fourths of that is in the extracellular fluid and plasma one-fourth. The 6-4-2 rule percentage of distribution is very important. The total body water is intracellular fluid plus extracellular fluid. Next slide please. So the good eye diagram of the chart above. So total blood volume is 60% of the body weight is 42 liters in the normal adult man of 70 kg. The intracellular fluid compartment is 28 liters, extracellular fluid is 14 liters. And intravascular is 3 liters, extravascular is 9 liters. Interstitial is 10.5 liters, and tank cell is 0.5 liters. These all are very essential for maintaining the body fluids, carrying oxygen into the cells and carrying out the carbon dioxide and waste products out of the cell system. The movement of fluid compartment is hydrostatic pressure and atomic pressure. Effective circulatory volume, that is easier, that is in an artery system, different solutions and expression area. Hypovolemia, normal system is cirrhosis. Again, assessment of fluid status is depends on history, vital signs, status, memory, sleep turbidity, calorie refill. Which normally the measure is these signs. Just auscultate for meditation and proven examination, gastric hydration, and the involvement of the brain. CVP is normally about 4 to 6 centimeters. It's about more than 6 centimeters dilated, urine output. Then the complete cell count, LFT, RFT. The urine is both sodium and decreased in hypovolemia. And others, you can assess the echo in IC diagram and pulmonary catheter. That is normally about 16. That's a great diagram. This is the most voluminous presently in the cells. Less in other fluid, plasma stores in the blood circulation, and the interstitial fluid which carries and maintains the transition. So normal using physiology, all the fluids are present. The clinical parameters, paraclinical parameters, respiration, and diabetes. We mentioned earlier. So class of fluid, balance is like diarrhea, vomiting, blood loss, trauma cases, and other head injury or any other injury fractures commonly encountered in the human system. It is a vector cirrhosis and overdrive is affected in the dehydrated state. Dry and wet space loss. Wet and wet clearly overload. IV fluids covers blood systems and ICU emergency settings and organic matters. Used to maintain effective blood volume, maintain organ perfusion, also dilution of blood. The types of fluids available are crystallized and colloid. Crystallized what we know normally is Indian lactate, normal saline, half normal saline, and half normal saline, and colloids are normally glucose solutions. The chart comparing with the crystallized and colloids. It is readily crystallized are readily available in the ICU and in the OT. It is easy to store and well tolerable by the patient. It has many advantages. Mainly treated for DAs and any cause hypoglycemia, hypertension, treated with fluid in the legal of these finance. So this is a normal chart of the sodium, chloride, potassium, calcium, magnesium, waters, and the osmolality and the pH. Indian lactate, asthma, and sodium chloride are most commonly used in the OTs and ICUs. Critical care. Especially if the patient is not ventilated. Normal saline is it normal? Highest fluid is chloride content. Large rapid volume leads to hyperkalemia, metabolic acidosis. We cannot give more than 2 points of normal saline in any situation. Leads to hypotension, coagulopathy, acute kidney injury. So, globulopathy, so often, and it is GFR. Some studies compare with other slides lower in chlorides. They found an increased surgery complication, acute kidney injury, death among saline dose. Normal saline is the best resuscitation fluid in hypovolemia, especially in perfume, diarrhea, GI loss, metabolic alkalosis. The human argument is in a condition used to the cirrhotic conditions like hypoalbuminemia, very high cost, normally rarely used, used abroad. India also nowadays major metabolism they are using in the ICU. Albumin is equivalent to saline fluid resuscitation, but have beneficial levels in patients with sepsis, bacterial infections. Yes. Hydroxyethyl starch odor filtration used in hypertonic increase acute kidney injury, prevention, coagulopathy, neuropathic patient resuscitation, patient trauma, diagnosis for various diseases. Studies noted that this is also the death, acute injury, kidney injury, vascularization, studies noted that hydroxyethyl starch carry more benefit over the starch. So it's better to use this starch. So we commonly use Indian lactate. It causes very DAC. Exercise of plasma genetics are not used in the US because of the short use of active, expensive also due to rapid extinction in the US as well as the American life. Amount of fluids used, you can usually start diseases. Normally they use the formula 10%, 20%, 40%, 4-to-1 formula. So it depends on the loss of volume in the patient. Nothing over 2 liters of isolate describes the IC as rapid as possible in an attempt to restore the tissue perfusion. Can be managed more than ESS to carry patient not more than 2 liters. Normal requirement is 2 millimoles per kg for 24 hours. Potassium requirement is 1 millimole per kg for 24 hours. Septic shock 30 ml per kg. Average includes 3 liters. So take home message, fluid status, assess the sometimes difficult. There is no gold standard. The normal formula is 4-to-1 formula.
question, sir. It is a very great subject to all the other regarding Mr. Only one simple question. ASA grade of case, taking from the academy, and which fluid you want to start using?
If the patient is fasting for 6 hours, it is not normoglycemic, then better to go for, I would safely use real lactate. Rather than normal saline or DNS, I would safely use RL. So the most safest fluid used in the OT and ICUs. It balances the equal input and output well. So I use RL. If you have any suggestion, please you can guide me.
Hi sir, I want to talk about the critical events right from today. The pain of the abdomen, the low limb, or upper limb, whatever it is, it's a critical event, right? Yes. And the person not having low confidence, single more critical. Why? Because the food and the everything is unlimited. It's affecting our bodies. So I will do whatever it is, assessment, whatever it is we do. We have to be careful about the assessment of the patient. Now, so what else? This is the message. Thank you, sir, for the special for you.
Thank you. And the APK assessment is very important, especially sodium, potassium, and especially resuscitation, cardiac resuscitation. Potassium is more harmful than respiratory acidosis or alkalosis. So you have to balance up free management. Thank you. All the best. Thank you.
So much, sir. So the take-home message for all of us in clinical care is not just about giving fluids, it's about giving the right fluid to the right person at the right time. So knowing about enough is enough. So this is the take-home message of this session. So I request all of you go through the face scan or eye scan. It closes by 3:30. So otherwise you don't get to 20 hours. Thank you. We go for next session. So the next session will be by renowned speaker, Dr. Shailaja Madam, Madam. He is a consultant physician and managing director at Shailaja Hospital, Karimnagar. She did her MBBS in Gandhi Medical College, MCA in Kakia Medical College, and senior residency at MRNH Hyderabad. She also served as district coordinator, RSSBI Karimnagar, treasurer of Indian Society of Hypertension, co-organizing secretary EPICON 2019, and served as vice president at IMA API Ghana. She also had delivered so many speeches at various state conferences and national conferences, and had participated in special areas of interest in cardiology, diabetes, metabolic disorders, and thyroid disorders. I welcome Dr. Shailaja Madam to deliver her speech on vascular diseases from fatty street to plaque culture. I also invite chairperson Dr. Padma Madam, who is a senior physician at Sai Sudha Hospital, Dr. Papa Kailash sir, who is a senior cardiologist at Papa Super Specialty Hospital, Dr. Navina, senior physician at Government General Hospital, and Dr. Vidya Madam, senior pathologist at Vidya Pathology Center, and also she is HOD of Pathology Department at Chandra Medical College.
Please carry on.
A very good afternoon to all of you and respective chairpersons and all the dignitaries on the dais and Dr. Anas.
longer duration of time so that we reach the maximum benefits and reduce the incidence of the atherosclerotic cardiovascular diseases. So we all should remember earlier, lower and longer. So as you can see, the estimated annual percentage change in cardiovascular disease incidence in 204 countries and territories. So one point that we need to remember is most of the affluent you have seen the various stages. So there are some specialized investigations by which we can find the adenoma inside the arteries. So if you have an invasive IVUS, that is intravascular ultrasound, or an OCT guided ultrasounds, if you do, you can find out the adenoma. But we don't generally do it to find just if the patient is having an adenoma inside the artery. And another important thing is you can sometimes find it on a CT coronary angiogram. So once you do a CT coronary angiogram, you can in some cases you can pick up the adenoma which is going in a positive remodeling way. So you can see the lumen is normal, but the plaque is growing abdominally and it is compressing. It will, in future it will compress the lumen, but now it is normal. So when you do a CT-CAG, it may pick up the plaque, which can be seen as a napkin sign. So once you have a lipid lateral fibroadenoma, the thin fibrous sac can let plaque rupture, plaque erosion, or calcified node when the patient is present with CDA or a CAD with an acute ST elevation MI or a non-ST elevation MI, where you are treating the patient. So this is how you can, once there is plaque rupture or any other injury which is causing narrowing of the vessel wall, then we can find out that by our conventional TMA or stress test or your 2D echogram, ECG or a conventional angiogram. So before that, we want to screen the patient to identify the thin-cap fibroadenoma before the rupture occurs using the various risk scores, biomarkers and non-invasive imaging. So what the 2026 ACC guidelines have given us is the various risk factors that we all know traditionally that are associated with ACC. You all know LDL cholesterol, high LDL cholesterol, low HDL and high triglycerides, the component, and hypertension, diabetes, cigarette smoking or tobacco, age, men more than 45 years, women less than more than 55 years. And another important thing that we all forget is a family history of premature ACVD. So whenever we take history, it is prudent for all of us to take the family history, because a strong family history of atherosclerotic cardiovascular disease, men less than 55 years and women less than 65 years, if one of their family members, first degree or second degree relatives, have suffered from a major cardiovascular event, it itself is a major risk factor for this stratification. So obesity again is an important factor, metabolic syndrome and physical inactivity, unhealthy diet and sick age. So what are the normal risk factors or the risk enhancing factors? We have now, these are the risk factors that are recently included in the guidelines. Lipoprotein A levels more than 50 milligrams per deciliter. So essentially, everybody has to undergo a lipoprotein A level checking at least once in their lifetime, and it is mandatory for all more than 40 years of age. That is, once in their lifetime they should get LPA more than 130 milligrams per deciliter is also an important risk factor. And all the inflammatory markers like the HSCRP more than 2 milligrams per liter. Sorry for the inconvenience. I was told that the timer was removed, so I was very slow. Just now they have re-entered the timer for my sake. So we try to finish off fast. So the newer risk enhancing factors, as you all know, as we have to remember it, the raised lipoprotein A levels, which we have to measure at least once in the lifetime after 40 years. And if your traditional risk factors like the LDL cholesterol and is low, but still the patient is suffering from disease, you have to check the FOD levels or the non-HDL cholesterol levels. And guideline that was added was offspring history, which is very important. So any female who has experienced premature menopause, preeclampsia or gestational diabetes during her pregnancy has to be followed regularly for increased risk of atherosclerosis in the future. And another important guideline that was added was a coronary artery calcium score. So this is an important add-on to the newer guidelines. So previously when your cholesterol levels are borderline and you don't know whether to treat the patient, that means the patient is in moderate risk or intermediate risk, you don't know whether to treat the patient or not, you go into the coronary artery calcium scoring. It is non-invasive and there is no usage of contrast for doing coronary artery calcium scoring. And if the calcium score is more than 100 angstrom units, you should definitely treat the patient. So these are the cutoffs that you have to remember. And this is the risk calculator. How to screen the patient is by you have a simple list that you submit to it. The risk level that each patient is going to have. So depending upon the various parameters given in the traditional risk factors, it will divide the patient into low risk, borderline, intermediate and high risk. Low risk is less than 3% risk of having ACVD in the next 10 years. Okay? So it is divided into low, borderline, intermediate and high risk. So you have to first calculate the risk, then personalize the risk. So after calculating, you take the personal history of the patient, if they have any risk enhancing factors, and then reclassify and reassess. So all this we are going to give statin therapy and also to make the patient understand their severe exercise. So it's not that children can take any number of chocolates or any number of sweets. We don't want to eat sweets, give them to our children so that they won't be lazy. It's not like that. So the fat is free, as we have seen, it starts early in the childhood. So you the first universal lipid screening according to the newer guidelines at 9 to 11 years of age. You should get all your children checked at 9 to 11 years of age, and again at 17 to 21 years of age, and repeat regular lipid screening should start at 19 years. And after 19 years, the lipids have to be checked every 5 years to reassess the risk of the patient. And after 30 to 40 years, you will apply the ASCVD prevent calculator and tell them whether they fall in the low risk, borderline risk, intermediate risk or high risk, and start treatment according to their risk. And after 40 or 45 years, you may have to apply the coronary artery calcium scoring also to reassess the risk that the patient is having. And all the patients have to be reassessed every 4 to 6 years. And once you start at 4 weeks of interval to see if you are achieving the target goal of cholesterol, LDL cholesterol that you want to reach. So the target is to reduce the cholesterol to at least 100 milligrams per deciliter, and in medium and high risk patients you have to reduce it to less than 70 and less than 50 milligrams per deciliter. As we have seen, the lower the better. You should get it checked for all the patients, irrespective of their lipid levels. We have low LDL cholesterol, but all the guidelines, and we classify the patient based on the risk factors. So, statin therapy, when you should be statin, and for all high risk and very high risk patients, you have to give high intensity statins for lifelong. And if you are unable to come to the goal, as I told you, we need to recheck at 4 weeks interval and at 3 months interval. If you are unable to achieve the LDL goal that we want to, at the end of these, we need to add along with the statin the estimate or PCSK 9 inhibitors that are the injectable anti-cholesterol drugs that we have, what we call as Repatha or Inclisiran. Injectable Repatha, it can be given at Evolocuna, can be given once in 2 weeks, and this Inclisiran can be given once in 6 weeks, 6 months for high-risk patients to reduce the cholesterol levels. You can see the goals: less than 100, less than 70 and less than 50 for very high-risk patients. So the pharmacotherapy ladder, just angiography or PCSK non-indicated. So other than the CT coronary calcium story, we have the CT coronary angiogram, and you can even have a PET FDG done. The latest PET FDGs can pick up the fibroadenoma as a red spot on the filling, and even the MRIs, even high resolution MRIs can also pick up the type of lesion and edema present around the coronary sort of vessels. And you can do a non-invasive pulse wave velocity or flow-mediated vasodilation test, that is left with internal medial thickness, and the flow-mediated vasodilated test to know the flow inside the arteries. So there are the newer drugs that are upcoming, other than drugs we have told. So the take-home message is atherosclerosis begins as early as infancy. So cumulative LDL exposure over decades drives the ASCVD events. Like you have the what you call the smoking years. So we have the cumulative lipid index. Fat years. The pulmonologist calculate the fat years. So we have now the cumulative lipid index where the fibrous cap, if it is less than 65 micrometers plus large necrotic core, it is responsible for 70% of the ACS events, and cholesterol screening should start at the age of 9 to 11 years, and formal prevent ASCVD risk assessment should begin for all patients from age 30, and prevent equations replace the pooled cohort equations. They are age neutral and include 10-year and 30-year risk, and are better calibrated, and CPR framework. What we have learned just now, calculate, then reassess. So LPS screening, FOB screening, and LDL targets have to be restored, and as we all know, earlier, lower, and longer. Thank you for your
excellent presentation. Madam students, here.
I request all the chairpersons to go on to the right side of the stage for presentation. Thank you, madam. Thank you for your extensive speech. The next speaker is Dr. Rekha Rani, madam, who is a medical director at Rekha IVF and Laparoscopic Center, Karimnagar. She did her MS OBG in Usmania Medical College. She is a medical director at Rekha Sagar IVF and Laparoscopic Center, associate professor at Chandranagram Medical Sciences, done as fertility specialist in Manohari IVF Center, Tirupati for 5 years. Proxy certified advanced laparoscopic training in Sunrise Hospital in 2015. She also did her fellowship in infertility under IMA. She did her master's training in reproductive medicine in Dubai and felicitation as a felicitator. She also did in IMA AMS fellowship courses. I invite Dr. Rekha Rani madam to come on to the dais. I also invite chairpersons, Dr. Radha madam, Dr. Tulsi Reddy madam, Kartika, senior obstetrician and gynecologist and infertility specialist, Dr. Jyoti, senior obstetrician and gynecologist at Vasana Hospital, Karimnagar.
Yeah, okay, ready, madam, smile.
As well as esteemed delegates. Thank you. So let's demystify the IVF journey. So what is demystifying? So an individual couple has a tremendous pressure from society, but the truth is there is no help in the treatment process from the state society. So most of the times when there are doctor friends or relatives, they do come to all the doctors for asking about the treatment options. And I think as physicians and doctors over here, we should know the minimum process of what is fertility treatment. So, and you all should know it's not easy. It's a roller coaster journey, even for the patients as well as an IVF specialist. So why is it a roller coaster journey? Let's see.
See, and the red balls what you are seeing are the eggs in the, in the human body or the human female. You can see it is totally decreasing from 18 to 41. And mind you, the people who present to us for ART techniques are the people above 35 years, where the infertility factor, previously much significance was not given to male infertility, but of late, there is a male factor also. There is a research going on where they show men younger than 40 have a better chance of conceiving. So then comes our ART. What is ART? ART is art of treating the people, but it is assisted reproductive technique. And as you all know, it is not new to our history, Indian history, because many mythological eras have seen that. From the Surya has a virgin using the same divine Marta. So it is nothing but an IUI technique what we do. And also the Pandavas, the Kunti, this is among children from divine father, Surya, Yama, Vayu and Indra. It is nothing but the same IUI because the Pandu is incapable of procreation. So maybe it was so scientifically advanced at that time that the patient was given an option of having IVF. The IVF is also not new because all of you know as a Gandhari, after a long abnormal pregnancy, she gives a lump of flesh and sage Vyasa divides the fetus into 101 fetuses, placing them in the jars, which is then incubated, resulting in the birth of Kauravas. So this is used by scholars as a narrative as IVF and multi-embryo. Just like slicing of embryos, artificial uterus, whatever the advanced techniques what we are now into, it was long back during the Mahabharata era. So this is the artificial uterus which is in Japan, Bulgaria and South Korea, where artificial uterus was made and so many fetuses can be kept in the artificial mythological era, so many hundred babies were born. So again coming to stem cell converting to embryo, all of you know the stem cell, that is there is a believing that through the sweat of God, Hanuman, Nagaraj was born. So here you can see the stem cell converting to embryo. Now we are using each and every cell for converting into an embryo. The research is going on in this generation. So then came, everything vanished, our scientific knowledge, everything went ahead, and then we are again to square one, where after so many research and scientific developments, in 1978, the birth of Louis Brown in the UK has happened. That is only 48 years ago. That means we are very new to the idea. So this is Louis Brown, the first test tube baby. So just followed immediately on October 3rd, 1978, our India has given the first IVF baby. But our officials, our government didn't recognize the source. Actually was shifted into the ophthalmology department and was shifted to India. Okay, so the public perception and ethics, IVF sparked widespread ethical and religious debates about creating God. Many question the safety and morality of creating life outside the womb. Now, the first IVF was done by laparoscopy. Do you believe? It was a very strenuous procedure and the result was very good. Actually, in 10 years, 268 patients underwent IVF with only 5 clinical pregnancies. So, what are the technical challenges? Yeah, the original IVF technique involved in natural ovulation. Early methods required surgical retrieval of the eggs and success rates were extremely low, that is below 10%. So, why that challenge? It was a new technology, it was non-acceptance in the society, difficult for scientists to try new methods, and there was absolutely no support from the government. So, in 1992, the revolution came where ICSI was introduced, that is intracytoplasmic sperm injection. The cryopreservation also came into play, and improved culture media, lab conditions have improved the embryo quality and survival rates. So this is the ICSI, where into the egg cytoplasm, the sperm is the idea of this. So that's such that the IVF success rate improved by late 1990s and the success rate was up to 25 to 30%. So why still that? Because there was like one size fits all. Everybody can't have the same size clothes and everything. Now everything is customized. Even our sofas in our home is customized. So even for this, the patients have to be customized and have to be personalized. Only one drug was there. Now so many drugs are there that no side effects are there at present. So IVF in 2000, refinement happened, personalization happened, PGT means we do genetic testing for the embryo and the salvation rates of the eggs and embryos. And ovarian stimulation became more customized without the side effects, and this is there. No, at present we recommend single embryo transfer because our percentage of pregnancy rates have increased to 50 to 60%. So obviously the obstetric complications also come down with that. So the accessibility and awareness has increased. IVF became more widely available. 10% in 1980 has now come to 40 to 60%. It is because of better embryo quality, genetic testing and single embryo transfer. Still, any treatment we take, everybody gets a result because once we do delivery, we will keep the baby. There is nothing that we just go, we can't do, the baby has not come out. The other plans may develop properly or not, and only few, one or two, will come to a stage where they can give you fluids. So that is IVF. We are nothing but IVF where artificial intelligence, automation, advanced imaging have revolutionized the treatment strategies. Let's see. So there are a lot of automation happening in IVF. Here, there is a time-lapse embryo technique. What is this time-lapse? It is an AI and machine learning where the embryos are taken. This is the time-lapse technology. The embryos are taken. Yeah, the embryos are taking photo every few minutes, and after that it is automated, then done a deep learning, and then got to a stage where which is the best potential embryo will be automated and will be kept in the patient, which can give you best results. So this is one cell. Everybody has developed from this single cell. So this is day 3 embryo, actually day 4 and day 5. Day 5 embryo is called as blastocyst, and blastocyst will give you 50 to 60% of the pregnancy rate. Okay, so a picture is worth 1,000 times. That is the reason the automation gives you this time-lapse technique. We go through all the embryos which are developing, and this is the best embryo which is developing fastly, and we keep that. So this is another automation, artificial intelligence. See, these are the eggs we take from the patient, and each egg has been given some numbers. That is the rating which has been given to the oocyte. And depending upon the rating, usually we decide the best rating oocyte will give you blastocyst, which can give you a proper pregnancy. So much of automation has been happening in IVF industry. Okay, so is there any change in the sperm? Yeah. Once you have labeled an azoospermic patient, can also have an AI-facilitated sperm detection tool in azoospermic sample. So here you can see nanobots. These are the nanobots. This is also an automation AI technology where here you can see that magnetic thing is attached to the tail of the sperm where it takes and guides the sperm into the egg. So this is one of the technology where automation and AI is also revolutionized. Yeah, the another one, boiling technology is there where here the oocyte is calculated and told that whether it will go to blastocyst, whether it can go to lymphoid, and depending upon that we transfer. So initial studies, which we all know, has given less than one oocyte. Do you know? Because most of the times when we say 15 oocytes we got, everybody thinks what is there in 15 oocytes because at the end we get 2 or 3 embryos. But at that time when it was started, it was less than one oocyte, 0.7 oocytes, and 6% pregnancy rate has now come to 8 to 15 oocytes and 40 to 50%. So the other one is emotional role. I think many of the psychiatrists over here agree that our infertility patients' depression rates are about 40 to 50%. It's not
not just about themselves, it's from the husband, it's from their family, it's from the society who doesn't help the woman. So psychological support and destigmatizing infertility is the idea of the art. So many a times I feel bad because many doctors who have undergone IVF also wouldn't say that they are conceived with IVF or IVF. Because that is the type of the height of the destigmatization we have in the society. So that is most important needed. We should encourage the patients who are going for the IVF because if they act early, they get their own biological child rather than acting late where they have to go for a donor research program. So the other one is the financial burden. Is another hindrance for the IVF patient. Because there is very limited insurance coverage in India regarding the IVF. Still, nobody considers IVF as a disease, like infertility as a disease. Recently, WHO has come up that it is a disease. So, limited insurance coverage. So, the other thing is regulation and ethics. Do you think regulation and ethics are needed for IVF? Yeah. Because I will give you two examples. In Guntur and Punjab, there were 70-year couple who conceived with IVF. At one point of time, we think, oh, 70 years getting a children is a very hectic. But within 5 years, the child who was born to a fertility couple has become orphan because the parents died. So is it an ethical practice to give children to older age people? No. That is the reason the rules and ethics have come where the prescribed age is there where we have to formulate all these treatments. Okay? So the ART, it is a bill which was passed in the Lok Sabha and then it became an act. Now we have to do everything according to the ART Act. The guidelines have been done by Indian Council of Medical Research. So what is the future of IVF? As we look ahead, the future of IVF holds exciting possibilities and challenges. Still, emerging technology is there. I think all the medical, this CRISPR technology is a gene editing. The bad gene is taken out and kept the other one so that we are away from it. And then stem cell derived gametes, a non-invasive embryo testing, and robotics and automation. So IVF will become more efficient, accurate and accessible. Automation and AI will further personalize, and global collaboration in fertility research will accelerate the process. Thank you.
So it was like starting from the Buddhas, till the
We travel from Buddha to the modern generation.
And the need of the IVF, like it is not only a disease or it is not limited to the couple or to a family. So it has become a social disease. So the insurance coverage, what we are proposing to the government and insurance companies, so it should come to help the couple to get the IVF treatment.
Actually, we have come a long way from 1978, we are actually the first IVF.
Very well presented, ma'am. You showed the connection and how advanced it is ART. From old, we used to say old is the gold, but now ART is gold in
We
ART.
have to go back to mathematical era to the scientific development at that time.
Very well presented, ma'am. Thank you. Congratulations.
Very well presented, madam. Such an elaborate and all the new upcoming things of ideas was very well explained. Thank you, madam. Thank you for this session. I request all the chairpersons and speakers to go to the right side of the stage for demonstration.
Thank you for giving me this time to talk. Now, what we are facing is the evidence-based medicine. What we are facing is the evidence-based medicine. Then how we can take the example of gynecology, where the evidence if you ask
Yeah, okay, ready, smile.
I thoroughly, if I talk about Ramayana in my medicine, Sangeeta how it we should not speak about mythology.
Okay, ready, okay,
Thank you.
Thank you, sir. Now we move on to our next talk. I would like to invite Dr. Shamini onto the dais. She will be talking on relationships in pregnancy. Dr. Shamini is a consultant nephrologist at Sunrise Hospitals and has previously served as a consultant at Apollo Hospitals. She completed her DM in nephrology from Osmania Medical College, Hyderabad, and is a proud gold medalist. She further advanced her training as a Global Fellow and is an active member of the Hyderabad Metropolitan and a member of International Society of Nephrology. Her academic journey is marked by excellence, having received the Kerala University Gold Medal and the third Youngest Power Award and recognition of the best outgoing student of Osmania Medical College. She has also been honored awards for her research, including ISAC Thesis Award and International Award in Acute Kidney Injury Research. She has contributed extensively to research with multiple international publications and presentations at the World Congress of Nephrology and the over 10 publications in national and international journals. I would also like to invite respected chairpersons, Dr. Subhani Krishnamurthy sir, renowned urologist from Krishnaswami Hospital, Karimnagar. Dr. Sandeep Reddy sir, senior nephrologist, Adarsh Hospitals. Dr. Srinivas Kumar, senior post-graduate. I request Shamini to come on to the dais and
Good afternoon, everyone. Thank you for giving me this great opportunity. So today I am going to discuss about renal diseases in pregnancy. Currently I am working as a consultant nephrologist at Sunrise Hospital, Karimnagar. So we are seeing so many complicated pregnancies. I am not going to take much time on physiology and all. I will be briefly discussing on cases. So what happens in renal pregnancies, the kidney size increases up to 30% and increased renal plasma flow exceeds GFR. So by early as early as 4 weeks, the vasodilatation is seen and the RAS is also getting activated. So even renin is released from ovaries, not only from kidney, it is also released from ovaries. So all these causes increased uteroplacental flow, blood flow, and also there is excess absorption of sodium and water, and also there is decreased osmolality. So what are the disorders? So there is so much of uteroplacental flow, nicely the blood flowing into the placenta, giving all nutrition to the child. So what are the diseases? Why? Because we see hypertensive disorders in pregnancy, mainly decreased, secondary decreased uteroplacental blood flow. So primarily, mostly we encounter preeclampsia, superimposed preeclampsia, gestational hypertension and chronic hypertension. According to ECOG guidelines, so it is defined as more than 140 by 90 mmHg on 2 occasions in 4 hours apart is defined as hypertension. So these are the main 4 hypertensive disorders in pregnancy. So chronic hypertension is defined as hypertension before 20 weeks and all preeclampsia, superimposed, gestational are after 20 weeks. So these are the hypertensive disorders and preeclampsia comes with proteinuria. So today I want to emphasize on the main part is don't neglect every pregnancy or every preeclampsia as preeclampsia. Here is complement disorders, so I'm directly going into the cases. So 26-year-old female presented with severe, was very reduced urine output and HB was 3. So when she came, so she was delivered in the peripheral center at 36 weeks. She was teaching by herself. She had 1 day of abdominal pain and they went to clinic and they said we have to deliver. So after delivery, she had severe PPH and they transferred 3 PCVs and also after coming here, there was severe pleural effusions and decreased urine output. Because of overload and high creatinine, we had to do 3 sessions of dialysis along with PCV. So the fish is, even after 3 PCV transfusion, her HB was still low. It was only 4.5. So then we had to do further investigations. So after doing further investigations, we came to know that there is an ongoing hemolysis. So we had sent the LDH levels, which was severely high, that was 4,800, and cystocytes were present, retic count was high, and there was thrombocytopenia. So we had sent for ANA profile, which was negative, but there was low C3 levels. Then again we came to a dilemma. So what we should do? So we kept all these diagnoses, differential diagnosis, health syndrome or TTP or HUS or AFLP or whether it could be a CATS or APS. So we came to a diagnosis of atypical HUS. I'm going to discuss how we have to differentiate preeclampsia, health syndrome and atypical HUS and TTP. So this is the main differentiating factors. So usually we think of health syndrome in pregnancy, postpartum or during peripartum period when there is an API, we think of health syndrome. But the health syndrome, it becomes better after delivery. And atypical HUS, it worsens after delivery. And there is severe API in atypical HUS. And TTP, it usually presents with CNS symptoms like seizures and fever, multisystemic features. In HUS, it presents mainly with renal failure. So in our patient, it was severe renal failure. The creatinine went up to 7, urea went up to 200. So what is atypical HUS? So atypical HUS is a rare, life-threatening disease causing uncontrolled complement system activation. So the complements are released into the blood uncontrollably, which lead into tiny blood clots. So, which is causing thrombotic microangiopathy, entering all the vital organs and causing present as early as day 1 after birth, and it can be seen up to 83 or 80 years of age. Usually we see in children before 2 years. So in our patient, there was CFH antibody positive. So what we did, the drug of choice is eculizumab here, but it is very costly and because of its unavailability in our state, so we have to go with therapeutic plasma exchanges. So we have done 5 sessions of plasma exchanges and also alternative dialysis, and we had started the patient on a small dose of steroid as we got CFH antibody positive. So we had to go with this, and as of now our mainstay of treatment remains therapy plasma exchange because of the cost of drug. So coming to second case, that is nephrotic syndrome in pregnancy. So again it's a primary presenting with proteinuria and pedioedema and hypertension. Here the creatinine was 1.2, but severe proteinuria was there, nephrotic range, 1 per kg, but there was persistent proteinuria, so we had to go for higher drug, that is immunosuppressive drug. So we started the patient on azathioprine 50 mg BD because it is safe in pregnancy. We can also plan for tacrolimus, and also we have to supplement with aspirin, calcium supplements, and low-dose steroids. So, as after starting steroid and azathioprine, the proteinuria responded well initially, and it is reduced to 1 gram per day. As term approach, in 9 months, that is 37 and 36 weeks of pregnancy, again she presented with hypertension, severe SOD, grade 3, grade 4 SOD, and there was 8 grams of proteinuria. So immediately we had to call for delivery. So C-section was done, and held an active child delivered with 2.8 kgs. After delivery, the proteinuria was reduced to 2 grams, and the patient was on steroid and azathioprine continuously. And after 3 months of postpartum, the renal biopsy was done, which revealed lupus nephritis, stage 3, with hypertension, nephropathy, with arteritis. So here, she was a primary, and she never had history of lupus nephritis or SCD or cutaneous features or anything. So the pregnancy itself is a risk factor. It can present as lupus nephritis for the first time in pregnancy. So don't neglect it as a preeclampsia and work for lupus nephritis also. As it can present for the first time in pregnancy. What are the warning signs? So we have to look for foamy urine, hematuria, high blood pressure, frequent urination, extreme fatigue, extreme weakness, and edema. So what are the challenges in lupus nephritis? So it can present as preeclampsia or pregnancy loss, intrauterine growth retardation, and neonatal lupus. So how we can take care during pregnancy? So how we have to take care that is kidney related in pregnancy. So all the patients should be started on HCQs and start with steroid. Initially start with pulse dose therapy, that is methyl-prednisolone, then later reduce to 0.5 mg per kg, and you can start on azathioprine if it is required or if the steroid is not enough, and also the tacrolimus is safe, but avoid cyclophosphamide and rituximab. Still, even after starting all these things, there is no response, then go for therapeutic abortion. This is the third case I am going to present, that the patient, 26-year-old female, she never had history of CKD as such. So she had only history of kidney stone and operation for that. So this is the last case. So she presented for the first time with high creatinine, anemia, and that is serum creatinine was 9, India was 160, and there was showing small kidney, that's it. Only later small kidney was there. So we have to initiate her on dialysis as she wanted to go on with the pregnancy. She don't want to get aborted. So we started her on dialysis, and we went up to 32 weeks. After 32 weeks, we delivered 1.5 kg child, which is active and healthy at present. So why it is important is effect of pregnancy on kidney disease. So it can worsen the kidney failure. The pregnancy itself is a precipitating factor. It can worsen the kidney failure, and it can cause hypertension. It can cause preeclampsia. What are the kidney effects on pregnancy? It will cause usually kidney disease patients will have infertility, and they will have early abortions or IUGR or preeclampsia and polyhydramnios. In our patient, she had only one history of stone, which caused her CKD and precipitated during pregnancy, which made her to start on dialysis. So what is the role of obstetrician here? So identify those cases and prevent preterm birth, prevent regular fetal monitoring is necessary. Always use corticosteroids, indomethacin, calcium channel blocker, check umbilical artery Doppler, and issues in CKD patients in pregnancy. So surgery is advised and you can deliver at term at 38 weeks. So all of nephrologists maintain BP and you can go for delivery at term. But supplement with calcium, phosphate and check for antihypertensive contraindications are AC inhibitors and ARBs. So we can do dialysis, increased dialysis that is more than 20 hours per week. So as dialysis hours are increased, the pregnancy outcomes are better according to the studies. These are the low flux dialysis we have to do. Heparin you can use in pregnancy. Take care of anemia. Postpartum you can feed. AC inhibitors you can restart postpartum. So these are the measures you have to take. Thank you.
Since lack of time, you are avoiding questions. Thank you, Chandni, for a lucid presentation.
Thank you, Dr. Chandni, for an excellent case-based discussion. Thank you, Krishnamurti sir, Sandeep sir, Sunatya madam for chairing the session. I request speaker and chairpersons go for the felicitation.
My dear friends, ఒకప్పుడు కొన్ని రకాల చదువుకుంటాయి డాక్టర్ వినయ్ కుమార్ గారిని నేను రిక్వెస్ట్ చేసుకొని మా కోడలు చనిపోయిపోతున్నా అని డాక్టర్ ఏకరాణి గారి స్పీచ్ పెట్టించుకున్నాను. సారీ I request Dr. Vinay Kumar Kamal to deliver his lecture. He is very long. He is from my close place and he was very friend to me for last 25 years. He has conducted lectures in European students also. I was a chairperson once also in the past, but I almost forgot you. Now just I came to know we have done a little bit mistake about him. Please forgive us, sir.
Because we are not sure the next of details also. That's the reason this but luckily the confirmation has come. Thank you.
Thank you, sir. Sorry, sir. Sorry for the delay. Dr. Asuri Vinay Kumar. Sir is Professor and HOD Department of Pulmonary Medicine, Chalmana Anandra Institute of Medical Sciences, Karimnagar. He is a consultant pulmonologist for interventions, critical care and sleep medicine at Surya Church Hospital. Sir did his MBBS from KFC Warangal, MD Pulmonary Medicine from Usmania Medical College. Sir is BRTT and RPSGT certified. Sir did many clinical trials and has many publications in the index journals. Sir has been examiner for MD and DMD students since 2012, faculty at NACOM from 2005 till date. Sir has been playing a key role in the organization of TGTCCOL. Sir is the chairperson in international, national and regional pulmonary meets on various topics in recent advances of pulmonary medicine, tuberculosis, sleep medicine and critical care. I request chairpersons to come on to the dais. Dr. C.M. Professor of the Department of Pulmonary Medicine, Cme Institute of Medical Sciences. Dr. K.V. Ramesh sir, District TV Officer, Karimnagar. Dr. Rajkumar sir, pulmonologist at Lalita Church Hospital. Dr. Sulata Garu, pulmonologist at JKR Government Medical College.
box complete close the bed box level to long bed. आप इनका आप long waiting.
Very good afternoon. I thank you very much for the introduction and for the opportunity. I would like to express my sincere gratitude to our IIT President, Shailaja Ma'am, and my staff and team, and distinguished chairpersons, and my dear senior colleagues, juniors and students. So, post-lens and obstructive sleep apnea. So, a tough combination. So, it will test our patients as well as our audience here. So, as you are aware and more knowledge about obstructive sleep apnea, many thought it was uncommon, but surprisingly, at given point of time, about 1 billion people are suffering from obstructive sleep apnea worldwide. So, and it is a dangerous disease, as Shailaja Madam was talking about cardiovascular risk and cerebrovascular and metabolic complications as OSCI is associated with. So, as you know, one of the famous personalities and music composer, Bhakti Lahari, and in our neighborhood, Chakri, who died in sleep because of this sleep apnea. And tragic accidents, many we have witnessed it. Though problem is we don't have proper legislation in India, whereas in Western world there is a clear-cut legislation regarding sleep certification before, especially for high-risk jobs like driving. And societal problems, marital problems. So, as Indians, many we may not come forward to discuss sleep-related issues publicly, but in the Western world, it is a quite common thing, especially celebrities like Cameron Diaz. She came up with a public proponent concept of sleep divorce. That is, ideally, if you don't want to get adjust, sleep better, sleep in another room. So, of course, many people may not come out with this, but it is happening even in our part of the world also. Yeah. So what is sleep apnea? As you know, as we go into sleep, our body also goes into sleep, our airway is also relaxed. So in healthy individuals, otherwise the patency of airway is maintained and airflow continues to happen in and out. But in individuals who are susceptible, so airway tends to collapse either partially or completely, resulting in hypoxia, hyperapnea, and sometimes repeated arousals will result in disturbance in the sleep. Ultimately, there will be sympathetic overactivation, daytime symptoms like excessive daytime sleepiness, and many things will disrupt our sleep. So, I would like to present some of the history, how it has evolved. In the famous Charles Dickens novel, the character Joe, you might have heard about it, that specific clinical picture was described. Since then, in the early days, patients who are obese, hypersomnolent, because the hypercapnia was thought to be the reason for excessive daytime sleepiness. But later on, once the polysomnography has come into the picture, so it was then the repeated sleep interruption were thought to be the reason for excessive daytime sleepiness. So since then, many studies have come. Polysomnography has refined, the flow channels were introduced, then full polysomnography was coming to the picture. In 1981, the Sullivan, Australian scientist, who has come up with the treatment modality called positive airway pressure. Since then, there were a lot of devices have come. And in early part of the 1980s, one of the largest randomized population-based studies done, that is Wisconsin and American Heart Health Study, so which have clearly shown the risk of obstructive sleep apnea. Since then, there are a lot of papers have come into the picture, realizing that sleep is a very important component. But as the diagnostic procedures like polysomnography was available in very few centers, so later on, minimal complex models like home sleep apnea testing models have come into the picture. So these are a few of the studies since 1980 till recently. Among them, as I told you, the Young et al. Who has done this Wisconsin and American Heart Health study, which has clearly shown the prevalence of obstructive sleep apnea is quite high, especially if you look at the bottom line. So 24% of men and 9% of women were the sufferers of this obstructive sleep apnea. When you extrapolate these results, about 936 million people worldwide with mild to severe obstructive sleep apnea and about 425 million people with moderate to severe sleep apnea are suffering. The same study has shown that about an average 18% of the individuals, that is about 1 in 4 males and 1 in 10 females are the sufferers of obstructive sleep apnea. That is the complexity of the problem, that is the burden of the problem. So since then there were many Indian as well as Asian studies have come. Among them, one of the population-based study, the bottom line, which was done in the Delhi, it's by Suri et al. They have further categorized the risk in various age groups, especially if you look at the Indian pediatric age group also, it is quite common. And almost in male child and female child, it is almost equal. But when it comes to the reproductive age group, it is predominantly males are the affected, whereas in females, it is the reproductive hormones having a protection effect. When it comes to the post-menopausal age, the incidence, the prevalence is almost same, both in males and females. Whereas when you extrapolate the same results to the Indians, about 104 million Indians of working age group are the sufferers, whereas moderate to severe apnea, about 47 million Indians are suffering from this. This is an interesting observation which was published in European Respiratory Journal. So I would like to add a note on this specifically. So this is a general population sample survey. So they have done in a normal population. So this was done in Iceland. So this was based on type 3 study, a questionnaire and psychomotor vigilance test. So what they observed is about 15 to 20% of general population had moderate to severe undetected obstructive sleep apnea without any symptoms. That means the burden of the disease in general population who are not presenting any symptomology is quite high. So that is the reason we need to develop more and more screening tools, and many times patients may not come to you with as if sir, I am having obstructive sleep apnea, please test me. You will not come like that. Many times the symptomology is vague. So if you look at the cardiovascular, cerebrovascular, metabolic problems, the odds of having even without symptoms, especially in routine, commonly day-to-day problems, if you look at these issues, the odds of having obstructive sleep apnea in a simple hypertension is about 30 to 60%. Likewise, in drug-resistant hypertension, patient who is using more than 3 drugs, it is approximately 90%. That means almost every hypertension patient needs to be screened. And likewise, the cardiovascular diseases, stroke, arrhythmias, very, very important components in our practice. So one has to give a special attention to these problems. So as I am talking, it is a quite common problem and still it is under-recognized and under-diagnosed. Why it is under-recognized, under-diagnosed? Many times, so unwitnessed symptoms. Of course, in our part of the world, it is quite common to sleep together as a family, but majority of the Western world, people will sleep separately. So many times these symptoms were ignored. The symptoms were not known for themselves. So unless otherwise it is observed. So many times we tend to miss the symptoms. Likewise, subcutaneous symptoms. Many times, especially females, they may present with simple fatigue, simple body pain, simple headache. So for which we do not understand that there is obstructive sleep apnea or not. Likewise, in our medical schools, there was very little attention was given to sleep studies and very little attention was given for our curriculum. So this needs to be understood. Likewise, preconceived type of body. We think only obese people will have obstructive sleep apnea. That is wrong. So there are different phenotypes where we need to consider, we need to screen other individuals as well. So this is obstructive sleep apnea cycle, it's a vicious cycle. So why do we need to treat obstructive sleep apnea? So there are a lot of systemic complications associated with the negative intrathoracic pressures, resulting in infrared left ventricular filling, the hypoxia, hypercapnia, which will result in sympathetic overstimulation, resulting in persisting daytime sympathetic activity. Likewise, free radical damage, resulting in endothelial damage and increased blood pressure. These are all consequences of not treating obstructive sleep apnea. So what are the risk factors? So these are common and quite well known to many individuals like obesity, neck size, gender, genetic factors, upper area obstruction. So there are other phenotypes as well in addition to the routine risk factors. We need to look at the other phenotypes like high lobe gain and poor muscle responsiveness, low arousal pressure. So as I told you, one has to keep these things in mind before evaluating the obstructive sleep apnea. So what are the common presentations? So patient usually present with loud snoring, witnessed apneas, especially by the bed partners, and nocturnal awakening, nocturnia, and nocturnal sweating, unrefreshing sleep. So we like to let us understand the diagnostic part. So important is to look at the physical examination. So usually patients are obese and high blood pressure is a common observation, and neck circumference, and look for craniofacial features and examine for macroglassia, tonsils, hypertrophy, other anatomical problems. There are certain screening tools like Epworth sleepiness tool, where we will assess the sleepiness in different circumstances, thereby understanding the severity of the obstructive sleep apnea. And most commonly used screening tools are very much simplified, like Stockband questionnaire and multivariable apnea prediction index and Vernier questionnaires. These are commonly used in our practice, which is very simple. And the Stockband questionnaire stands for S for snoring, T for 5 days, O for observed events, observed apneic events, P for blood pressure, high blood pressure, B for body mass index over 35, and A for age over 50, N for neck circumference, and G for gender. So here score, each has given score of 1, and score above 2 is abnormal and above 4 is moderate to severe risk. Now nowadays we have a lot of wearables coming to the market, smart watches and mobiles, even they are recording the sleep patterns. While some algorithms, though they are predictors of obstructive sleep apnea, but diagnostically we need to again depend on the full-fledged studies like polysomnography. So there are some comparisons of Samsung Galaxy Watch to Apple Watch. So these devices have a very good agreement with the polysomnography, and sensitivity is up to 60%. Same thing with IP watch, because they are in the market for quite some time. So which will assess the sleep patterns day and night patterns by the accelerometry and light sensors. Now let us come to the most commonly done investigations in our setup. So the gold standard investigation is polysomnography. Of course, we have other investigations like anatomical to understand anatomical and functional imaging of the behavior, like DICE, that is drug-induced sleep endoscopy, dynamic MRI, and other radiological investigations. So among them, polysomnography, as I told you, is a gold investigation. Polysomnography is nothing but it records the sleep by EEG, and it records the respiratory effort by chest and abdominal wall movements, and it records the airflow by oronasal sensors as well as the pulse oximetry, which is a comprehensive investigation. So one has to undergo for a proper diagnosis polysomnography. So there are different complexities of polysomnography depending on the number of sensors we use, like level 1, level 2, level 3 and level 4 studies. So among them, level 1 is the gold standard. As I told you, this is not only diagnosis of sleep-related breathing disorders. Of course, there are other sleep-related disorders like hypersomnia, parasomnia, insomnia. So differentiate them from other sleep disorders. So that is why it is a gold standard, but it requires overnight monitoring by technician assistant, which is a quite laborious one. Very few centers are having such a level 1 lab. That is the reason it is difficult to screen more and more people. Thereby we have other simple, less complex investigations like home sleep apnea testing devices, where we can use even with the simple training, so where it doesn't record sleep, but of course it is useful in high probable, less complicated, uncomplicated obstructive sleep apnea cases. If you have a comorbid, if you feel that it is complicated, level 1 is the best investigation. And of course, as we have witnessed COVID pandemic, everyone is well versed with pulse oximetry. So even pulse oximetry also requires overnight saturations, desaturations, which gives an important information like a screening tool. So it is easy to understand. It helps as a screening tool. So the typical, after looking up, the typical pulsonometry patient looks like this. The typical plot where obstructive events, where the red mark shows the flow is stopped for more than 10 seconds and still respiratory efforts were seen. The green. So this is the reporting format where we will be recording the various parameters, the sleep time, sleep onset, total sleep duration, different sleep stages, and apnea, hypopnea index, and at different body position and desaturation index. So what treatments we have? So we have various treatments, the properly tested, time tested, and evidence-based. Presently we have FAB devices, that is positive airway pressure. Among them, CPAP is the most popular and simpler device. Of course, we have various other surgical and other medical management. Let me go through one by one in simple slides. So, what happens in positive airway pressure CPAP device? So, by applying an interface, that is face mask or nasal mask, or CPAP device delivers the air at some amount of pressure. So thereby it springs open the airway, thereby maintaining the ventilation. I am completing. So there are other models of treatment like lifestyle changes. As you know, the 1% weight reduction results in 3% reduction in AHA. So this is one of the important trial. Now everyone is, of course, is Mohenjo-daro treatment. So in 2024, NEGM has published it, and USFDA has given approval for Mohenjo-daro for moderate to severe obstructive sleep apnea patients and for obesity. So this is there's a famous SURMOUNT trial where they have compared patients who are not using CPAP, patients who are using CPAP, and they have compared patients who are named CPAP with the Mohenjo-daro versus placebo. There is significant mean reduction of AHA of 25.3, and about 43% of the participants have shown resolution of their symptoms, that is AHA less than 5. Likewise, patients who are using CPAP and tetrapathide versus placebo, and still there is a greater reduction of AHA and greater reduction of obesity. So from there, therefore, it has a very significant role to play, especially in obese type of sleep apnea patients. Of course, there are other devices like mandibular advanced devices or mild to moderate or obstructive sleep apnea where the mandible is pushed forward, thereby opening the airway. Likewise, tongue retractor devices. Likewise, so hypoglossal nerve stimulation is an implantable device, especially patients who are intolerant to CPAP. This can be done. Simple positional therapy. As you know, in the supine position, body will relax. There is a tendency for collapsibility of airways is greater. In mild to moderate obstructive sleep apnea, even a change of position will reduce the AHA. Of course, there are other devices like VPAP devices, INAP devices, and even myofunctional therapy. Exercise of upper airway muscles will help to an extent. So, of course, my VT colleagues will help you with the surgeries in specific indications. Among them, popular surgeries, of course, ovuloparopharyngoplasty. There are medications which will help improve the symptoms. I would like to present last slide. This is the umbrella study of all the treatments so far I have explained. So there are multiple randomized controlled trials were plotted in the forest floor. So they were compared individually and in combination and in isolation. As you know, a line was seen left to the line. When the results are close to the midlines, they are insignificant. If they are away from the midline, they are significant. Among all the treatments, if you look at the treatment option, CPAP is the best option. Next is lifestyle changes. Next is other devices. Next is when in combination of lifestyle changes. So I would like to end with the last slide. So obstructive sleep apnea is a common problem. One should not ignore. And it is, if you don't take, it is a dangerous problem. Like I told you, cardiovascular complications are quite high. And it is easily recognized. If you give an insight, it is easily recognized and it is a treatable condition. Remember, it is a treatable condition. Thank you.
Thank you, sir. Thank you so much. It was very clear and detailed about CPAP. Thank you, sir. I request chairpersons and speakers to go to the right side of the stage for further felicitation. Now, I would like to invite Dr. Bangaraswamy sir, who needs no introduction in the field of orthopedics. He completed his MS in orthopedics. He is a gold medalist from the University of Health Sciences 2002, and he did his fellowship in spine surgery in the Department of Neurosurgery in LIMS in 2004, and he also did fellowship in total joint replacement at Trinity Institute of
Okay, madam, please cover it.
He did his MC and fellowship in microspine surgery at Ganga Hospital.
Okay, madam, please.
Fellowship in total joint orthopedy in Germany under World Neurosurgery Organization.
Okay, ready? Final one, please cover it.
In Switzerland under the guidance of Dr. Chen in 2025. Thank you, sir. Thank you for being speaker for today's session. I also invite PDK Kishore sir, who is a senior neurosurgeon from Bhadrakali Hospital Neuro and Trauma Care Center. Dr. Prashant, senior general surgeon from Abhinasha Hospital. Dr. Anil, assistant professor in the Department of Ortho from Pratima Medical College. Dr. Ramu, professor in Department of Ortho at Chandra Mandal Medical College, to chair the session. Hello. Let us congratulate Dr. Bangaraswamy for becoming state president for Orthopedic Association. And small felicitation from our IMA, and he is a platinum donator for this conference. Thank you, sir. And congratulations, the Kishore sir and Bangaraswamy are going to become relatives because Kishore sir's daughter is going to be daughter-in-law to Bangaraswamy. Thank you.
Light them, light them.
IQ, they enter in medicine, and slowly what happened? The complications, whenever they see some cases are in death, the complications shift their confidence and they become dull. And failures question their identity, shall I practice or not? And system challenges our ethics and patience will challenge us. Not every surgeon ends in success. A good surgeon, every time not getting success, not every effort gets recognized. And this is what the situation now in the society. This is not a theory, this is an actual example of our seniors and myself also. And real stories, these are not statistics. This is real what actually happening now. Choose and one Dr. couple who were married because of love and they ended their marriage life because of complete failure in practice or failure in financial aspects. And many doctors fight to leave the other profession because they think that there is no progress if they continue this because the challenges in daily practice in private sector is very, very hard. And skilled surgeons, I've seen many surgeons, my seniors, my juniors and my colleagues also, they are operating in small private hospitals, though they are very skilled, they are operating in small private hospitals under very much limited conditions. This is happening why? This is because of not visible to the society. When you are not visible to the society, skill without visibility will become obsolete, will become absolutely invisible. So whatever you are doing, you have to be visible to the society. That is most important now. As of now, with this slide, everybody think that the private practice is there. So I don't want juniors to come into medical field. No, this is absolutely wrong. Medical field is not dead. Medical practice, private practice has been transformed. We have to adapt to it. Otherwise, we will disappear very soon. So when I come to Karimnagar in 2002, there was the golden era. Doctor was a brand. There was a lot of patient and doctor-patient trust was very high. And when a person is having skills, 100% success will be there. A surgeon or a physician, when he is successfully good clinician, that success almost followed immediately. It was an instantaneous practice. It was like a high peak within 1 month. Private practice used to become busy, not having time to have lunch and dinner and have spent time with families. And at that time, the RPs used to depend on doctors. Sir, I'm so and so, please support me, my patient, take care of my patient. They used to come to hospital and stay in the line for hours together. Now you know the tendency of RPs, what they are doing. The marketing is very, very minimal. The doctor was the brand at that time. Now what's happening now? They are, when my wife joined the next era, the challenges started coming. The rapid increase in hospitals around small towns, and more specialist doctors has come in inside. Before that, there were the general surgeon, orthopedic surgeon, and gynecologist, obstetrician. Now this era, the super specialist doctor like neurosurgeons, neurologists, or urologists, nephrologists, all the specialty doctors have started coming into our pool because they have to practice in the locality. There is no other room because they belong to this area. So we have to accommodate them. And at the same time, corporate hospitals are emerging. At this stage, the non-medical hospitals, the non-medical hospitals, the main is hospital, private hospital business, private hospital healthcare, and organized business. You know how private hospitals managed by non-medical persons, how they organize it. And at this stage, it is not only enough. You need marketing. That is very, very important. Now the doctors started asking the RLP, please send me cases. This is the situation where I am in 2000 up to 2018. So slowly what happened? Slowly the corporates, they started looking at district headquarters because the competition in Hyderabad was very, very high and they want to have a chain of hospitals in district headquarters so that their revenues, their intention is more than, rather than, healthcare, they want to see at the top line revenues. That is very, very important for any corporate hospital. Even now in a time I am looking at my top line, what is my top line, whether I am performing positively or not, shall I stop, where to start, what to do. These things are everyday battlefield in the private sector. Because of corporatization of hospitals, high infrastructure competition, one doctor comes next step. He has to get it, otherwise people will not go with him. So automatically he has to get into a lot of loans and gets nowadays the healthcare, most of the share is being taken by out of the revenues, most of the share is taken by the instrument and implant companies, not the doctors. And the referral pattern also changed. The COVID has changed few things. The patient has been bankrupted, most of the money has flown out, and COVID has not actually changed the healthcare. In fact, it has accelerated the change in healthcare system. We have to adapt to it. So the current situation, I've seen many people, marketing preparers keep coming. Sir, OPD is falling in many hospitals, IPD is falling in many hospitals. Why this is happening? Too many hospitals in the same area, corporate outreach marketing, social media influence, different systems, and because of daycare surgeries and cost conscious patients, fear of hospitalization, moreover, even the government schemes and the private insurance schemes, they want the patient to get out of the hospital by third day. Even the surgeons are on that to control the cost of the hospital. So automatically the IP will get down. Initially when I was there in 2002, I used to reserve a patient on 8th day or 10th day after switching over. This is no more practice. On third day, the patient has to get out of the hospital. And earlier, now the situation has reversed. Earlier the patient used to search for the doctors. Now the doctor has to search for the patients. Doing marketing and getting into all kinds of marketing. So the great practice, the hospitals which are dependent on insurances, government healthcare schemes, lot of risks. And many insurance companies, even Dr. Rajkumar is fighting for that, and CMC is fighting for it to have a hospital rack rates for insurance companies. It is not happening. All the insurance companies, they gather, they become a team, and they are giving a very small package for all the private hospitals, which is very normal, just 5% more than the RFSC BPL patient schemes. We have to treat today and wait for money to come for months and years together, and you have 10% of below poverty line patients. Those poor patients were having below poverty line. This scheme started for that. Now slowly it has expanded to 80% of the population, and that has become the standard of that BPL scheme price has become the standard care and standard pricing for all kinds of patients. Imagine, can you deliver a good quality care such schemes? So because of that, the hospitals, there is a lot of impact on hospitals, hospital enterprise treatments, and rising operational costs, financial strain. Because of poor quality, there are many complications in the patient, especially in surgical patients. So these patients have to go to the regular or spend a lot of money to 5 times than the initial money. And the doctors are overloaded. They are paid very less amount. I have seen my colleagues operating. I was surprised. He was telling they are paying just to the factor for a knee surgical implantation. This is really very bad. Guarantee gets 15,000 rupees, and orthopedics will get 3.5,000 rupees. This is really unfair. And the welfare pricing becomes universal pricing. The pricing which is started for the BPL patient has become universal pricing for all the patients, and the quality and the sustainability definitely suffer together. We cannot deliver good quality care. The commission system, not always patient goes to the best doctor. The R&D diverged into a place where they give 70% commission. Patient becomes a transaction, no more, healthcare commodity, they become healthcare commodities. And rumors has become, this I have heard, and this happened in the past, that the agents, they spread rumors about you, that a good doctor is very sick, he is not operating today, doctor has serious illness, maybe sometimes they are actually suffering with AIDS also, doctor weekend after COVID, is no more operating, and doctor will be brought for treatment of bad disease, and his surgeries are failing, and many patients are getting into complications. Fear, before the patient comes to your clinic, the fear is implanted into the patient. So once that fear is implanted into the patient, he will never come to our hospital again. And who are the sufferers with this? Who are the real
the skilled surgeon or a physician, but who is not marketing. Is skilled but not marketing. Focus on patient care, but not on networks, sitting on non-networks, and believe in outcomes, not on commissions, and excluded these kinds of physician surgeons are excluded from the society due to lack of, not due to lack of skill, but due to lack of, not to interested in the play game. The silent casualty of ethical doctors is happening. This is the time we have to raise and take some decisions to improve the healthcare in our society, and especially the burden falls on the IMA doctors and nursing home associations to take care of all such kind of things. Let us have the profession should excel. The financial discipline, this is very, very important. Control unnecessary expenses. Now I started to do this after a very long time. Control unnecessary expenses. Avoid over expansions. Freeze it. It is the end, and maintain cash reserves. Monitor every rupee what you earn every day. And cash flow is more important than profits. This is very, very important. You have to look at the cash flow than the profit. If you look at the profit, you will slow down. So maintain the cash flow at the same time. Save every penny earned. This is important. Earn the patient strategy. Spend time with patients. Clear communication. Honest advice. Avoid unnecessary procedures. When the indication is borderline, wait for a few days. Follow the protocols. Evidence-based medicine. Then, if it is not doing good, then convert into surgical indication. Trust is the biggest marketing nowadays. It's not the RMPs. Trust is the biggest marketing now. And navigating local ecosystem challenges, everybody faces this, but it should be very clear and calm. Just avoid non-professional, media influences or any social activists. Professionally, calmly avoid it, because you can, with that money, you can do more number of, free services, do service to poor patients who are in need. But it is very, very important. Don't spoil your institution. Protect the institution without spoiling their reputation. And this, everybody knows, the current challenges is Googling for patients. The cost sensitivity class patients they want low packages but better care. The previous exam is available in the market, which is not possible. And high patient expectations. Competition from corporates and retail patient trust is the most important thing, so that your pool of patients will retain very forever. Supply is more than demand. Supply is more than demand. Now, how to supply? My solution, our solution is build systems, follow the protocols, standard operating protocols, teamwork for an individual, and patient experience. When the patient gets experience, at least during the discharge, get a patient experience. Many fallacies are there, correct yourself, and next patient, don't see that patient, not repeated, and expand beyond local. It is really difficult. A super specialist doctor that neurosurgeon cases are very necessary, has to expand beyond medicine and look at other districts where it is really required. And we can target online international patients also. Nowadays, there is, medical inclusion is happening. Otherwise, we are not sure for it. If you have a good facility, you can do that. We tried it, but things are on the way, on the road. And there are people who are situated abroad, and their parents, their sisters, their cousins who are staying here, we can target them. This everybody knows better than me, but I'm trying to, see this slide. This is very, very important. Financial discipline is important. Know your numbers. Every day, every week, we have to sit at least an hour, so that we will know our number, our revenues, our expenses, the trade and profit and loss. We have to do personally also, so that the next month you will not have any problem. So earn carefully and spend wisely. Track everything and every day. So this is very, very important. When two leaders are there, two leaders can build faster growth. Acknowledge our successes. Most of them are couples of it. We have to acknowledge our success, public and privately. Avoid ego battles, which is very, very important in front of staff. And shape power. Don't compete for it. Don't compete for power in front of our staff and protect her personal space, support and control her, invest in marriage like invest in hospital, handle conflicts very maturely, and most importantly, when you are going home in the night, we delete all the messages and unlock your phone. She is not your wife, she is your greatest strength in silence. When you close your eyes, when you are in real struggles, when you are really in struggle, your wife silently comes as your support. So she's not only our wife, she is our silent strength. Respect her. And most importantly, if you want to excel in the future forever, this is part of our private practice. Excel in academics. Never stop learning, build strong critical foundation, follow standard protocols, SOPs, and make the academic environment and hospital documentation is absolutely necessary. Teach while you practice while you are looking at the patients. Medical practice is very, very important. And a hospital grows not by building number of beds, but by the knowledge, discipline, and integrity of the doctors who are running the hospital. This is very, very important. And always, global learning is very, very important. Just don't follow the future. We have to create the future. We have to adapt the new things in the world, and we adapt them. We first adapt those things in the world. And corporate social responsibilities. Everyone do this because the society is looking at us. So we have to give back to the society as we become fat. So do some service to the society and spend few amount which you are in the society so that your service will get recognized. And thank you so much. And my journey, what I both of us what we learned and realized, we started very small. Besides Dr. Lakshminarayan, I started attending at hospital. Rekomendation was not there. I used to sit in my clinic in 2004. And we started very small, focused on skill and patient trust. These are the most building blocks of our practice, and adapted to changing times. Always whenever they change, we have to change ourselves. And always consistency beats any competition in the world. We have to be very confident and competing with the rapid changes. And second, golden rule. Every one of our brings relaxation. We have a relaxation game in our Karimnagar without the number of hospitals, number of patients, number of amount of income, and number of patients in the bed. The golden rule is we should have a good friends and family circle. Thank you, the God has given us the best family and friends into our life. Thank all the neighbor doctors who always back us in struggle. And the conclusion is, for 20 years we have not been practicing medicine. We have been learning to survive the change. The change we have to accept. The future belongs to the doctors who combines the skills, the system, and compassion. And the final thing that I want to tell is how to balance these systems. In order to business, it has become a business. The modern healthcare business, how to balance. These are the 4 pillars. That is ethics. More important, ethics and service to the humanity. Growth is very, very important, and growth nowadays comes by building a brand and trusting the patients. And this is my final, word. Practice evidence-based medicine where science guides every decision. Do not use your assumptions that will save you from even medical implications. Thank you so much. Thank you all for this opportunity. Thank you very much. Thank you, INA President Apu Madam, Secretary ISF, and Ima Madam. Thank you so much once again. Thank you all.
Thank you very much, sir, for a wonderful talk. Truly practical talk and very useful to hospital owners and beginners. How to start the hospital and what are the difficulties we are facing. You elaborate yourself. Thank you very much. Now to proceed further. Moment of presentation to chairpersons and speaker.
Next we move on to the next session. Next session is bridging crisis to
పైన పెట్టుకోరు జరుగుతుంది నేను మిడిల్ ఉంది కానీ ఇలా పైన పెట్టుకో ఇక్కడ ఇక్కడ
May I invite Dr. Y. Narendra sir, Senior Researcher of Karimnagar, and ex-Master
బ్యాక్గ్రౌండ్ లైటింగ్ షాడో వస్తుంది
Amina sir, Class Secretary,
ఓకే సార్ ప్లీజ్
and Dr. Ramu, Deputy.
Thank you so much.
ఓకే రెడీ సార్ ప్లీజ్ సార్ షాడో వస్తుంది ఓకే రెడీ స్మార్ట్ సార్
Good evening to everyone. I myself is Dr. Kaushik. Consultant and medical surgeon in some staff of Hyderabad. And I would like to thank myself and Uncle Mom and Neil Mom for giving this opportunity. And today, the lesson is actually well related. So, theme of the well related this year is solid ethics and strong leaders. That means lifestyle disease or liver health. So if we are living a healthy lifestyle, we don't need any doctor to take care of us. Coming to my topic, it's about liver failure. There are two kinds: it's acute liver failure and chronic, acute and chronic liver failure. Why about this topic is they are more prevalent in India. They are more prevalent in India and their incidence has been steadily rising with carrying. India is one of the third largest living transplant program. So, coming to India, they have an incidence of 255 patients every year recurring transplants. And coming to acute and chronic liver failure, they are in the Southeast Asia as well. We are recovering more than 300 people per year recurring transplants. The main similarity for ALF and HLF patients, the definitive cure is liver transplantation, and the etiologies may be different for both ALF and HLF, but the management and the liver transplant indications are mostly similar in adults and children. The liver failure can be avoided either it is acute hepatitis, acute liver injury, and severe acute liver injury and acute liver failure. The course of the clinical spectrum starts from prodromal symptoms and it proceeds to the jaundice and it proceeds to coagulopathy and encephalopathy. It should be reversed before the encephalopathy becomes brain-free or brain growth. Otherwise, if we don't do transplant at the time, then we will proceed to multi-organ failure, which may lead to loss of the brain. There are three patterns for acute liver failure. The first is hyperactive, which is day-based. It's less than complex and most commonly it's seen in paroxysmal poisoning and hepatitis B and B. And acute liver failure is seen in hepatitis B patients, which span from 1 to 21 days. Subacute is with the daily percutaneous liver injury, which takes 21 days to 26 weeks. The additional risk of this is subacute liver failure. Acute and hyperactive liver failure is presented in correct time interval, we can solve it. So if acute liver failure comes to us, what they are going to do is, the first thing is to work out the etiology. What is the reason for the liver failure? The second is to rule out the area of disease which has caused the liver failure. And the third is whether the liver transplantation will be useful or it will be futile. And the other things we have to do is we have to support the liver and the other approach is liver protective measures. And to stratify the risk for early referral to a transplant center and to counsel the patient relatives for the need of liver transplantation. So, the first thing is to rule out the epidemics which are malaria, dengue fever, leptospirosis, scrub typhus, and the main causes were in India the viral hepatitis is the most common cause, mostly hepatitis B virus. The treatment for hepatitis B chemotherapy should be started as early as possible, and hepatitis C and E supportive is as per the pregnancy-related active category of pregnancy, the immediate delivery of fetus has to be done, and then if the patient still has liver failure, she might need liver transplantation. In children, Wilson's disease is most common with Coombs negative hemolysis with rapid anemia progression. The only treatment of choice for Wilson's disease is urgent transplant. The scopes of risk stratification actually came into effect to take a practical decision on what to do with the patient. The scopes should have the maximum sensitivity and the specificity. So the first time any patient comes, we do a key solid criteria, which includes doing an ABG. If the artery page is less than 1.3 and the lactate is more than 3, they are candidates for transplantation. So they should be able to a transplant center. Or they should have other criteria like hepatic encephalopathy and INR more than 6.5. In patients who are not due to plasma like hepatitis patients, the INR is more powerful. If it is more than 6.5, we should refer to the transplant center for transplantation. Or other 3 out of 5 criteria which are we are not able to determine the etiology, or the patient's jaundice to encephalopathy is more than 100 and INR more than 300. These are the patients who require transplant. And the King's Call criteria is a static score, but the dynamic score is also score, which predicts the need for transplantation. If the score is more than 4, the mortality rate is 67% without transplant, and if it is more than 5, it is 84%. The other dynamic score is SOFA score. It has 6 parameters, including the cardiovascular system, CNS, respiratory, coagulation, liver, and kidney. If the score is more than 10, patients should be referred for transplantation. And the main problem with the ALF patients is the blood from the water system keeps bypassing the liver, which leads to more ammonia. And this can be controlled by any of the methods like CRRT or plasma exchange. And lactulose and monotherapy is not proven actually. So the first thing is to control acidosis with CRRT and to control the ammonia level with plasma exchange. This has been a proven therapy in most of the studies with significant reduction in arterial ammonia with plasma exchange. And the main principle of plasma exchange is it reduces the damage associated proteins produced from the liver and the repulsion associated proteins from the gut microbiome, and reduces the cytokine storm, which leads to cerebral edema. It reduces the ICH and it reduces the kidney disease and it reduces cardiac myocarditis. The role of therapeutic plasma exchange is very well proven in most of the studies, with transplant-free survival of 38% and overall survival of 61% in 28 days of ALF. The criteria for referral to transplant center is clinically, if patient had any hepatic encephalopathy, better to shift, and if the rapid deepening of jaundice and increased cerebral edema with coagulability more than 2, acidosis, lactate of more than 3 and renal failure, and to see for the prognostic scores. If the MEL score is more than 30, Cliff score more than 10 and alpha score more than 4, better to shift the patient, and the referral at the very sign of HE has a very good prognosis. All patients we will not be able to do salvage with the liver transplantation. Some people who it is contraindicated to transplant are patients with severe mental impairment or active malignancy, who have psychological problems and who have more than 3 organ failures like heart failure and respiratory failure requiring more than 90%, forced inspiration of oxygen is ventilated, and dangerous to brain. So coming to 2022, the success rate of transplantation has kept on increasing. It started from 70% in 1990s and it has reached 98% in 2000. So the main technical aspect is to select the right donor, and the donor should be young in age and blood group match first degree related with DNA and with an X. And we can also do ATO incompatible liver transplantation if the relatives not fit for donation. And the only thing is it will be the chance of survival will be 80% rather than 95%. And this is interesting technique which we do for some of the patients who are suffering from FKDJ and parasmal poisoning. This is called auxiliary partial orthotopic liver transplant. In this process, we from the donor we take a partial liver and we keep the native liver of the patient also, and we keep the partial donated liver from the donor also. And once the native liver regenerates and gets blood from its insult, it starts to work, and we remove the immunosuppression to eventually kill the transplanted liver and the native liver stops functioning. Coming to the comparison of ALF and ACLF, the main thing is in ALF the liver would be normal, in ACLF the liver would be already damaged, and the hepatic pressure would be very less in ACLF, and the recovery chances are very low in ACLF compared to ALF. Comparison of ACLF in adults and children, the main thing between adults and children is the etiology. In adults, the most common cause of ACLF is acute alcoholic hepatitis, but in children, the most common cause is hepatitis virus. And in both of them, the mortality rate without transplantation is 50% within 28 days, and in pediatric, the native liver survival is good. The mortality is 20 to 40%. The ACLF usually comes with triggering factors. Patients who are already having chronic liver disease will get some trigger by the infections or any other triggers like large volume parasympathesis or spontaneous bacterial pericarditis, or patient having some drug-induced liver failure will land up in ACLF. The main pathophysiology is there is excessive systemic inflammation and blood disturbances which lead to cytokine storm, and this storm will never settle unless the liver which is producing the cytokine storm is removed from the body. So the latest variant is the Kyoto Consensus, which is a unified definition which has made the ACLF into two types, type A and type B. It is the severity of the disease. Type A is usually the damaged organs would be liver and the coagulation and the cerebral part. In type B, the other extrahepatic organs like renal, CVS and oral sleep disorder. Coming to the risk stratification of ACLF patients through ESL flip organ failure exposure. They are divided the organ failures into two types, organ dysfunction and organ failure. The grade 1 means it's only single organ failure, especially kidney, and grade 2 is 2 organ failures, 3 is 3 organ failures. So the parameter is if encephalopathy is there, immediate referral should be done, and if ACLF grade 2 and 3 are there, they need transplant. The window for transplant is 3 to 7 days. This is the ARC scoring which decides whether the patient needs transplant or not. If the score is more than 10, these patients have a 28-day mortality, more than 85% without transplant. So they need to undergo transplant as early as possible. Patients with score 8 to 10 can be managed conservatively, and they need to be watched out for 7 days for the development of encephalopathy and liver failure. This score usually involves normal bilirubin, INR, hepatic encephalopathy, lactate and creatinine level. This is an easy score to calculate. And the HE management in ACLF, this is the outcome of the patient. If the HE is severe with the Bell score of more than 30 and R score of more than 10 and R score of less than 10, what we can do is we can reduce the HE with less 15 days, then the chance of recovery is very less. So this is the golden window. The disease progresses from liver injury to systemic inflammatory response syndrome to sepsis and organ failure. So any decision of transplant should be made before the sepsis or organ failure takes over. The second window is after once the organ failure comes, the patient might again get better. They can get better from ACL of grade 3 to grade 2 also. That time the transplant can be considered, that is called second transplant. So the factors associated with adverse outcomes, which patients we usually avoid doing transplants, patients who are having respiratory failure, who have septic failure with the lactate levels more than 4, who have renal failure with increase in creatinine by more than 300%, who have infections, who have KID score of more than 64, and the clinical fragility score of more than 7, and patients who have hepatic encephalopathy grade 3, grade 4 with more than 72 hours ventilator support, and patients with IPDMD and malignancy with HCC. So this is the article in the Journal of Clinical and Experimental Hepatology. They showed that liver transplant when is the correct timing. The indication should be CHOP score is more than 10, and patients who are not suitable or patients with more than 4 organ failures and hepatic encephalopathy on prolonged ventilator, and the timing should be within 7 days. This is the dynamic algorithm. Who needs medical management and who needs transplant? Patients with odds score of 5 to 10 can be wait and watch with bridge therapy with plasmapheresis. Patients with more than 10 should be seriously considered for liver transplantation. And patients with organ failure more than 4, this is futile to transplant. They should be given palliative care. And this is the survival rate. In patients with single organ failure post-transplantation, they have 82% survival at 400 days, and ACL of 3, they also even have 83% survival. And when you compare the survival without transplant, it is only 7.9%. This is the second transplant window where the ACL of 3 patients got better and came into the window of ACL of 2 and transplanted. They are very. And this is the outcome studies of post-transplant and without transplant. Post-transplant, the patient had 92% survival, 5 years, and without transplant, they have only 1.9% at 1 year survival. This is outcomes in pediatric liver transplant for ACL. In pediatric liver transplant, chance of native liver survival is more. The NLS rate is more than 50% in most of the patients, and LT is secured in only 8 to 10%. Thank you for giving this opportunity. This is the new scoring schema with the, you can check with QR code and you can answer the questions to check your liver health.
Thank you so much for insightful presentation. Transplant meeting now before the voting meetings. It begins with the decision to donate. One organ donation camp is, our organ donation camp is open here on the back side. There is a register, you can register for organ donation. Once the one donor can say ready. So this is the caption. So everyone requested to register for organ donation. There is registration in the beyond the backside of our room. Please do register for donation. So thank you so much. Sir, any questions?
Very good lecture, very good and informative, Dr. Karthik. I wholeheartedly congratulate you. You have given a latest and very good innovative ideas, so we can follow these things. And hearty congratulations to you.
Thank you.
Small question. What are the chances of biliary structure in living and donor, living donor and
in deceased donor, the chances are 20%, sir. In living donor, it's 5%. Thank you. Sorry for the more internet talk. Previous talk was more practical.
Officer and Treasury, Department of Neurology, Children Institute.
Okay, ready, sir?
Sir Davis MBBS from Government Medical College, Miraj, MD Internal Medicine from Loconia Municipal Medical College, Sion, DM Neurology from Care Hospital and St. GSMC, Parel, Mumbai. Sir Davis Neurointervention Fellowship in Tamil Nadu Government Multi-Super Speciality Hospital, Chennai. Sir stood first in university exams in BM Neurology. Winner of Torrent Young Scholar Award and Best Orator Award at USA. I would like to request the chairpersons to come up to the dais, please. Dr. Mohammed Ali sir, sir is retired here at Ima Karimnagar, and brother sir is assistant professor of Gynecology, Karimnagar Medical College. Dr. Rathari Sridhar sir, consultant neurophysician at Jayashri Neurocenter, Karimnagar. Dr. Ranjit Kumar sir, professor in Department of Neurology, Karnataka Institute of Mental Sciences. Dr. V. Sai Prasad sir, consultant ENT surgeon at Sarojini ENT Hospital. Dr. L. Varsi, consultant psychiatrist at Suma Hospital, Srinagar.
Answer normally. Shukana, na? Ipada Elari na.
We will discuss a few cases, so it will be not a theoretical discussion. It will be clinical-based discussion.
Yeah, okay.
So I will go directly to the cases. So this is a 12-year-old female who presented with complaints of difficulty in swallowing with nasal regurgitation, duration of 2 days. After that, she developed difficulty in speaking with nasal cry. So with these two symptoms, patient went to ENT specialist who know what is the cause for that difficulty in swallowing and speaking with. So the ENT specialist, he found that patient also had imbalance while walking and swaying to either side. So this was a typical history with which patient was referred to me. So on examination, patient had vulvar involvement. Clinically, she had dysarthria, nasal speech, dyspepsia, uvula was not moving and gag was absent. So this indicates that there was 9th and 10th nerve palsy bilateral involvement. And our motor system examination was normal, but cerebellar signs were present. So this patient had ataxia, areflexia, and 9th and 10th cranial nerve palsy bilaterally. If that 9th and 10th cranial nerve palsy was not there, only ataxia, areflexia, so we can think of Miller-Fisher variant of GBS. As you all know, we studied in MBBS also. So, but in this case, there was no external ophthalmology. So, this patient had a cranial nerve palsy in the nerve of 9th and 10th bilateral involvement. So, with this, we did investigations like MRI brain with contrast, which was normal because we thought that patient might have post-infectious cerebritis as age was 12 years only. Then we did CSF analysis, which suggested cells were normal and normal glucose and proteins were raised. So, it indicates that there is an albuminopsychological dissociation. So, whenever patient is having ataxia, areflexia, with CSF of albuminopsychological dissociation, we can think of some variant of Guillain-Barré syndrome, GBS. So, we thought of a typical Miller-Fisher syndrome with 9th and 10th cranial nerve palsy. So, we started with IV methamphetamine, 30 mg per kg per day was given over 5 days, but at the end of 5 days, there was no clinical response. So, as a GBS initially, they may not improve with methylprednisolone. So, we have added them. Thought of a typical GBS variant, we said ganglioside antibody panel for this patient. And patient simultaneously was started on IVIG. So, no response to methylprednisolone, added on IVIG. But with IVIG, patient started improving on the day 3 of IVIG, then there was complete recovery within 5 days. So, this case was like Miller-Fisher syndrome, but some different variant from GBS. normal Miller-Fisher syndrome, we have ophthalmoplegia, but our patient has bilateral retinal keratoconus palsy and that antibody titer which we send. So this is a neuroimmunological thing. That we got anti-GQ1B antibody positive. So initially we used to read only theory books. Now we are doing practical antibody testing also, which will help us diagnose and treat the patient properly. So this is another case. Similarly, patient was a rapidly progressive weakness of both lower limbs since 2 days, and this patient had a normal potassium, which was reported out. I am telling one more story with the similar kind of patient presentation, whose potassium was normal outside, but his ECG was showing changes of hypokalemia. So even normal potassium, if patient comes with few report from outside, so don't believe that report. You repeat it several times because it is a treatable cause. The patient is on hypokalemia, quadriparalysis, with potassium supplementation, patient will have complete recovery. But in this patient, potassium was normal, but patient progressed to quadriparalysis within 36 hours only. So this was a very rapidly progressive quadriparalysis. So this upper limb power 2/5, lower limb 1/5. The typical thing was, or atypical thing was, areflexia was there. Then sensation system was normal, mental was normal. So at this time, we did NCS, which showed prolonged distal motor latency and reduced CMAP that indicates that patient is having a demyelinating disorder. CSF done, which was showing again no pheocytosis, elevated protein, that is algorithmic cytological dissociation, which is again characteristic of GBS. MRS 5 was done, which was normal. So now we thought, according to NCS and CSF findings, the patient might be suffering from common variant of GBS, that is motor axonal neuropathy. This is a very severe disease. So patient was started on IVIG, 2 rounds over a period of 5 days was given, but after 5 days also there was no response to IVIG as previous case. So what next? Patient had quadriparalysis, typical CSF was pheocytosis, no pheocytosis and rest proteins. NCS was showing like demyelinating neuropathy. So what next? So here we cannot stop. So what is the diagnosis? The diagnosis was not GBS. So the patient was suffering from nodopathy or paraneuropathy. So this is the autoimmune neuropathy or autoimmune peripheral neuropathy. So this here again our knowledge of neuroimmunology will help to diagnose the patient and treat it, because we thought of case to be GBS, we have given IVIG, but there was absolutely no response. We have said this nodopathy panel or paraneuropathy panel, that autoantibodies, because these are the red flags when if GBS patient is not responding to IVIG, you should think of this diagnosis. We did this nodopathy panel at which the anti-neuropathic 140, that is NF140 IgG came positive. So this was a very atypical case, not GBS but nodopathy. Because to diagnose a case as a nodopathy is important, because treatment part will be very important. Because in GBS, IVIG will the treatment authorization. But for the nodopathy, this patient won't respond to IVIG. So we have to give rituximab. For this patient, we have given rituximab. And after 2 doses, 2 weeks apart, patient was absolutely fine. All became almost 4+5. The patient started walking without support. So if you diagnose case properly, then only you can treat the patient properly. So this is another case which presented to ER with acute onset breathlessness. So any patient with acute onset breathlessness, we have to take the history that no risk of fever, cough, chest pain, visiting infection. Patient went to emergency department. Then they intubated in view of breathlessness because ABG was bad. But the important clinical history you should know: the acute onset of breathlessness, not having pulmonary or cardiac etiology. So what next? So I asked on the phone to the deputy doctor that any other clinical findings are there. So he told that there was bilateral doses. This is a very important history. If any patient of acute breathlessness is coming with bilateral doses, so there may be many differential diagnoses for this. Like maybe mycelic crisis, because bilateral doses, quadriparalysis with respiratory involvement, make botulism, make snake bite, because many snake bite we see was showing repeated conduction study, which was showing decremental response that indicates that patient was having a neuromuscular junction disorder. So patient was started initially renal penicillin, no response. Then by the time we were finishing the 5 days of renal penicillin, patient anti-muscle antibody came to be positive. So another case of neuroimmunology where we diagnosed will be important. So patient again started on IVIG. Over a period of 5 days, patient improved well, was off ventilator support, then gradual clinical improvement was seen. There was improvement in doses. After that, we have given rituximab to the patient, 2 doses, and then other biopsy and patient is also done. So the diagnosis is very important in this case also. Another short case, another neuroimmunological case, 45-year-old female presented with acute onset paralysis with bladder trouble. So again, this is the myopathy. Okay. There was no issue of visual impairment, no issue of neurotrauma similar to in the past. So immediately whenever there is a quadriplegia or paralysis, we go for spinal MRI. In this case, spinal MRI was showing longitudinally extensive transverse myelitis. Whenever there is a longitudinally extended transverse myelitis, we will think of neuromyelitis optica. So it was an NMO disorder. So as we see that anti-aquaporin 4 antibody was positive, then we have given methylprednisolone complete recovery. Then again she had a second episode after 6 months. In that she developed optic neuritis. So there are recurrent episodes were there. So we have started on steroid. Then that episode was also she was fine. After that we have given rituximab. The patient was on adathioprine. So all this immunosuppression was done. So after adathioprine of 2 years, patient went into complete remission. Then we started tapering of adathioprine. Then what we found after 6 months of stopping, patient developed butterfly rash on the face. So whenever patient is developing butterfly or malar rash, everyone will think of lupus, right? So we similarly thought of lupus because she was not developing lupus symptoms initially. Why? Because we have started already immunotherapy in that. The immunosuppression was done. Later on, that ANA was 2+, then DSDNA was 2+. So maybe she might be having this DSDNA positive initially also, but we diagnosed later on. So in this, why this is a typical case is patient presented with neuromyelitis optica. Initial correct diagnosis is SLE. So this is like neuromyelitis optica or longitudinal extensive transverse myelitis presenting feature of systemic lupus erythematosus. This is the last case. So this is very difficult out of to diagnose and treat. 75-year-old gentleman presented with diminution of vision in both eyes over a period of 48 hours. So complete vision loss. There was no PLPR in both the eyes. So very tough for patient and relative also. It was associated with retroorbital pain and headache. So anyone can think of bilateral vision loss with headache. Most likely he must be suffering from optic neuritis, bilateral optic neuritis. So just to know about what are the causes of painless and painful bilateral vision loss. So there are so many causes. Most important painful is bilateral optic neuritis. Then pituitary apoplexy also. For all of us, we should know these causes. Then acute angle-closure glaucoma. Then posterior irreversible encephalopathy syndrome or PRESS. We see many post-delivery. We see many cases of PRESS syndrome in which they may lose vision bilaterally in both eyes. Or stroke. Then painless. There are few causes for painless vision loss also. Then we went through this painful bilateral vision loss. All these, trying to pull out all these causes. So fundoscopy was done, which was showing bilateral optic swelling. So bilateral papillary was there. Then we went for MRI brain with orbit. So we found that patient had bilateral optic nerve enhancement, which showed that patient was having bilateral optic neuritis. Then MRI brain was normal, spine was normal. So we did CSF, in which proteins were raised, cells were normal. Then oligogonal band was negative, so it was not multiple sclerosis. In the serology, again neuroimmunological thing to help us to diagnose this case, serum MOG antibody, MOG IgG was strongly positive. So we diagnosed this case as a MOG associated disorder, which presented with minor optic neuritis. The interesting thing in this is that mob-associated disorder is very difficult to treat. Initially, they have given initially he was treated with methylprednisolone for 5 days, absolutely no response, no PLPR. After the patient came to us, we did plasmapheresis for 5 cycles. At the end of 5 days, also no improvement was there. Relatives were also not willing to lose the host. So again, what we did is after 5 cycles of plasmapheresis, again we have given a trial of IVIG, 2 grams per kg over a period of 5 days. Absolutely, there was no improvement in the patient. When patient was given rituximab on day 3 of IVIG, still there was no clinical response. This is a very rare mob-associated disorder which is related to myelopathic neuritis. After, despite giving IVIG, plasmapheresis, rituximab, absolutely there was no improvement in the region. So, neuroimmunology, there is a spectrum of diseases with which in few patients will be up to high dosage of methylprednisolone will be absolutely fine. But despite giving all options available for immunotherapy, still patient will not have a zero response. So very tough to treat or deal these kind of cases.
Thank you.
Thank you, sir. Very informative cases. Please connect the mementos on the right side of the stage. Chair.
So very elaborative and interesting presentation by Sanjay. Every one of us knows Sanjay and academics go side by side. Previously, just for any immunological disease, only suppressants are used to be given, but he has given very important insight into the exact etiology and management. Thank you, Sanjay. Thank you very much.
So next we move on to the next session. This is the last session. After that, we have a cultural program, Telangana programs. Okay. Next session will be narrow complex tachycardia. Tachycardia will be fast, but today's session will make us understand even more faster than sharper. It is my privilege to introduce our speaker, interventional cardiologist, FPDM, Dr. Kutsiram sir, working as a consultant in Reading Hospital. Sir is an expert who does not just read ECG, but delivers them with clinical perfection, who reads ECG like language, speaks it fluently in clinical language. Sir has vast experience in electrophysiology, intervention procedures, and acute cardiac care, making him perfect guide for today's topic. To change this session, may I invite Dr. Emmanuel Medicine, Senior IMA member, Dr. Ramkiran sir, Radiologist, Ayurveda Diagnostic, Dr. Vinod Kumar, Cardiologist from Sunshine Hospital, and Dr. Baba Anish from Vedar Hospital, and Dr. Vice.
One small announcement. The answers are waiting for the cultural program. We'll be shortly having a cultural program after this class.
Good evening to all the speakers. Thank you for providing me the opportunity to present this forum. So I'll be presenting today on an approach to myelocomplex tachycardia. So for definition, tachycardia absolutely the heart rate is more than 100 per minute, and LRT orders is at the root of the complex is less than 120 milliseconds. It's less than 120 milliseconds. So the origin in this myelocomplex, the origin has to be supranuclear. So some of the tachycardias we will today are sinus tachycardia, AVR, cooperative tachycardia, atrial fibrillation, atrial flutter, and multifocal atrial tachycardia.
So narrow closed circulars are divided into regular and irregular. The regular ones are sinus tachycardia, AVNRD, orthodontic AVRD, atrial tachycardia, atrial tachycardia. Irregular ones are atrial fibrillation, atrial flutter with variable conduction, atrial tachycardia with variable conduction, and multifocal atrial tachycardia. So in regular narrow closed tachycardia, we have to see the P-QRS ratio. If the P-QRS ratio is 1:1, then we can divide it into a short rapid tachycardia and then long rapid tachycardia. Short rapid tachycardia includes typical AVNRD, orthodontic AVRD, atrial tachycardia with prolonged period. And long rapid tachycardia includes atypical AVNRD, atrial tachycardia, sinus tachycardia, and PGRD. If the atrial component is more than the vertebral component, it can be atrial flutter with variable conduction or atrial tachycardia with two-stone or three-stone conduction. So what do you mean by short PR or long PR? Short PR means that the RP interval is less than 50% of RR interval. And long RP means the RP interval is longer than 50% of RR interval. So how do you calculate the RP interval? You measure from the onset of R wave to the onset of P wave. So combining all that, we have a devised algorithm for it. So first when we come across a narrow closed tachycardia, see whether it is regular or irregular, and then search for the P wave. When you identify the P wave, see the P-QRS ratio, whether it's 1:1 or 2:1 or 3:8. See if there is an isoelectric baseline between the P waves. If there is 1:1 relation, see whether it's a short rapid tachycardia or a long rapid tachycardia. If there is no 1:1 relation, measure the atrial rate and the ventricular rate separately. See the mode of initiation and termination. See if there is changes in cycle length, and see what's the response to cardiac sinus massage or admission. So the first tachycardia is the sinus tachycardia. So why do we say this is a sinus tachycardia? First of all, it's a narrow closed tachycardia. Then it is a regular interval. We can see the PA clearly. It is a non-rapid tachycardia with a P-QRS ratio of 1:1. And so then we have seen the morphology of the PA. It is positive in tooth area. It is negative in AVR and AVR, and it's biphasic in V1, and it's positive in V1. So that is the basic definition of a normal sinus PA. So what is a normal sinus PA? It is a dome shape with a smooth contour. It is positive in lead 2, 3 EF and lead 1. It is negative in AVR. It is biphasic in V1 and it is isoelectric or negative in AVR. So this is the definition of a normal sinus PA, right? And that's why that is a sinus tachycardia. Next is the concept of real PA. So what is the real PA? Within the real PA circuit, there are two pathways. A slow pathway, which conducts slowly but has a short refractive period. A fast pathway, which conducts rapidly but has a long refractive period. So what triggers this reactive tachycardia? It is an early ectopic impulse that gets brought to the fast pathway and conducts the slow pathway with an adequate delay, but it conducts retrogradely through the fast pathway. So this is the pictorial description of it. The first one is a normal conduction pattern. A is the slow pathway and B is the fast pathway. A normal impulse goes through the fast pathway and goes this way. The impulse also conducts the slow pathway, but it gets neutralized by the impulse which is coming from the fast pathway. The second diagram shows what happens when an ectopic occurs. An ectopic impulse will find the fast pathway which is refractory. It goes through the slow pathway and at the conjunction point, it turns retrogradely. And if it finds the fast pathway has recovered from the refractive period, it conducts retrogradely and hence a real PA is initiated. So the most common narrow tachycardia after sinus tachycardia is AVNRD. Here the reentering circuit is present as an AV node. The impulse, the ectopic impulse goes to the slow pathway, gets blocked in the fast pathway, and goes down and then conducts retrogradely through the fast pathway into the atrium. The most important thing in the AVNRD is atrium and ventricle gets contracted simultaneously. So this is the EGM of AVNRT, where the green channels are the atrial signals and the yellow channels are the ventricular signals. You can see that atrium and ventricle are almost on the same line. So they conduct simultaneously and you cannot see a P wave in the ECG. The P wave is basically submerged within the QRS. So this is an example of a AVNRT. So why do we say this is a AVNRT? We say it's AVNRT because it is a narrow QRS, regular tachycardia. And that's you can see a P wave there at the end of the QRS in B1 and at the end of 2 and AVF. So there is a P to QRS relation is 1:1. And it is a short rapid tachycardia. So it's a short RP tachycardia, and we calculate the RP interval, it is less than 70 milliseconds. It's around 50 to 60 milliseconds, and that's why it is AV90. And this is the sinus ECG observation, where you can see there is no hump at the end of the QRS in V1, or as in AVR, as well as in 2 and AVR. So we went ahead and updated the slow pathway in this question. So what is atypical AVNRT? In typical AVNRT, the retrograde pathway is a fast pathway. In atypical AVNRT, the retrograde pathway will be a slow pathway. So the RP interval will be a long RP interval. The next is the orthodromic reciprocating tachycardia. This is the macro-radial tachycardia, where the anterograde pathway is the AV node and the retrograde pathway is the left accessory pathway. So it's the same concept. Where an ectopic atrial impulse gets blocked in the fast pathway and goes to the slow pathway. Here the slow pathway is the AV node, fast pathway is the accessory pathway. In sinus rhythm, if the accessory pathway is manifest in the ECG, it's called as a WPW. So this is an example of an AVRT. So why is this AVRT? It's because first of all a narrow QRS. It's regular interval. And you can see a P wave at the end of the QRS. That is the starting of the ST segment. And it's a short RP tachycardia with a 1:1 P QRS relation. And the RP interval is around 7 to 8 milliseconds, just over the 70 milliseconds mark. So it is AVRP. Here we can see the green channels of the they get contracted after the ventricular contractions. So it's not a simultaneous contraction as atypical or typical AVNRT. It's more of a sequential contraction. So one of the concepts in orthodromic AVRT is Kugel's law. So during orthodromic AVRT, there is a Van law which is related to the accessory pathway. This will produce decrease the heart rate or increase the tachycardia cycle length. So this is an orthodromic AVRT where you can see initially it's narrow complex, and then it becomes broad complex, and then it becomes narrow complex again. If you see carefully, the heart rate during the broad complex, it's less by around 50 to 60 milliseconds compared to the narrow complex. So it actually shows the pathways on the left side. This is the concept of it. Here the impulse goes across the AV node through the left bundle and into the left side accessory pathway. So when a left bundle branch occurs, the impulse goes through the right bundle, goes across the ventricular system through the muscle and through the left ventricle and then enters into the accessory pathway. This slows down the tachycardia cycle and slows down the heart rate. So for this patient we went transeptally and we updated the left ventricular accessory pathway. Next is the atrial flutter. This is again a macro-radial tachycardia present entirely in the right atrium. The rate is around 250 to 350 beats per minute. The slow pathway is the KO tachyphylaxis. The fast pathway is the remainder of the right atrium. It is of two types, typical and atypical. Typical is more or less classified into clockwise and counterclockwise. The characteristic feature of flutters are the flutter waves, otherwise called as the sawtooth waves or picket fence waves. In counterclockwise flutter, the flutter waves are negative in the interior reach and positive in V1, whereas in clockwise flutter, the flutter waves are positive in the interior reach and negative in V1. The ventricular rate is rarely 1:1 and usually it is 2:1 or 3:1. Sometimes variable conditions overseen. This is an example of a
So why do we say this is cutter? This is because it's first of all a narrow complex. It's irregular, and when you see the P waves in lead 2 or lead 3, you can see the rate is around 280 to 300. It's the flutter rate. And between the two P waves, there is no isometric baseline. This is the characteristic feature of atrial flutter. So this is atrial flutter with variable conduction. So this is the electrogram of atrial flutter, where the impulse starts at electrode number 20 and goes to number 1. So the circle catheter is the catheter which is present in the right atrium. The tip is the electrode number 1, and the base electrode is the electrode number 20. So actually the impulse starts at number 20 and it goes along the right atrium 3 volt, and then it goes to the tip, which is the electrode number 1. So you can say it's a counterclockwise typical atrial flutter. After ablation, the patient regains the sinus. This is the atrial tachycardia. So tachycardia rate is around 150 to 250 beats per minute. It's again a long after tachycardia. The most characteristic feature of atrial tachycardia is the change in the period morphology compared to the sinus period. Usually it is 1:1 conducts 1:1, sometimes 2:1 or 3:1 conduction conditions. These are parts of where the tachycardia can originate. So the morphology of the P wave depends on the site of the origin. So the general consensus is, if the P wave originates from the left atrium, it is positive or negative positive in lead V1. If it originates from the right atrium, it is negative or positive negative in V1. If it's from the top of the atrium, it comes from the P wave positive in the leads, and if it's coming from the base of the lower part of the atrium, it's usually negative in the leads. And the isometric or negative P wave in lead 1 is 100% specific for LA focus. So this is an example of an atrial tachycardia. You see, the first complex is a normal sinus P wave. And after getting 2 or 3 atrial ectopics, the tachycardia has reinitiated. So if you can see the lead number 3, it's positive, P wave is positive, but if you see it has become negative, or sometimes even negative positive. So that is a specific characteristic feature of atrial tachycardia, where the morphology has changed from positive to a negative P wave. We updated the vascular area position. Next is atrial fibrillation. Atrial fibrillation is characterized by fibrillative waves and the lack of clearly defined P waves. It's an undulating baseline that can change between an recognizable atrial activity and a rarely flatline. Atrial fibrillative activity is best seen in V1 and the inferior leads. The heart rate, the atrial fibrillative rate is around 350 to 600 beats per minute. It's classified into fine AF as well as coarse AF. The amplitude in fine AF is less than 0.5 millimeters and in coarse AF more than 0.5 millimeters. Fine AF is supposed to be seen in long-chain AF, and coarse AF is seen in the recent onset AF. And the atrial ventricular response is due to a phenomenon called as functional conduction. So this is an example of atrial fibrillation. So you can see it's a narrow QRS complex. It is irregular, and there is no clear-cut P wave, but there is an undulating baseline in all the leads. This is a characteristic feature of an atrial fibrillation. So how do you calculate the heart rate related to fibrillation? Count the number of QRS, 30 large boxes, or 50 large boxes, and multiply by 10 oxygens respectively. And the phenomenon seen in atrial fibrillation is the Ashwin phenomenon. For long RR interval is followed by a short RR interval, the atrial impulse will be conducted with the broad complex. That's because it's usually a right bundle branch slope, because the right bundle branch refractive rate is much longer than the left. So for this patient, we did a pulmonary isolation on both the isolation of the left superior and the inferior pulmonary veins. This is isolation of the right superior and inferior pulmonary veins. Afterwards, we return to sinus. Last is the multifocal atrial tachycardia. So it's basically an atrial complexes originating from multiple foci atria. So P waves are irregular with varying size and shapes. The diagnosis of MAC is based on the presence of 3 or more consecutive P waves or different morphologies and isolated baseline P waves. The rate of more than 100 per minute. This mechanism is mainly because of an increase of chemistry and is commonly seen in patients with COPD or lung disease. Thank you.
Mahesh, please come on to the desk. Dr. Mahesh, he is a one hospital managing director. Dr. Mahesh is an anesthetist. He did a lot of work in paracolic poisoning. He went to Delhi and met several authorities to ban the paraquat. So, IMA leaders, please stay back here. Just felicitate with Dr. Mahesh. Please sit down. Our IMA leaders, Ramkiran sir, MLA Devi sir, Alim sir, if you are here, please come on to the stage. Rashid, Charter Sridhar, please come on. In his arguing because he was all alone. Dr. Mahesh, character was dangerous.
Thank you so much, ma'am. Actually, paraquat ఇది బ్యాన్ చేద్దామని చెప్పేసి దీని గురించి ఫైట్ చేసినప్పుడు ఐఎంఏ వాజ్ ద ఫస్ట్ అంటే మెయిన్ కీస్టోన్ జరిగింది మనకు ఇండియన్ మెడికల్ అసోసియేషన్ తోటి. ఎందుకంటే దానికంటే ముందు ఊళ్ళల్లో ఎన్ని క్యాంప్స్ పెట్టినా ఎంతమంది రిప్రజెంటేషన్ ఇచ్చినా ఎప్పుడైతే మన స్టేట్ ఐఎంఏ కిషన్ సార్ ముందుకు వచ్చి మన కరీంనగర్ ఐఎంఏ నుంచి కూడా చాలా మంది ముందుకు వచ్చి రౌండ్ టేబుల్ కాన్ఫరెన్స్ జరిగింది. ఆ రౌండ్ టేబుల్ కాన్ఫరెన్స్ వల్ల ఆ రోజు అందరు ఎంపీస్ నేషన్ ఇది అంతా కవర్ అయ్యేసరికి దట్ వాజ్ ఎ వెరీ హ్యూజ్ స్టెప్ ఇన్ దట్. సో ఐఎంఏ స్పెషల్లీ వెరీ థ్యాంక్ యూ మ్యామ్. అది యాక్చువల్గా నేషనల్ లెవెల్ కూడా ప్రయత్నం చేద్దామని చెప్పేసి కిషన్ సార్ అన్నారు. సో అది చేస్తే ఇంకా చాలా బాగుంటుంది. సో మీ అందరికీ ధన్యవాదాలు చేస్తారని చెప్పేసి థ్యాంక్ యూ.
థ్యాంక్ యూ. ఇప్పుడు తెలంగాణ డాన్సెస్ ఉన్నాయి. ఉన్న కొద్దిమంది ఉండండి, ఈ డాన్స్ని చూసి ఆనందించి వెళ్ళండి. థ్యాంక్ యూ. ఇప్పుడు చైర్పర్సన్ చేసిన వాళ్ళకి కింద మొమెంటో ఇవ్వబడదు. థ్యాంక్ యూ.
I just want to only introduce cardiologist Dr. Tulsiram. I think he's the first cardiologist in Northern Telangana who is doing electrophysiological laser ablations, and for him we are imagining a new state of machine that is both for periphery as well as cardiac sequence machine, and he does all ablations, and anybody requires his help, he can take it, and he is operating both between significant cardiac center and the hospital. Thank you so much. Thank you so much, sir, for accepting our request all the way from Chennai, and he will be here for next 2 days with us, and hope he will settle here. Thank you.
Dance to please. Okay.
staying so long on a Sunday. We would like to honor, appreciate the work done by the postgraduates and leaders from Pratima Medical College who helped us to manage the stage from morning to evening. So we would like to appreciate them. I would like to, it would be a great appreciation for them. I would like to call them up to the dais. Dr. Joshua, Psychiatry BG. They came at 8 o'clock and they are still here, and we are very much relaxed because of them. Thank you, Dr. Joshua. Dr. Mahati, Psychiatry PG, Dr. Pooja, Dr. Adarsh, General Surgery PG, Dr. Maidi, Dr. Shravana, Dr. Jyoti, Dr. Purvi, the interns, Dr. N. Shivaprasad, Dr. N. Kavya, Dr. Devasinu, Dr. Purasar. Keep up the good work. It will be a great learning experience for you.
Sir,
I would also take this opportunity to extend my thank you to Dr. Sai sir, Dr. Sailaja, Dr. Geeta Ravi, Dr. Shravanti, Dr. Swapna. Without you, we could not handle these orations and scientific stages so smoothly.
Okay, other girls, madam, please. Sir, and extend. Put it there. Okay, ready? Sir, other girl, madam, please. I'm the smiley, madam, please smile. Smile. Madam, ready? Okay. Sir, ready? I'll put hand with the meditation. Okay. Hand down there, Anjab, sir. Is it okay, na? Okay. Madam, please Okay, ready? Smile with another please. Sorry, turn the other side. I don't like next one. Yeah. Yeah, ready? Smile. Madam, you can do that, madam. Ready? Okay. కొంచెం సార్ సైడ్ కూడా అది వీడియో లైవ్ ఉంటుంది కొంచెం నవ్వుతూ ఏం రాలి
Thank you, children, who really helped us. All the PDs and houses. Feedback is to be there now for that. Very good evening,
all the doctors, our seniors, our professors, present over here. Thank you so much for making us part of this. We PTs of first year from level 7. Thanks to Vikram for making us part of this event and making this event very successful. Thanks to all the delegates here. Very thankful to inviting us. Thank you.
Everyone present here. I would like to especially thank for everyone here present here for giving us an opportunity to come here and learn a lot of new things, get exposed to a great number of great doctors, which I would never have seen otherwise. So I would like to thank them. I'm very grateful for this opportunity. I'd like to be a part of it everywhere it is possible. Thank you much. Thank you.
I think it was wonderful, CMD madam. Actually, orations ante just ala కూర్చొని ఎవరు డెలిగేట్స్ వస్తారా ఎంతమంది కాల్ చేయాలని పొద్దు నుంచి వెయిట్ చేసేదానికి వాళ్ళే పరిగెత్తుకుంటూ వచ్చేలాగా చేశారు. యాక్చువల్లీ మనం టీచర్ అందరికీ తెలుసు నాగేశ్వరరావు లెజెండ్, ఇక్కడ మనం టీంలో ఆకాశాలతో లెజెండరీ. I think it was wonderful, coordinating, networking, chief guest handle చేయడం అందరికి ఎవరికి అంటే సాటిస్ఫై అయ్యడానికి is not easy. I think it shows the pure team effort. That is very good. Thank you. And thank you for giving me an opportunity. I look up to the market. Sponsored the bags, really we are thankful to her. This is a small token of respect from Ima Karimnagar. And what is your feedback, please?
Okay. Madam, please.
To be part of this great event and the Orations Cme. To be honest, I didn't expect such great event and arrangements was really good. I realized it after coming here. It was such a great event and hosted by great leaders, and the talks event were very inspiring to us. And I thank ma'am and all the delegates here and thank you for giving me.
I would like to call Dr. Ravikant, Dr. Jadhav, Dr. Sripati Naidu to come up to the dais. We have them to support them.
Senior doctors, please come onto the stage. We have a photo. Doctors is also please come. And we have administrator.
Thank you one and all. It's a celebration time. Congratulations to Manan, Ravi Kiran sir. Ram Kiran sir.
మీకు కంగ్రాచులేషన్ చెప్పాలి
స్టేట్ అయ్యమ్మే కదా.
కొంచెం ఇంకా సైడ్ ఉండాలి సార్, అంత సైడ్ కూడా బాగుంటుంది, లైన్ వేద్దాం.
మరి నేను ట్రైపడికి
మేడం ఓకే ఓకే స్మైల్ అందరూ. మేడం నవ్వుతూ పుట్టియండి వస్తుంది అర్థం.
Dr. Malik, Dr. Shivan, Dr. Varshi, Dr. Ravi, Dr. Rajkumar Rani, Rajkumar Health Station Machpaya Marma. Rajkumar, PSLC member, Rajkumar Health Station, Isha Events Coordinator, Dr. Rajkumar, please sit down. We want to felicitate you. Thank you for your kind cooperation. Dr. Rajkumar, the one and only hero, he got elected Telangana Council member. At this age, he got elected as PSLC member. Dr. Priya, where is Priya? Krishna Priya. Rajkumar, wonderful person, he helped us a lot. Because of Rajkumar, we will do this so successfully. Isha Events, event manager, PSLC member, anesthetist, RK Diagnostics. Take the Oscar award.
Okay, sir, please, sir. Allah, after you, sir. Sir, go ahead, sir.
would also like to thank Bunty for saving for audio visual team of Bunty. Bunty, stand up.
Smile now, sir.
because Ratnakar sir, presenting a
Thank you.